Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more. everyone, it's Alex from the PCRI, and welcome to day 2 of the 2022 Moyad Scholz Mid-Year Update. We have an amazing lineup today, including Dr. Amar Kishan, who is a recognized leader in radiation oncology, Dr. Nicholas Vogelzang, who's a clinical oncologist from Comprehensive Cancer Center, and of course, our resident doctors, our executive director, Dr. Mark Scholz, and our beloved moderator, Dr. Mark Moyad. You can go ahead and visit pcri.org/2022-MYU to see the agenda and our exhibit hall. Also, while you're there, sign up for the giveaway. Subscribe to our YouTube channel and submit your name in a giveaway section of our website to enter to win a $50 Amazon gift card. Also, remember you can donate to PCRI on our website, pcri.org/donate. Your support has helped make this whole event and all of our resources free for anyone who needs it. Also, I'd like to thank our sponsors, Bayer, Pfizer, Astellas, Janssen, AbbVie, Advanced Accelerator Applications, Dendreon, and Tolmar, who have helped also to make this event possible and enabled us to make it free for all of you. All right, let's get into it. First up, we have Dr. Amar Kishan. He is the Associate Professor and Chief of Genitourinary Oncology Service, Department of Radiation Oncology for UCLA, and he will present on SBRT and its side effects. All of that will be followed by a Q&A session with Dr. Mark Moyad. Dr. Kishan, thank you so much for coming to the 2022 Moyad Scholz Mid-Year Update. We're so excited to have you. Here we go.
Hey, welcome to the Moyad Scholz 8th annual conference. Emphasis on Moyad, less emphasis on Scholz, as you know, because I tell people I'm an egomaniac that needs more emotional support than probably any doctor in America. So this is an exciting one I have for you. I'm going to give you this. This is I want to give you the background story before this doc starts his presentations. So we had a lot of radiation oncologists on our radar, especially my radar. And as we started getting closer to the conference, we would get calls from people that said, he's really, really good. I'm really, really happy with the staff. He explains things really well. It was almost as if he was paying these people to tell me these things. It was so effusive. I was. Yeah. So I said, this is ridiculous because he's checking all the boxes for PCRI. I think he's world-renowned. I think he's prolific. But he's also got good bedside manner. The patients really like him. They're very happy with not just the outcomes, but how he explains things. Then I went to watch some of his videos and I immediately called and I said, Alex and I said, we have to get this guy, make him feel guilty on every possible level and get him in here. So we did that. So Dr. Amar Kishan from UCLA, who's an assistant professor. I think you also run GU oncology there within the department, right? Is that correct?
I'm fortunate enough to have that responsibility. Yes.
Yeah, you poor man. And he's been there for some time. And I don't spend too much time on the bio. I can just tell you that in the area of SBRT and what we're going to talk about right now, he's at the top of the game, and he's the kind of person you want to hear from. So first of all, I want to say welcome. It's a real honor to have you in our space. Thank you for showing up.
Well, you're very welcome. And I want to say that the honor is mine. You know, I've heard so much from all my patients about you and Dr. Scholz in this conference. Everyone has seen your videos. Everyone talks about Dr. Moyad. And so it's an honor for me to be here.
That's really sweet. I appreciate that. I think most of your patients were saying extremely nice things about me and then possibly some nice things about Scholz. Don't you think? It was more than that. So I'm just kidding, Mark. I want to share with you something funny before this is a true story. And when I'm old now, but when I applied to med school, all right, I just thought I'm going to apply to 7,000 schools and I don't care if they want me or not. I'm just going to hammer it out. And I went and I applied to Harvard, and Harvard said, we have this new program that if you get in, you can also apply to this MIT program. And I thought, oh, that's perfect for me. I got the smarts. I'm going to go into Harvard and then I'm going to do MIT. And Dr. Kishan, I'm embellishing a little, I'm exaggerating, but it was almost as if it was like this. I put my application, because those days you put your application in the mailbox, and it's as if when I put my application in the mailbox, someone was already tapping me on the shoulder and going, what are you thinking? And because I found out later what the scores you needed to get into the Harvard MIT program. And I thought nobody gets in that program. This is for some kind of robotic freak show who's got these incredible scores. So you got into this program. You're part of the reason I never got in. So can you tell me what it was like? Do you remember that day when you got in? That's like, I'm trying to give people an analogy. That's like getting picked to go to the All-Star game in the NBA.
I mean, I'm not gonna lie, I was very excited to get the phone call to be accepted to that program, and it was great. I loved my time in Boston, and it's a world-class place. I was fortunate, lucky to get in, and I have to say though, as a California guy, I don't regret coming back to California and settling in Los Angeles. Yeah.
But this is a very select group. Do you even know what an A- is? Did you ever even know what a B+ was? I'm serious, because you're the kind of guy we stayed away from in school. You're what we call the curve buster. You know, we would never take classes with. If I saw Dr. Kishan in my med school class, or if I saw my college class, I'm like, I'm not taking that. This guy's he's gonna kill the curve. So seriously, did you ever get a B?
I did not.
That's awesome.
I'm probably the kind of person you didn't want to hang out with, essentially.
No,
right?
that's not true. I would have hung out, because I would have actually asked you for answers to my take-home homework. Then you're the kind of guy that you're probably so nice you would have done my homework for me. But that's an incredible story that sets up for, just really quickly before I let you start your presentation on radiation and prostate cancer, mostly SBRT. So the MIT in Boston, Harvard. So when you went into the MIT combined program, were you already thinking radiation oncology? Like what was the aha moment that you're going to do radiation oncology?
Yeah, it was actually, I went to medical school wanting to do oncology, but I didn't actually know much about radiation oncology. And what happened was I explored the different types of oncologies, medical oncology, pediatric oncology, and radiation oncology. And I loved the radiation oncology clinic. As fate would have it, I sat out a famous radiation oncologist that works in prostate cancer, Paul Nguyen, at the Brigham Women's Hospital. And I loved this clinic. The patients were very happy. Many of them were cured. And I thought, I would love to do this. I'd love to offer something that could cure people. At the other end of the spectrum, sometimes patients have metastatic cancer that can't be cured, but you might be able to help them. You might be able to relieve pain and help suffering. And so I thought that was super cool, and the ability to do research and innovate things. And so I was instantly drawn once I was exposed to the specialty to radiation oncology. But actually, I didn't go to medical school thinking about it.
Wow. And then what was the aha moment before you start that you were going to go? Because there's a lot of glamorous life in other places of radiation oncology, breast cancer, other places. Was there an aha moment that would take you into prostate? Thank goodness you did.
Well, yeah, I mean, as a resident, you rotate and see different types of cancers like breast cancer, prostate cancer, brain cancer. And I just found myself drawn to the prostate cancer patients. Again, I thought it was great to be able to offer something curative to these patients and be able to go over different options, talk about, it's great when you can talk about long-term side effects in a patient. That means you can cure them and do well. And I just saw a tremendous opportunity also to improve our care. So that was very attractive to me.
That's awesome. Do you have any hobbies, by the way? I went through, this is your whole bio. I went through it. There's a million things about you can all read it, but I didn't see the things I thought I would see. Like, for example, loves surfing, has 8 dogs, all the stuff that you think you're going to see from a California doc.
Yeah, I mean, I love to go hiking. It's a great place. I have 2 daughters that keep me busy. And then I also like to pretend that I can sing and do some karaoke, which I'm not going to repeat here.
Okay, you just set us up for the next time we interview you. Alex, by the way, if you're out there, we got him on a karaoke thing. All right, so if you are stuck on a deserted island and you can only watch the Clippers or the Lakers, which one?
It's got to be the Lakers.
Okay. How about the Rams or Chargers?
I'll be a fair weather fan and say the Rams.
That's a good answer. All right. Last but not least, before I let you start, favorite restaurant in Los Angeles. If I'm in Los Angeles, I got to go somewhere to eat. Where am I eating? According to Dr. Kishan, where is the place to be?
That's a lot of pressure there. I would say I'll take a different tack on that and say probably a good guilty food place that you might not endorse for many patients would be Blue Star Donuts. in Abbott Kinney. Very,
Wow.
very good. If you can spoil people with that. Very, very good donuts there.
Blue Star Donuts, huh? Okay, I wrote that one down. Thank you. No, I appreciate your candidness. You're supposed to have fun in life. You just can't follow the rules all the time. It's ridiculous. So Blue Star Donuts is going to be at the top of our list. All right. So now, again, I want to thank you again for being here. And I want to let you do your presentation first, and then we're just going to have a little banter afterward, and then we'll call it a day. So we're going to let him do his presentation first. Let's take it away. Dr. Kishan is going to tell us about radiation treatment for prostate cancer and where we are today.
Okay, so I'll be going over some basics of radiation therapy for prostate cancer, specifically going over SBRT, and also I'll talk about some side effects from prostate cancer radiation. Here are my disclosures for your reference. So a question that I get from almost all my patients is, how does radiation kill cancer? It's intuitive how surgery would treat prostate cancer. Obviously, you're removing the gland, but how does radiation do that? So it turns out that cancer cells are defined by an ability to divide uncontrollably. That's a hallmark of cancer. And what radiation does is it causes significant DNA damage to cellular DNA, and cancer cells are unable to repair that. And what happens when a cancer cell tries to divide with damaged DNA is it dies off, and then the body can clear away the dead cell. So that's how radiation kills cancer. It's effective at killing cancer. It's not just a temporizing or palliative treatment. We're actually trying to cure patients when we use radiation. That's why it's a standard of care option for all forms of prostate cancer. Now, there are two fundamentally different types of prostate cancer radiation treatments. One is external beam radiotherapy, or EBRT, and the other is brachytherapy, or implanted radiation. And I'm going to be focusing on EBRT and specifically a form called SBRT in the remainder of this talk. And so some general principles of EBRT, just to catch everyone up to speed. In EBRT, we are using high energy X-rays that are directed towards the prostate with a linear accelerator. Patients are not radioactive. There's no heating or burning, and it's completely non-invasive. And what you see on the left there are just some images of some linear accelerators we have at UCLA. One is the Meridian device, and another is a Novalis TX device. These are just examples of linear accelerators. Now, there are different types of EBRT that patients may have heard or read about. So EBRT can be delivered in a form of multiple daily doses over a certain time period. And what we've learned over the years is that prostate cancer is actually more susceptible and sensitive to a higher dose per day. And as our technology has evolved, we've been able to do this safely. So briefly, the types of radiation here are conventional fractionation. That's a dose per day of 1.8 to 2 gray, a total of 39 to 45 treatments. Typically, that's 8 to 9 weeks of daily treatment. Moderate hypofractionation is 2.5 to 3 gray per day, 20 to 28 treatments, or 4 to 5.5 weeks. And then SBRT, which will be the bulk of this presentation, 7.25 to 8 gray per day, with 5 total treatments, typically over 1.5 weeks, or treatment every other day. As an aside, people often read about IMRT, and they ask, well, is SBRT IMRT? Am I getting IMRT? So what's IMRT? IMRT is intensity modulated radiotherapy. It refers to the use of advanced radiation technologies to deliver external radiation with high precision. It's a planning and delivery technique. Typically, different beams with different orientations are delivered with varying fluence, or photon flux per unit area, in a way that sculpts the high dose radiation around the target. And so IMRT oftentimes is used interchangeably with conventional fractionation or standard radiation, the long 8 to 9 week course of radiation. But actually, IMRT is used for the other forms of radiation as well. It's just a general principle. So what's SBRT? SBRT is stereotactic body radiotherapy. Another form or acronym for that is SABR, stereotactic ablative radiotherapy. This is a form of radiation treatment where high doses of radiation are given over a period of about 5 treatments or so using advanced imaging and delivery techniques. Many different platforms exist for delivering SBRT, and these are sometimes referred to by their brand name. CyberKnife, Novalis TX, TrueBeam, Meridian. These are just types of SBRT delivery devices. When a patient says, oh, I heard about CyberKnife, my friend got CyberKnife for prostate cancer, that's a type of SBRT device. What's the evidence for SBRT? Well, as of 2022, SBRT is now considered a standard of care option for prostate cancer in the United States. It's supported by multiple high-level studies, and I'll go over 4 of them in some detail. I don't want to dwell on the specifics so much, but just so we're aware of the level of evidence that exists to support SBRT. The first is the hypo-RT-PC trial. This is a randomized trial out of Sweden. And just to make sure everyone's on the same page here, what a randomized trial is something that's required to show that something becomes a standard of care. It's called level one evidence. What this means is a patient comes into the clinic and they're given an option to enroll on a trial where they're randomized. Basically, a coin is flipped and they either get one type of treatment or the other. There's no bias involved in what treatment is decided. And when we take bias out of the equation, we're able to prove whether something is as effective, whether it has the same side effects, whether it's better, whether it's worse, depending on the way the trial is designed. So the hypo-RT-PC trial was a randomized trial designed to show that SBRT type radiation would be equally effective as the longer form of radiation. Now, this is a relatively older trial, so they didn't use modern SBRT. They actually used a high dose per day, but it was called ultra hypofractionation rather than SBRT. What did this trial show? So as you can see on the right there, that's what we call a failure-free survival curve. It tells us what percentage of patients are alive without disease at a given time point. You can see that extends out to 10 years after treatment. And what we see is the red curve and the blue curve there are superimposable. There's no difference. Failure-free survival was equivalent between this type of high-dose radiation per day and conventional radiation, which was the 8 to 9 week course. It showed no difference in long-term side effects either. So what does this mean? It provides high-level evidence that treatments using a high dose per day have similar efficacy and long-term side effects as treatments using a low dose per day. Now, the PACE-B trial is the second study I'll mention. It's out of the United Kingdom. It was also a randomized trial. Here, they used modern SBRT. It's a newer trial. And they compared this against that moderate course of radiation as well as the long course of radiation grouped together. And what we see are the early results there that were published in 2019. And you're seeing on the top there are the bowel side effects graphed kind of as a percentage of patients experiencing them out to 20 weeks or 5 months after the radiation. And then the bottom graph is for bladder effects. And again, the blue and the red curves are superimposable. That kind of the circles that you see there are grade 1 side effects, which means minor disturbances. The lower kind of the square and the triangle are more severe side effects. Thankfully, they're rare. And we'll get to the side effects later in the talk. But the main point here is that those curves are superimposable. So the short-term side effects of modern SBRT and either that 4-week course of radiation or the longer course of radiation are equivalent, and patient-reported outcomes are equivalent as well. And I'll show a slide with patient-reported outcomes later in the talk. So again, providing high-level evidence that SBRT with modern treatment techniques is equivalent in terms of side effects, at least in the short term, through 5 months, as other forms of radiotherapy. The third study is a UCLA-led general consortium study. Here, we pool the data from numerous non-randomized trials, but still trials, run in North America to kind of look at the safety and efficacy of SBRT in a large group of patients, 2,142 patients. We had a median follow-up of 7 years. And what we see there on the right is a biochemical recurrence rate graphed over time. And that's the chance of the cancer coming back in the sense of a PSA rising. It's not survival, it's not death. You know, the survival, thankfully, is extremely high, close to 99%. This is the recurrence rate. And what we can see at 7 years for low-risk prostate cancer, about 4.5%, for favorable intermediate risk, about 8.6%, and for unfavorable intermediate risk, 14.9%. These are all without hormone therapy. What does this mean here? We're talking about long-term follow-up, again, 7 years on average, suggesting modern SBRT is safe and effective. Now, we also looked at side effects. Specifically, we looked at severe side effects because that's oftentimes the main concern. And on the left there is grade 3 or greater GU, genitourinary or urinary side effects. And on the right, grade 3 or greater GI or bowel side effects, gastrointestinal side effects. And what I've done is I've plotted the percentage of patients on different trials of different types of treatments, like the long course of radiation, the intermediate moderate course of radiation, brachytherapy on top of radiation, and looked at the proportion of patients that experienced these significant side effects versus the present study, which is at the bottom there, which was for SBRT. What we see is that the 7-year rate of severe GU or urinary toxicity is only 2.4%, with SBRT. And the median time of onset, the average time of onset is about 27 months. So most patients experiencing that type of a side effect relatively early, within 2 years or around 2 years. Grade 3 or greater GI toxicity at 7 years was 0.4%. Again, the median time of onset here, about 31 months, 2.5 years or so. Most patients are experiencing side effects within 3 years for either the bowel or urinary side effects. And the main takeaway is that when you look at that present study, again, a rate at the bottom, it doesn't appear different from any of the other types of radiation, possibly even better than the other types of radiation. It certainly isn't way out to the right, meaning, one of the major concerns early on with SBRT was, is there going to be an issue with this higher dose per day? Doesn't appear to be the case, potentially even otherwise, that there are less side effects, although that hasn't specifically been shown. And then the last study I'll talk about right at the outset here is a UCLA-led SHARP consortium study. This is looking at high-risk prostate cancer. Most of the earlier studies looked at low and intermediate risk prostate cancer and not so much high-risk prostate cancer, although high-risk prostate cancer patients were enrolled on that very first study that showed. And the UCLA-led consortium here pooled data for 7 phase 2 trials of SBRT for high-risk prostate cancer from across the world, together 344 men overall with on average 4 years of follow-up. And again, the curve here is biochemical recurrence-free survival or failure-free survival over time. And you can see that the cure rate at 4 years is 82% overall. And when patients are getting hormone therapy, which they should for high-risk prostate cancer, it goes even higher to 87%. And I would argue as we get new technologies like PSMA PET scan to better stage patients at the outset, we get newer drugs, we get maybe better radiation technologies, that number is only going to get higher. So this is really telling us that SBRT is effective for high-risk prostate cancer. Now, let's talk a little bit about the logistics of SBRT. How is SBRT delivered? And here we got to go back to some basics of external radiation as well. The prostate is actually a moving target. That schematic on the right shows the prostate situated beneath the bladder. The urethra is a tube that runs through the center of the bladder, through the center of the prostate and out, carries urine through to the penis. The rectum is behind the prostate. As the bladder fills up and empties, as the rectum fills up and empties, the prostate actually moves back and forth, up and down, and even left to right. And because of that motion and other inherent uncertainties and considerations with external radiation, we always have to treat not just the prostate that we see, but a margin around the actual clinical target to make sure that we're dosing the prostate accurately. We don't want to miss. The paramount goal is to cure patients. So we treat a margin around the prostate. Now, historically, we've used CT or X-ray guided SBRT with fiducial markers. In this type of a scenario, 3 metal markers called fiducials, they're about the size of a grain of rice, are placed into the prostate in a minor outpatient procedure. They can be tracked with an X-ray or CT scan. That allows us to align to the prostate. So typically we get a CT scan prior to treatment to evaluate anatomy, and then the X-rays are used to align to the prostate since we can see those metal markers. These X-ray images can be repeated during the treatment to make shifts as needed, or we can do the treatment very quickly to minimize the motion effect, like in the span of 3 minutes or so. Now, an MRI can actually show the prostate much better than a CT scan can. That's why men that are getting staged and evaluated for prostate cancer get an MRI scan for evaluation. But the thing is, historically, we've not been able to combine an MRI scanner with a linear accelerator that delivers radiation. That's been an engineering and physics challenge. That's only recently been surpassed with the use of MRI-guided linear accelerators. In an MRI-guided SBR treatment, you can actually see the prostate directly using an onboard MRI. Moreover, when you're using a system such as the Meridian Linac, which we have at UCLA, MRIs can be obtained 4 to 8 times per second to actually track the prostate. You can put this margin around the prostate that can actually allow the beam to automatically turn off if the prostate goes outside that margin. And that allows us to actually shrink that margin that we usually need to a smaller amount, actually 50% as much as we use with the CT-guided SBRT. I'm going to try to show this video here. What you can see is this was a patient that was treated on our device, and the red there outlined is actually the prostate. And what you're seeing is the motion that occurs. See how it's pushed outside of where we think it is, as kind of a gas bubble passes through the rectum. That this is happening in real time as patients are being treated. We're just able to see it now with this real-time MRI. What happens is if it goes outside that yellow boundary, the machine automatically turns off. And so that allows us to be more precise and ideally limit side effects. And actually, this is something that we studied in a randomized trial that was very recently conducted called the Mirage trial at UCLA. We actually did a one-to-one randomization. Men that were coming to our clinic, we didn't just treat them on that newer machine. We actually said, well, unfortunately, we want to try to show this is better. So we're going to randomize and flip a coin and treat some patients 50% on the MRI machine and 50% using what we've been doing since 2010 with CT-guided SBRT. And the final results of that trial are not available, but we did present the interim analysis after 100 patients were treated earlier this year at a conference. So I can share those. And you can see the curve or the bar charts on the right there. The percentage of patients experiencing moderate side effects, either GU or urinary or bowel GI side effects, is significantly reduced in patients receiving MRI-guided radiation. And we think that's really because we're able to shrink the margins needed because of the enhanced technology. That's our hypothesis. And so this has changed my approach because although we are still awaiting the final results of this trial, I'm now routinely offering the MRI-guided treatment to patients. And I think we can talk maybe in the question and answer session a little bit afterwards about who's a good candidate and what are the other considerations that go into that in terms of patient experience. And another question that comes up in terms of logistics is, what is SpaceOAR? Lots of patients have heard about this, read about this. They've read about this gel that can protect the rectum. So SpaceOAR is an absorbable hydrogel that can be placed between the rectum and the prostate in an outpatient procedure to physically separate the prostate and the rectum. And the schematic at the top there, you can see before, there's the prostate, the rectum behind it, and outlined in pink there, or shaded in pink, is the high dose region. That's that margin I was talking about. You can't treat just the prostate, you have to treat an area around it. And part of that high dose radiation margin is going to go into the rectum. So the SpaceOAR idea is that you put this gel, it moves and kind of separates physically the prostate and the rectum, and therefore that high dose envelope kind of is going to be in the gel, or at least move significantly away from the rectum. There'll still be dose of radiation going to the rectum, the lower doses that are crossing it, but it does, spare part of the rectum from the high dose radiation. So, what's the evidence for this? It was studied in a randomized trial that was funded by the manufacturer of this gel, Augmenix, that used, or Boston Scientific now, that used conventional radiation. And it was associated with lower grade 2 or greater rectal toxicity. You can see the curves at the bottom. And control means patients that didn't have the SpaceOAR, and the spacer is referring to the SpaceOAR product, the brand name. And you can see a separation of those curves. The proportion of patients or probability of patients experiencing a moderate bowel toxicity is lower significantly in patients getting placement of the spacer. Now, those are low numbers overall, and with added technology, hopefully those numbers get even lower and lower. But the basis of the approval of SpaceOAR by the FDA and coverage by Medicare and many insurances were the results of this randomized trial. Now, who's a good candidate for SpaceOAR? Well, patients with clear evidence of prostate cancer extending outside the capsule of the prostate in the posterior direction are probably not a good candidate for this, because we don't want to displace the cancer. Additionally, it is a procedure to put it in, and so sometimes there can be bleeding infection risk with that. So it's worth a discussion with your radiation oncologist, but oftentimes they can provide some advantages. Now let's talk a little bit about radiation side effects as we move into the second part of this talk. So side effects from radiation can be divided into acute, or kind of within 90 days of radiation, and then late, beyond the 90 days after radiation has completed. Typically, we're concerned about urinary, bowel, and sexual side effects of radiation. Fatigue is another general acute side effect of radiation as well. In terms of acute urinary effects, we refer to something called urinary bother. And what is that? I think it's best answered by looking at this questionnaire called the International Prostate Symptom Score. I actually give this to patients before they come to see me for consult and for follow-up as well. And it kind of defines what the elements of urinary bother are. You can see incomplete emptying, frequency, intermittency, which is pausing during the flow of urine and then starting again. Urgency, how difficult it is to postpone urination, weak stream, straining, and then nocturia, or getting up at night. And so acute urinary bother is essentially this constellation of symptoms. And you can imagine a patient that comes in with zeros across the board. Let's say these increased by 1 to 2 points across the board in the context of radiation in the short term. We're talking about some urinary bother, but perhaps manageable with medications. Whereas if someone comes in with a 5 across the board, it's going to be pretty difficult if that gets worse because they already have significant symptoms. Now, typically, the most common things are obstructive symptoms like weaker stream, straining, and those are treated with non-steroidal anti-inflammatory drugs or NSAIDs, like ibuprofen or Advil. You can also use urinary medications like tamsulosin, a brand name Flomax. Urinary urgency and frequency can also occur. And sometimes we treat that with something like oxybutynin or other drugs in that class. Incontinence, or the ability to control the flow of, the leakage of urine, that's extremely rare. You can see that's not part of this questionnaire because that's extremely rare with radiation, particularly in the short term. What about bowel effects related to the rectal? And we call that bowel bother also. And this can be really characterized by another questionnaire we give to patients called the EPIC questionnaire. And I've took out a kind of snapshot of the bowel questions there: urgency to have a bowel movement, increased frequency of bowel movements, losing control, bloody stools, and kind of rectal pain. So that constellation of symptoms could define bowel bother. I would say, with the exception of losing control of your stools, which is extremely rare, particularly with modern radiation, to experience anything like that in the short term would be very rare, but the others can certainly happen. Typically, it's less frequent than urinary bother, and it tends to be dominated more by the first two things, their urgency and increased frequency. These diarrhea-like symptoms can be treated with over-the-counter medications like loperamide or Imodium. Rarely is a prescription strength medication needed. And if there is any kind of bloody stools, like an exacerbation of hemorrhoid or pain, something that might be called proctitis, steroid suppositories can be used and can be very helpful. And what I'm showing you here is kind of the time course of these acute side effects. I mentioned I would show this in the context of the PACE-B trial. These are the short-term side effects going through 3 months, 12 weeks. And we can, tackle them stepwise. At the top is urinary incontinence, which I mentioned is very rare. So you can see if we score that as 0 at the baseline, there's a very minor drop. It's not even statistically significant at the 1 month mark, and then it returns clearly to normal by 12 weeks. Same with urinary obstructive symptoms. You can see a dip there. It's more pronounced because those are much more common for patients to experience, but it's resolved largely at 12 weeks or 3 months after the radiation. And then overall urinary bother, a combination of these two, dips again at 4 weeks and then is resolved at 12 weeks. Bowel bother, also kind of dipping at the 4-week mark and largely returning to normal at 12 weeks. And you can see the magnitude of that drop is less than the magnitude of the urinary bother drop. Sexual side effects we'll talk about. Typically, we're not seeing too many short-term sexual side effects unless patients are going on hormone therapy, although sometimes patients don't feel like engaging in intercourse. They might be more tired. There could be a little bit of pain with ejaculation, and the volume of ejaculate could go down. But essentially, the big picture here is we're looking at short-term side effects that do occur. They tend to peak at the 1 month mark after the radiation is completed and largely are resolved at the 12-week or 3 month mark after the radiation is completed. What about late side effects? Arguably, this is of more importance to people, right? They understand there'll be some short-term side effects, but really, I don't want to deal with late effects. And we can quantify these. You might recall I gave some rates for severe side effects from our UCLA General Consortium study. It was about 2 to 3% for significant urinary effects. We call the cystitis or urethritis. This could be things like pain with urination, very frequent urgency that's not really responding to medications, a very, very weak stream, potentially blood in the urine. These require more intervention, not just the medication, but perhaps a urologist has to look into the bladder, maybe treat something that's there, or maybe we need to use something like hyperbaric oxygen therapy. For bowel effects, actually the rate was about 0.4%, but just being conservative, let's say that's 1% of patients getting a significant severe bowel effect we call proctitis. That could be urgency, typically bleeding, That would be a more common thing. And that might need to be treated with a gastroenterologist actually going into the rectum and perhaps treating or cauterizing something that's burning something that's bleeding, I should say. And again, hyperbaric oxygen treatment could work. And now these are rare, but they do happen. So let's say we treat 200 patients per year. Just to put some numbers on that, that means 4 to 6 patients may ultimately develop this type of a significant urinary effect, that's 2 to 3%, or 2 patients may develop a significant proctitis, 1%. So they happen. They are rare, but obviously they're things that we want to minimize. And then the other thing that patients ask about, rightfully so, is what about the fact that the radiation causes a cancer? Radiation is obviously something that's scary. We don't want to do it to people that don't need it, because yes, there is a very small chance that the DNA damage caused by the radiation might itself incite a cancer. And we're all aware of that from reading things in the news too. So the chance of that is very, very low, and the risk-benefit balance favors using the radiation in someone that has an active cancer, but it is a possibility and is something that just should be going to the consideration when deciding on the type of treatment. But again, it's extremely rare. And so now let's talk about sexual side effects. Oftentimes that's the number one concern for men, particularly younger men that are getting treated for prostate cancer. The acute sexual side effects I mentioned already are pretty rare. Men on hormone therapy will experience these, but otherwise fairly rare. But there could be a decrease in desire, decrease in interest in intercourse. There is a lower volume of ejaculate when the prostate is treated. But the major long-term side effect is erectile dysfunction. That's also age-related, but it happens in maybe 23% of patients at the 2-year mark after SBRT. And it tends to be a vascular or blood flow-related issue. And you can see some images here pointing out the relevant structures. The neurovascular bundle on the left, that's a constellation of nerves and blood vessels that's running towards the back of the prostate on either side. You'll be familiar with that in the context of people talking about a nerve-sparing procedure. And then the internal pudendal arteries are kind of these blood vessels that drape down in the pelvis and kind of hover close to the prostate. Both of these things are contributing to the development of erections. Obviously, nerves separate, but then these blood flow is contributing. And most of what we think causes radiation-related erectile dysfunction is thought to be from accelerated aging or narrowing of these blood vessels. In that context, medications like sildenafil or Viagra or tadalafil or Cialis will be effective in the vast majority of these patients because they open up and optimize blood flow, but it is a consideration. And although the data are mixed, there are some studies that suggest that maybe using a low daily dose of sildenafil or tadalafil may help maintain blood flow and could be a good prophylactic measure to maintain erections. Typically, these can be taken 6 to 12 months during and after the radiation really to have the biggest bang for their buck. And so highlighting those side effects, what's down the pike in terms of kind of improving this profile, reducing side effects? That's something we all want to do. And so I would say one is tighter planning margins, like radiating a lower volume of tissue will lead to less side effects. We saw that with the Moyad's MRI guided radiation trial. Real-time adaptive radiotherapy is a really exciting next frontier in radiation. What that means is patient comes to the table to prepare for radiation. We take a scan. The bladder is a slightly different size or maybe in a slightly different position. The rectum, slightly different size and different position. We actually replan the radiation right there on the table. That's an exciting frontier, and it kind of intuitively makes sense that would allow us to spare side effects as well. And then the final thing is something called radiogenomics, which some may be familiar from watching some other lectures on the PCRI channel. But I'll go into that in a little bit of detail. So radiogenomics is the concept that individual patients may respond differently to radiation, the same way that individual patients may respond differently to different types of medication. That's called pharmacogenomics and is really intuitive to us, right? Different people have different side effects. Well, that should apply to radiation too. And radiogenomics is the area of study looking into that. How does this apply to prostate cancer? So our hypothesis is that maybe when we're delivering these higher doses per day, certain men may react worse to that. And conversely, maybe when you're delivering the lower dose per day, but to a higher total dose, some men react worse to that. And we actually studied this. We looked at DNA from men receiving the long course of radiation and the short course of radiation, SBRT, here and in a hospital in Norway where we have a collaborator. And what we found is a signature that seemed to predict for risk of moderate urinary toxicity in the late timeframe after SBRT. And what you're seeing on the right there is a probability of toxicity curve. In blue are patients predicted to be at low risk of toxicity, though that would be the patients that we don't anticipate would be at very high risk of having a moderate or more severe urinary side effect if we did the SBRT. And indeed, their probability of toxicity, if you follow out that curve, is less than 5%, more than 3 years after the radiation. On the other hand, patients predicted to have a high risk of toxicity in the yellow-orange there, they experience side effects earlier and more frequently. So there, by 3 years, 50% of patients are experiencing these side effects. How could this be used? Well, if we have a patient thinking about SBRT, maybe we check their DNA first and we see, are they at high risk or low risk? And that really could play a role into making a decision for this patient. And we're actually trying to study this. A question is this validated? You just looked at this in a small sample of men treated here in Norway. Yeah, we're trying to validate it. We have an ongoing phase 2 trial at UCLA called the Garuda trial that was opened over a year ago. And that's really designed to validate this test. What we're doing is getting this cheek swab, which can be used to check DNA beforehand, and then trying to counsel patients at high risk, maybe consider another form of treatment, whereas patients at low risk, would be safe to go ahead with SBRT. So that's also an exciting future area. And so I'm going to wrap up there. We'll transition into some question and answers. But first, I'd like to thank my patients, first and foremost, for enriching my daily life. It's a true honor to take care of patients. And also, the ideas I get from research are from working with patients. I can see what are the problems that we need to solve, and that's what motivates me to work to solve those problems. I'd like to thank the PCRI for all the work they do for patients, for their kind invitation to speak here today. I'd like to thank my team at UCLA. Dr. Michael Steinberg is the chair of our department. Dr. Min-Chang Kao is the lead physicist that I work with. And I'd like to thank the entire SBRT team there. I'd like to thank some groups that have funded some of my research, the American Society of Radiation Oncology, the Prostate Cancer Foundation, and the Department of Defense. And thank you very much for your attention.
That was outstanding. And I'll tell you one thing that comes to mind about separate from your talk, and then I want to talk about your talk and questions, is that I went to the Blue Star Donuts website.
Yeah.
Oh man, I mean, these things are unreal. No wonder you go there. I mean, I think this is the kind of place that when you buy a donut, you get a treadmill for free.
Right? You should get a treadmill for free. But yeah, no, they're incredible. They're really, really good. Really good.
Once you said that, and when I was asking the question, I had to look at it and I thought, well, how great can they be? We're in the Midwest. We got the best donuts. We put on the most weight here when we eat a donut. And I'm thinking, wow, I've never seen these combination of flavors. It's like, wow, I can see how someone eats these and then they need to go to rehab at some point. All right, thanks, man. I really appreciate all of that. That's excellent. I want to repeat to the audience. Part of the reason we're doing this is we just got so many favorable notes from patients that said that they just love this guy and he has been so great. And you can see from that presentation, he walks us through it. This is a very difficult topic. So I thought what we would do today is, at a snail's pace, walk through SBRT. And even if we got to repeat, even if my questions repeat some of the concepts, let's stay with it, because I want to make sure that when people are done with this, they kind of have a really good idea of what they're going to get when they see you. All right. So the first thing I want to ask you, though, about is, let's face it, or maybe SBRT is kind of the golden child of cancer right now. I mean, it gets a ton of attention. And you're just going to clear this up for me, because I get this question 1,000 times, and I got it in your presentation, but I want you to repeat it. In the Midwest and throughout the East, there are billboards that say CyberKnife. It's the same thing, right? Can you please explain this? This is making me crazy. Is this Pepsi and Coca-Cola? They're just both colas?
Yes, that's a perfect analogy. The way I like to explain it to my patients is like, it's a brand name. CyberKnife is a brand name. It's a type of machine. So think about it like the technology is a smartphone, but you have an Android and you have an iPhone, right? But they're both smartphones. So CyberKnife is a type of machine that can deliver SBRT, but when the general concept is SBRT.
Okay, so it is an SBRT. Thank you. That just makes me wacky. All right, before we get talking about SBRT and prostate, I think people think this is kind of new and this is hip and this is awesome, but the reality is SBRT has been around for a while in other areas of cancer. Can you just briefly, to your knowledge, explain where SBRT is used, even if it's just another place in cancer? I mean, I heard of CyberKnife in brain tumors. But can you tell us where the appeal is outside of prostate?
Yeah, so the appeal with SBRT is the ability to deliver previously unheard of doses of radiation with high precision. I mean, obviously, one thing we worry about when we're delivering radiation is the side effects, but you need to get a decent dose to kill a cancer as well. And so SBRT was actually first developed. It was called something else, stereotactic radiosurgery, in the context of brain cancers, brain tumors or metastases of the brain. And actually a neurosurgeon, Lars Lascelles, helped develop that. And that was the gamma knife, the first kind of SRS device. Yeah. And now people have cited it in other things. And you brought up a great point. SBRT has been around for a long time. Even for prostate cancer, few people realized that the first patient treated with SBRT in the United States was treated in the year 2000. So, and we're talking about 22 years ago. So it's not like a brand new treatment. It's been around. I mean, it's getting better and better, but the concept has been around for a long time.
Yeah. So, I mean, people think this is hot and this is great, but it's had a very firm place in oncology for some time. Okay. And then I want you just as a standalone, because patients are going to hear this word. We're not moving in quite yet into prostate only, but can you just, in your mind, you hear this word hypofractionation, and these radiation oncologists throw out this word, hypofractionation. Well, my parents forced me to take Latin for 5 years. And I can tell you that hypo means lower or less than. So I don't understand. Can you explain what hypofractionation means in terms of your business?
Of course. So a fraction is a treatment, a daily treatment. A daily dose of radiation is a fraction, one treatment session. And traditionally, we've delivered low doses per day over a long number of treatments, multiple fractions. So hypofractionation simply means delivering a higher dose per fraction over a shorter number of fractions. So that's what hypofractionation means.
Oh, that's awesome. See, no one's ever explained that, because if you actually know the Latin or the Greek roots, I translated initially when I first heard this name. I thought you're getting less radiation. I understand it now, but I think the reason it confuses people. So that's a great way of putting it. A single fractionation is a treatment, like a cycle, right? Mm-hmm. And so if you get 30 fractionations, that you could get that in some prostate cancer situations. So just because you get less fractionations doesn't mean you're getting less radiation overall compared to the 20 times you might get radiation, right? Does that make sense?
Correct. I think that makes sense. And an important other concept there is the kind of what's a biologically effective or equivalent dose. The whole idea is you're giving a higher dose per day. So even though you actually are nominally giving a lower physical dose of radiation in total, for example, in your example, 3 times 20 is 60 is actually less than, say, 2 times 39, 78. Those are it's less radiation when you are giving fewer treatments, but you're giving a higher dose per day. So the body is feeling the higher dose per day as well. And that plays into the equivalence.
Aha. So just a couple of years ago, and people are still getting 25, 30 treatments, IMRT treatments. So when you get those 5, it comes cumulatively, you're just getting a lot more in the short period of time, but cumulatively you're getting close to the amount you would get if you stretch this out over a long period of time. Is that what you're saying?
Essentially, yes. I mean, as far as the prostate cancer is concerned, yes, it's the biologically equivalent dose of radiation as we have seen in all these studies. But actually the nominal dose of radiation, like the actual dose delivered, is less. Because 8 times 5 in this case is 40, is actually almost half the literal dose of 78 gray, which was that old 8-week course of radiation. So the dose received by the body is actually less, but it's given in kind of higher doses per day, which leads to at least an equivalent outcome.
So if I'm gonna sock you in the arm a little bit harder over a couple of days versus kind of tap you over 20 to 30, you're just as effective in giving me a bruise or a bigger bruise, right? I mean, it's that kind of energy. I sorry to be so pugilistic, but I'm just trying to put this in basic terms in my head. Okay, so that helps, and we're going to leave that. Now we're just going to go into what I hear from patients at UCLA and other places, and I want to walk through this at a snail's pace, because if someone tries to go too quickly through this, it's going to make my head spin, because these are the most confusing talks in all of prostate cancer, I think, for patients. So many people come back from seeing you and other people, and they say, and you mentioned this, they say, he gave me a cheek swab. And then from his cheek swab, he told me I don't qualify or I do qualify. Okay, you mentioned this radiogenomics, what is the deal? This is someone just comes in your office, they get this little DNA swab, it takes seconds, and then within, I don't know, walk me through it. It takes you 2 days to go, yeah, no, he looks like he's going to have too many sides. Is it that simple?
In a way, it's that simple. I mean, it is preliminary. I mean, it's something we're investigating, right? And we're hoping to prove and change the way that radiation is done. But basically, a cheek swab allows us to look at someone's DNA, and it's really someone's DNA, their inherent inborn DNA. The technical term is germline DNA, that might determine how sensitive they are to radiation. So we do take a cheek swab in clinic. Actually, it can be mailed to patients as well. And we do prepay the postage to mail it back. And then we send it to a lab, and it takes actually about 3 weeks, on average to get the result back. So it's not quite as instantaneous, but it would tell us, are you someone that's predicted to have greater than 50% chance of this moderate to severe urinary toxicity, specifically after SBRT, or are you in the group of patients that was like 5% rate of toxicity at 3 years? And so it is a useful tool, I think, and something we haven't been able to do before. And our goal is we can reduce the side effects for everyone this way. The people that are good candidates are going to be good candidates. The people that are bad candidates should maybe get another type of treatment.
Yeah. So if I'm coming to see you, is everybody getting a cheek swab, or this is a select group? I mean, is anyone considering SBRT going to get a cheek swab?
Yes. Unless they refuse, yes, they will be getting a cheek swab.
Okay. And you still feel good about this, because the reality is, and you have to admit it, that if I go to a lot of other places in the country, I ain't getting no cheek swab. Right.
Yeah.
I mean, some places, you're the places that I know that consistently believes in it. And you still feel comfortable that this is going to be the future, that everybody is going to move toward cheek swabs one day to predict toxicity. Do you feel that way?
I do feel that way. I mean, I believe the data. Of course, some could say I'm drinking the Kool-Aid there because we're the ones that generated the data. But yeah, and I should give a lot of credit to Dr. Joanne Wiedas, who runs our kind of basic science, kind of translational science division in our Department of Radiation Oncology, who really came up with a lot of these concepts and does the assays in her laboratory. But yeah, I believe it, having looked at the data, and it intuitively makes sense, right? Why wouldn't different people be differentially sensitive to radiation? I mean, that kind of makes sense when I explain it to patients, and it's easy to agree to say, okay, and then there's nothing to risk here, so it's a cheek swab.
Well, the reason I take it more seriously now is because I remember a year or two when people were getting cheek swabs, and I would talk to other people in meetings, and they go, some people would say, yeah, they're getting cheek swabs, they believe in that. Those same people I found in the past year or 6 months have been going, that's getting interesting, that cheek swab data. They've kind of almost, their tones changed a little bit, which is why I think it's become fascinating. It must be a little bit more entrenched. But
yeah, I think, we had our publication come out looking at this, and we're well enrolled in our trial now. So yeah, I think there's more data just coming out, and not just prostate, in other forms of radiation as well.
Well, so what's the catch here? If I get a cheek swab, is this really expensive and you're going to take the money and expend it on Blue Star Donuts? Or is this going to be covered?
I know, and Blue Star Donuts was not on my disclosure list, by the way, so they haven't paid me anything. They should be, actually. Given your audience, they should be. Yeah, but no, there's no cost. This cheek swab is there's no cost to patients. There's no cost to anything. This is paid for by a grant that I received, as well as Dr. Wiedas's grants.
That's really cool. I love the idea, because part of my argument with PCRI, not arguing with PCRI, is we argue that there's always talk of treatment, but really we're moving into a phase of life where the prevention and side effects of treatment need to become a super specialty, right? So I think it's a cool approach. The question, though, is, let's say I go to your office and you give me a cheek swab and you go, hey, Moyad, sorry, man, you're not an SBRT candidate. I go, look, I drank the Kool-Aid. I love SBRT. I want it anyway. What do you do with that? You have had people so far like that. Can you explain
Yeah, no, that's a great question. It does come up. I mean, for some people, when you're presented that risk, 50%, some people, they're just in whatever situation it is in their life that they'll accept that risk, right? They're more, they want to know that going in, but they'll actually, faced with that choice, still accept the SBRT. So there have been some patients who were high risk that insisted on receiving SBRT. For example, sometimes people that live very far away, they can't make a longer trip of radiation. It wouldn't work out for them, or whatever the case may be. I think the important thing is that they're informed and they know that their personal risk of side effects is not the low risk that we generally are quoting to patients, but actually a significantly higher risk.
Okay. I'm going to get in trouble here, and I apologize. I'm going to put you in a terrible, terrible position. And that is, I'm now thinking of the patient who is in Saudi Arabia, Iran, Boston, Montreal. I don't care where they are in terms of the fact, but we are united in the fact that they're all getting SBRT, or they're thinking about SBRT, and the doctor says, I'll give it to you. I talked to a guy recently who was on the East Coast. He wanted SBRT. He got it. Good for him. He did not get a cheek swab. But now he's going to watch this tape and think, this doc makes a lot of sense. I want a cheek swab, even though he's not going to treat me. What do you do then? What do you do with the guy on the East Coast who wants the cheek swab, but wants to stay on the East Coast? I've never heard that question asked to you. What do you do? I mean, do you send him a pat? This is a dilemma, because it's going to happen after this, I think.
Sure. And yeah, actually that does happen sometimes. And what we try to do is see if we can get them the cheek swab. So at this point, we are still offering that on a case by case basis. But generally, there's been no one that's asked for it that we haven't run the assay on. There's still some things that patients may need to sign, right? Because we were obtaining their DNA, running some assays on it, right? But we have done that.
That is really interesting, because as SBRT is becoming so prime time, and this cheek swab thing is still holding its place, and I'm talking to these guys who aren't getting it, and then they're going to watch this, they're going to think, how can I get it, whether he treats me or not? So I appreciate that answer. That is really interesting. That's why I'm glad we took our time with that. Okay, so now you're taking DNA from the cheek. And then I think to myself, well, there's a place where you take DNA from the cheek all the time, whether it's in women's or men's health, and that's to look at BRCA status. That's to look to see if you have a germline mutation. Do you guys look at more in that cheek swab than the stuff that you're supposed to look at for side effects, or sometimes you combine it with germline mutation analysis?
Yeah, that's a great question. And since we're specifically, getting permission and consent to look just at this signature, while in theory, you're correct, because we're extracting the DNA, we could look at that information. We're not doing that without someone's permission to do so. Right. Yeah. So it's a different test. What we're looking at is a different specific panel.
So you do that for people. You do those panels, right? You do those panels probably all the time, and people have that kind of risk. But as these kind of mutations play a bigger and bigger role, it's going to be interesting how much you're going to be offering that. So I had this prediction at a meeting the other day. I said, I have these wacky predictions, and sometimes they come true. It's like a flip of the coin. I said, everybody 5 years from now, where they're getting SBRT or whatever they're going to get a cheek swab for germline mutational analysis. Do you think I've lost my mind on that one, or is it possible we move that direction?
I think it's possible we move that direction. That's the whole idea behind this. We're getting, the ability to understand these interactions between radiation and kind of the patient's DNA. So, that might apply to other things too, like immunotherapy, chemotherapy, other things.
Right. Okay. I asked you all the cheek swab questions I could ever think of in my lifetime. Now I want to talk about something else that comes up constantly, whether they see you or somebody else. And you mentioned this, the the dreaded FM word, the fiducial marker, right? So they come in. Can you explain this again? So they come in and you place on average. I want you to be able to tell me on average, first of all, why are you placing these? How many are you placing? And I'll repeat it. Why? How many are you replacing? And then you're caught up in this whole world in urology of the controversies between transperineal placement and transrectal placement. And I saw you mention it in your previous talk that I watched. It's so good at UCLA that patients can watch right now. So can you just walk me through, why am I getting this? How many am I getting? And which way are you giving me these things?
Sure. So the reason we put any type of marker at all goes back to the fact that the prostate is a moving target. So even over the span of a couple of minutes, the prostate is moving back and forth. And we've measured this. It may be moving back and forth even up to 3 millimeters, front, back, up, down, left to right. And 3 millimeters is obviously a pretty small distance, but at the same time, we're talking millimeter accuracy with our treatment. So we need to account for that. We don't want to miss. And so we need a way to kind of line up to the prostate. Now, the prostate is very well seen on an MRI. It's not so well seen on an X-ray or CT scan. And historically, we've only had these X-ray or CT scan based treatments. What shows up on an X-ray or CT scan? Metal. It will show up on any X-ray or CT. So a fiducial marker is a metal marker that we place into the prostate. We usually put 3 in. They're typically an inert metal like platinum or gold. Sometimes people call them the gold seeds. They are not radioactive. So this is not brachytherapy. This is not implanted radiation. These are inert metal markers. How do we put them in? Through the perineum. And so you mentioned this controversy between perineum and rectal, and just to catch everyone up to speed, if you put in something through the rectum, which is how most biopsies are done, you do run the risk of infection, right? Because the rectum obviously can cause infection, spread of material. And so we go through the perineum, which has far less infection risk. And actually you can numb up the perineum fairly well with topical anesthetics, local anesthetics. So that's how this procedure is done. I will say that, with some of our newer machines, like that MRI guided machine, we've started to move away from needing the fiducial markers, because in that case, you do have the MRI to actually see the prostate.
Really? You're moving away from that because when you place the markers transperineally, whether gold, you said gold or titanium, right?
Yeah, platinum.
Platinum. So they stay there permanently. They never come out. They take you to, you get them there and you carry them the rest of your life, correct?
Yeah, correct.
Is there any issues with this? I might sound funny, but is there any issues with having those permanently in there in terms of, metal detectors and all that thing, or that's not an issue?
No, that hasn't been an issue. That doesn't seem to be an issue.
Okay. So, but right now you're still doing the fiducial markers unless, say that again, that unless they're getting really good MRI placement?
Yeah, so just to clarify, I mean, we historically have used these markers because our machines, our linear accelerators, have not had an MRI on them. They've only had these X-ray or CT equipment. We now actually have MRI guided radiation machines. These are new linear accelerators. And on those machines, there's an MRI built into the radiation machine. So you don't need the fiducial markers, because you can actually get an MRI as their patient is getting treated. So in those patients, which are actually sifting, and on the results, some of the studies that we did, we're treating more with that machine. We were not placing the markers.
So then why do I need the markers anymore? I just want your MRI machine. Can everybody get, is that just not that easy?
Yeah, the MRI guided machine is a newer machine, so it's not as widely available. That's probably the main reason. There are some differences, and just for the sake of patients to go over them, with you are inside of a tube. So to get an MRI, you have to be inside of a tube. With most of the X-ray CT based machines, you're actually lying on a couch and the machine is rotating around you, but you're not inside anything. With the MRI guided machine, you are inside something. So for some patients with extreme claustrophobia, that might not be the best option for them. And then there are some patients that have shrapnel in their body or pacemakers, and there's some special precautions, or maybe the MRI is not the best. But otherwise, I actually have been defaulting to use it, because in addition to not using the fiducial markers or not needing the fiducial markers, there's the real-time tracking aspect, which is their true benefit. I mentioned the prostate is moving, right? We actually can get an MRI 4 to 8 times per second. And if the prostate is moving too much, the beam will automatically turn off. It does prolong the treatment. So with the X-ray based treatment, we actually go super fast, and it's like 15 minutes in and out. This MRI guided treatment is 45 to 60 minutes. So it's a longer time. But my way of explaining it is that's time well worth spent, right? If we're monitoring and turning off the beam on and off, that's of benefit, right? It's turning on and off because of motion. So it is a longer treatment. But it has a lot of advantages and has become more of my default recommendation.
That is really interesting, because I'll tell you something I've learned in my career. There's the perceptions and the realities, and patients will, especially in the advocacy groups, they'll really tell you the reality versus the perception you'll see or hear about. I used to hear all the time, hey, fiducial markers, no big deal. We put in a couple of these. And man, I heard so many patients go, I hated the fiducial marker experience. It was not that fun. I didn't like it. I don't know if you have any comment on that, but that's really neat that possibly one day we'll be moving to that. So right now, when you're putting the markers in, Are there antibiotics involved, I guess, still?
Correct. Yes. We do give antibiotic prophylaxis.
Okay. And then what about if I'm on a blood thinner and you're going to be putting these markers in? I mean, does that come up? That we have to stop those, or what happens there?
Yeah, our preference would be to stop them. I mean, in a rare, well, it's different now because we have the other machines. So if someone can come off blood thinners, we would, by default be recommending the MRI guided machine. In rare cases, they can be done without holding the blood thinners, but that's by no means anyone's preference. There's a risk there if you're putting in fiducial markers on blood thinners. Okay,
that's very helpful. See, all this stuff. See, it's the treatment that gets all the gold. No pun intended, but it's this PREPA stuff that's so important. So now I want to move. We close that. I want to move now to the spacer, right? And what you said in one of your talks. Can we set this up again? This is what can reduce your exposure to radiation. This is this hydrogel. You said radiation in an older talk, just to show you how I have no life and I end up being obsessively compulsive about our speakers. You said it follows the inverse square law.
Mm-hmm. Yeah.
So can you explain what the inverse square law is and why this spacer is necessary for some people? And then I have a few follow-ups.
Sure. And so, I did. And thank you for, you're probably one of the many views of that, probably viewing it multiple times. And I'm the other person viewing it, just so you know. So it's just me and you that's watched that video. But basically the inverse square law is a physical law of nature. I like to think about it like this and explain it like this. You think about a light bulb. The closer you are to the light bulb, the brighter it is. As you move the light bulb further away, it gets less bright. Radiation is an X-ray. It follows the same physical laws of nature. So as you get further away from the high dose area, the dose of radiation decreases, and mathematically it's decreasing as the inverse square of how far you move away. And that's just a fancy way of saying moving away a little bit drops the dose a lot. And so the idea behind the spacer and any of these types of products are you kind of inject something between the prostate and the rectum. You're creating this physical separation. You're moving it apart. Maybe it's just 1 centimeter, but that 1 centimeter, you're dropping the dose significantly by doing that.
I see. So this is the bookmark that I use. I don't work with any of these companies, so people know that I'm just holding up something that looks, so they put in this hydrogel here, right? So it seems like you use this. Yes or no for most patients that you treat SBRT with, for most, right?
Yeah, I mean, there are some considerations that go into play, and just for full disclosure, it is a procedure to put in too. So just like you were talking about with the fiducial markers, it's like a transperineal placement as well. It is a slightly larger needle than the fiducial markers. So there's some pain and discomfort associated, and, bleeding risk infection with any type of procedure. That said, the biggest hurdles or biggest barriers to me placing it are, one, if someone has cancer growing outside the capsule of the prostate posteriorly, so in that space, I don't want to put in the spacer because then we might disrupt the cancer. And so I don't use it in those patients. And then two, practically speaking, it's covered by Medicare. It's covered by many insurances, but it's not covered by all insurances. And so its cost may be prohibitive also. So those are the two main reasons I'm not using it. Otherwise, I mean, it makes sense. And if a patient understands the risk benefits, to place it, I think is reasonably a good idea.
And this absorbs, the body absorbs over 3 to 6 months is what you said in one of your talks, right? Is that correct? Yes. I mean, after 6 months, it's gone. Because it's a polyethylene glycol, and you'll understand that's Miralax. That's what you use before a colonoscopy. I mean, polyethylene glycol is all over the place, those compounds. So the body's been used to being hit by that. But you taught me something, a patient taught me something who saw me, and I can't emphasize this enough, that what you have to discuss is that certain people, he told me this, he said that he talked to you, and for that one person, you weren't a fan of it because what you were saying is, repeat that again, that sometimes cancers are hanging out really close to where the marker would be. And so you don't want to use it in that case. Can you explain it again? That's an awesome thought for some reason.
Sure. Yeah. So I mean, the prostate, one way to think about it, is kind of like an orange. It has a rind around it or a capsule around it. And sometimes when
I'm ready, baby. I'm ready for it.
You're ready. Yeah. That's your snack versus a donut. That's why you're much healthier than I am. So the cancer, if it grows outside the capsule of the prostate, it's kind of like it punching a hole in that rind. And if that happens in the posterior direction, that's where the rectum is. And that's the space we would be putting the spacer in. And
Okay.
what we don't want to do is disrupt or dislodge the cancer or move some cancer cells out of the way. At the end of the day, that would defeat our purpose. And so actually, even in the SpaceOAR trial where they studied this, they did not include those patients on that trial. So in my opinion, it's not indicated in those patients.
That's what I loved about it. The patient was able to tell me, a lot of people, you want to hear the pro as well as the con. Okay, not everybody qualifies for everything, just like SBRT. And he came back and said, look, this is really educational. And I thought that is really interesting. Those are the people that you do not use the SpaceOAR with. When I was talking to Dr. Steinberg last year, I didn't forget something. He said that, you use it and now you're studying it. There's been some talk. I don't know where it is. It's been a year now, almost a year. He mentioned that it could be potentially protecting other spaces. It could be protecting bladder, but he wasn't sure and he didn't know where it was going to go. But the implication was it could be protecting other things besides the rectum. Where are we with that?
Yeah, so I think that's still being actively studied. There are some papers and publications that support this idea. And what it is essentially is there's this concept of in radiation planning, the dose has to go somewhere. And when you put the gel in, you can put more dose when you're planning the radiation posteriorly without affecting the rectum. That might allow you almost inadvertently to pull dose away from the bladder and some of the neurovascular bundles. And so there's some thought, and it was actually seen on the SpaceOAR trial to some extent. Some of these other things like bladder dose, neurovascular bundle dose are actually reduced as well. And so there are some studies that are looking into this more rigorously, but that's the thought process because dose has to go somewhere. If you're allowed to get more dose posteriorly and you feel safe with that because of the spacer, perhaps you can pull dose away from the neurovascular bundles in the bladder.
That's really interesting because there's another talk I'm giving on a person who's an incontinence expert from Florida. And I was saying how we've come so far with these neurovascular bundles. We used to always refer them in urology as being for your sexual health. And now we know they're very much tied into your urinary health, right? So these have become real buzzwords in our field. Okay, that is awesome. And I actually got through all the questions. Now we're going to walk through the SBRT step by step still. I got more. Now we're moving toward the treatment, right? Now you're going to be treating me. I'm excited. I don't care that you eat a lot of donuts. I still want you to treat me. And so everybody says the same number. It's 5 treatments, but then I hear different. 5 treatments over 5 days, 5 treatments every other day. What's the protocol on number of treatments and which days I get them?
Yeah, a great question. And so our policy at UCLA has always been to do the treatment every other day, every other business day. So we're talking about 5 days a week, typically Monday, Wednesday, Friday, Monday, Wednesday, or something like that. And the reason we do that is there have been some studies, including our own, that have looked at how you space the treatment. And patients treated daily, 5 days in a row, are more likely to experience side effects than those that are getting every other day treatment. So because we want to minimize side effects, we're offering every other day. Now, sometimes things happen and it's just like a logistical thing. Maybe a flight has to happen at a certain time or whatever. And so I do sometimes give 2 treatments in a row, like Monday, Tuesday, then Wednesday. Then Wednesday would be off in that case. And that's just for like logistical reasons. But I prefer that all 5 treatments are completed within a 14-day time frame. Now, there is a trial from Canada that showed that if you treat once a week, that might even lessen the short-term side effects a little bit. And so sometimes if I'm treating someone that has a lot of baseline urinary problems and that's not an issue for them to come once a week or they're older, we consider that too. But most of the time we actually prefer the every other day as our kind of go-to standard.
Okay, that helps a lot because I would have thought that during coronavirus, maybe someone was 2 or 3 in, then they got sick and then they couldn't come back for weeks. And what did you do there? Did you say, oh, we're going to do 2 more and make it 6, or we're still just going to complete out the 5? I mean, what do you do then?
Yeah, so that's a great question. Believe it or not, that didn't come up. We didn't run into that. But there we would fall back to this notion that from that Canadian trial where you treated once a week, 5 treatments. So we know that treating over the span of like 5 weeks is okay. And so we can space out the treatments that way if needed. So if someone got sick and we needed to move the treatments back, we probably don't need to add an extra treatment as long as we can complete the 5 within that kind of like 25 business day time frame of 5 weeks.
Okay. And then how long? So I go in for one treatment. How long does that take when I come in and say hi? How long does it take before I'm done? For one
It
treatment?
depends on a
I'm getting 5 of these every other day. What's the average amount of time I'm in the machine?
Yeah, so if we're doing the CT guided treatment that uses the fiducial markers, it is faster. That's a pro of it. It's about 15 minutes. If we're doing the MRI guided treatment, which doesn't need the markers and it may have some other advantages, that's a little bit longer, 45 to 60 minutes.
Okay, that's great. Now I'm going to ask you the question that I hate when someone asks these questions, but you got to ask it because I'm trying to make something simplistic that is so hard, but maybe you can help me. Who are the best candidates for this treatment? I mean, I'm asking you to generalize. I really am. I have someone watching this. Who is the best candidate? Someone that's newly diagnosed that has cancer in their prostate, someone with low risk, intermediate, unfavorable. I mean, just in general, who do you say, hey, you may qualify if you're this?
Yeah, so that's actually a great question. And I would say my practice is that anyone that has a localized prostate cancer, from low risk to very high risk, is a candidate for SBRT. Now, the ideal candidate would be someone who we do that cheek swab on and comes back as low risk of side effects. That would be number one. And then two, we get into this, notion, I touched on it briefly, someone that has a lot of baseline urinary symptoms, they have a really big prostate and obstructive symptoms. Now, the data are actually not clear on whether it's actually better to do a longer course of radiation in those patients. But that would be one in which maybe although your eyebrows are raised a little bit, are there going to be more short-term side effects if you're going very high dose per day on someone who has a giant, like 200 cc prostate? Maybe we spread things out a little bit. So that might be an indication of very large prostate, a lot of baseline symptoms, high genomic risk. Those are people in who I'd probably steer away from the SBRT, even though it might be okay, at least in the large prostate or baseline symptoms. But the ideal candidate is almost anyone else.
Wow. Okay. Who are your worst candidates? Who are people? And the reason I'm bringing this up is because you helped me bring this up, because I went back through every single one of your publications. Again, let me reemphasize, I have no life, but I do find this interesting. You mentioned there was a paper. I don't remember if you're a first author, but it was interesting. You were looking at people with inflammatory bowel disease.
Yeah. Mm-hmm.
And a lot of people have inflammatory bowel diseases. And the implication was you might have to be more careful there. Are these bad candidates, or you just have to be more careful?
Yeah, and I think that's a great question, and there's two pieces to the answer. The first is, are they a good candidate for radiation at all? Yes. Right, and someone with an inflammatory bowel disease is more likely to experience side effects after radiation than someone without inflammatory bowel disease. And so in general, those patients, if surgery is an option, they should seriously consider that. And I tell that to any of my patients that I see that have that, particularly active inflammatory bowel disease. Okay. That paper, we looked at inactive inflammatory bowel disease, so someone who may not having any active flares. And we did find there's a higher risk of side effects after SBRT compared to people who didn't have IBD or inflammatory bowel disease. But my personal take on that is it actually higher because it's SBRT, or is it just higher because it's radiation? Meaning it's also a higher risk if you do longer course of radiation. It's also higher risk if you do brachytherapy. It's the fact that you're doing radiation. So I don't think that IBD is a contraindication to SBRT. I think it's a contraindication relatively to radiation in general. But once you've decided to receive radiation, I do think SBRT is on the table then.
Because I think you answered it. So we're talking about ulcerative colitis. We're talking about Crohn's disease. We're talking about the ones you see on TV with all the big commercials. But they're on all these fancy medicines, these TNF alpha blockers. So a lot of them go right into remission. It's quiescent. And if someone has been in remission for a while, you don't have a problem doing SBRT on them?
Well, I still think they're at a higher risk than someone who doesn't have IBD at all. They have a higher chance of developing side effects. But what we saw in that paper is that the chance of severe side effects was still fairly low. And so we can consider SBRT if we're doing radiation at all. Again, those are the patients in whom, consider seriously surgery as a treatment. Okay.
And any other candidates jump out in your mind as you go, oh, I'm not so sure, we got to talk about this further? Anybody else that you can think of that's just... They're not good for SBRT?
So one area of controversy in the field, I have treated these patients, and there are others that treat these patients as well, but is someone that has had a prior urinary procedure, like a TURP, which is a transurethral resection of the prostate, or, someone has this giant prostate, they got a procedure where they kind of did a rotor-rudder, cord it out, or like a HOLEP procedure, another one of those type of procedures. In those patients, there's some, consideration again, the higher dose per day, is it going to cause an issue? I don't actually think the evidence supports that, because again, it's the question of, is it radiation or is it SBRT? Those patients may not be the best radiation candidates in general. If they can get the surgery, there might be less overall, urinary irritation from that. But I don't think that SBRT inherently carries a higher risk than, say, the longer course of radiation. So I do offer SBRT to those patients, but that's, that is an area of controversy. Some patients are not counseled to receive SBRT if they've had a TURP.
Yeah, so any of these BPH procedures that get all the attention and love, I mean, that's interesting. It's really interesting. Okay, so we went through candidates. I got that done. Now I just want to talk about PSA briefly, because I still have not found anyone that can walk me through this, although I think you can. I get SBRT from you. How low is my PSA supposed to go for a good response? That's my question, right? Is it supposed to be undetectable? Is it supposed to be 0.2? Where is this thing supposed to go where you are happy? And then if you forget, I'll remind you, because I hate when I get two questions, but I just don't want to forget it. What about this PSA bounce concept that we always hear, where PSA could bounce like a ball, but that might be okay? So two questions. How low should my PSA go? And, how are we monitoring this? And then tell me about PSA bounce. And that's a good couple minutes.
Sure. So after SBRT, the PSA should go to very low levels, but it does take time to get there. I check PSA first 3 months after SBRT, and then usually 3 months, every 3 months for the first year, and then maybe every 6 months afterwards, and then gradually spacing it out. It doesn't go to zero. That's because we didn't remove the prostate. It's not a surgery. There's still some benign prostate left behind that produces PSA, but it should go to a very low number. Oftentimes by 3 months, it's decreased by about 40 to 50%. So if someone came in with an initial PSA of 7, I'd like it to be around 3.5 to 4 at the 3 month mark. And then it follows what we call an exponential curve. So it drops less and less, but it keeps going to a lower number. Eventually, over 50% of patients get to a PSA of less than 0.2, and 80% get to a PSA less than 0.5. In terms of like what's a good number, when we're talking about long-term follow-up, there are good data to say that we want it less than 0.4 by 4 years. So 4-year PSA less than 0.4 has a very low chance of then having a recurrence. 4-year PSA greater than 0.4 has a higher chance of ultimately getting a recurrence. And that goes into your second question about the bounce. So how do we define a recurrence after radiation? It's by a rise in the PSA. And specifically, it historically has been a rise in the PSA of 2.0 plus the lowest number that it went to. That's called a recurrence. But sometimes we see this bounce, which we think is like an inflammatory release of PSA from the treated prostate. So someone could go, they've been at 7, then 3.5, then 1, then 0.5, and then it goes up to 1.2. And obviously that can be concerning because, oh, wait, that number was going down, now it's going up. Most of the time, especially if it's within 18 to 24 months after the radiation, that's called a benign bounce. It's just from inflammation. If you check it again, it'll be coming back down. It's actually not related to the cancer. It's more of a concern if you start to see this rise in a later time point. So if it had been 0.2, 0.3, and it's 4 years later, and then it goes up to 1.0, 1.2. If it's been a lot of time since the SBRT, that's when that's more concerning. So the bounce is a benign process. It happens in about a third of patients, actually. So it's fairly common.
Wow, it happens about a third. Okay. So I didn't realize it happened in a third of patients. So 33% experience a bounce. So basically, when you're done with your treatment, your PSA goes to a low level and it's supposed to hang there. For most people, it's not supposed to jump up and jump down and do very strange things. It's supposed to be more flatlined. It's supposed to be more staying within a particular range.
Yes. Right? Yeah, it is. And just another point is that different labs are different too. And in this era of ultra sensitive PSAs, I'm sure you have patients that ask these questions. They get it checked one place, it's 0.2. They get it checked a lab down the street, it's 0.3. Those aren't necessarily different. There are these error bars on any test where like you could get the same test at the same place even, and it might fluctuate. So we're talking about larger magnitude changes, but generally, yes, it should go down, keep going down, and then flatline around 0.2 to 0.5.
Okay. That's very, very helpful. Okay. The next I want to move to is, we got the PSA questions out of the way. I want to move to the side effects that you covered well, but just briefly cover again. So the short-term side effects, within the first few months, I hear patients from around the country say, you know, I got this urgency. I got to go. It's like they call it, they use the word urgency. So is that in a nutshell, the short-term biggest concern is that patients have urgency? And is there anything to do about that urgency?
Yeah, I would say it's this general bother, of which urgency is probably one of the most, bothersome things, is that, the inability to postpone the urge to urinate. So you feel like you got to go, you can't hold it for more than say 5 to 10 minutes. You have to go frequently. So, or you have to go multiple times per day, more than you used to have to go. That's urgency and frequency. That's very common to experience to some degree. There are medications that can be used if it's very bothersome, like oxybutynin or mirabegron. These are kind of what we call anticholinergic medications that can relax the bladder. But sometimes what's going on is it's actually due to the fact the bladder is not completely emptying because it's inflamed. And so people feel like they have to go really frequently because each time they go, it's not emptying fully. That's actually more common, and that's an obstructive symptom. We treat that with ibuprofen. Or tamsulosin, which is a Flomax. These are things that can open up the urinary channels to allow the bladder to empty more frequently. I would say those are the most common situations that we find ourselves in the short term.
So if someone's already not on those medications, is it good to talk about that? Because it's coming. The urgency is coming on some level of severity, mild, moderate, severe. It's probably good to talk about, hey, what can I use if that really bothers them? Then you guys have no problem prescribing what they need there, right?
Correct. Yeah. I would talk to the radiation oncologist and they should be able to prescribe a medication for you.
Let's talk about, so is there anything else short term? I'm just talking about the vast majority of what people experience. And is there anything else short term that just keeps you up at night besides the fact that it's the urgency and frequency, or does that cover the main ones you're concerned about the first 3 to 6 months?
I think that's the main one for urination, and then and for bowel too, it can happen. And arguably, if it happens with the bowel, that can be more bothersome to a given patient, particularly if they have to go to the bathroom more frequently to defecate. That happens less frequently. So acute bowel bother is not as common as acute urinary bother, but when it happens, I think it's probably more bothersome, and we would treat that as well with over-the-counter antidiarrheal medications like loperamide or Imodium, or if it's very severe, we can use like a steroid suppository that can be pretty effective as well.
I'm glad you mentioned loperamide or Imodium. It sits on all the shelves. It comes in like 2 milligrams. It allows really flexible dosing. And a lot of people will say, well, I'm scared to do that. And I'm thinking, well, you got to have that conversation up front before you have that side effect, so that you get the blessing that you can use that no problem, because it's a very gentle product with a lot of latitude, right? So I'm glad you brought that up. So let's talk about long-term side effects, just a few of them. What's the ones that keep you up? I mean, I can list a whole bunch of them some have been conspiracy theories. But what's the ones that worry you the most in terms of a year or two down the road? Is it like rectal injury, or what is it?
Yeah, it would be like any of the severe side effects, which thankfully are rare, but they happen. And I try to explain that to everyone, that it's a kind of a percentage game, right? So let's say the chance of a severe urinary side effect is 2 to 3%. That doesn't, on the one hand, it means the risk is low, but you're treating 200 people per year. That's 4 to 6 people. If you're one of those 4 to 6 people, it doesn't matter that it was just 2 to 3%, right? It happened to you. And so those are the ones that can be more challenging, because these are patients maybe in whom there's a lot of urgency and frequency, and we've tried the Flomax or tamsulosin. We've tried these other medications and they're just not working. and I have to send them to my colleagues in urology to maybe take a look into the bladder, and urethra and see what's going on and what can we do to treat it. And similarly with bowel, where it's thankfully even less common to have the severe kind of bowel issue, or maybe ballpark 0.4 to 1%. But again, it's happening. It's not like it's nobody. And anyone that treats a lot of patients will have patients that develop these side effects. And then you send them to the gastroenterologist. Just one thing that you have such a wide viewership that I want to make sure gets out there is try to let your radiation oncologist know if you're experiencing these symptoms, rather than going immediately to the urologist or GI doctor. Not that they're not good doctors, but think about it this way. Let's say there is a scab. What do you not want to do? You don't want to pick at it, right? So sometimes, someone has this rectal injury, someone goes in, they look at it, they biopsy it because maybe they didn't understand that you just had radiation, but that actually just makes the problem worse. Yes. So try please to talk to your radiation oncologist. And I try to tell my patients, keep me very involved. I don't want you to get a colonoscopy for 18 months after the radiation, unless we really need to, because I don't want someone kind of messing around in there with the rectum. And similarly with the bladder, although it's less common for someone to routinely get a cystoscopy.
Now I know why you got into Harvard and MIT and I didn't, because my next question was, no one's ever asked a radiation oncologist, when can I get a colonoscopy after a SBRT? And you just answered it. So you want people to wait up to 18 months, right?
I do. Yeah. Erring on the safe side.
I mean, are you, and the other thing is a lot of these other tests that are non-colonoscopy based are based on finding some fecal blood. So you're just basically, if you're going to get any of your colonoscopies done or Cologuards or you name it, you're basically saying, let's get that done before. Is that right?
Yes, correct. Absolutely correct. Yeah. If you're due for one and, it's going to be within 18 months after the radiation, I tell my patients to get it first. Now, I mean, Cologuard is as like a FOBT test or whatever, stool blood, that's okay. But, there can be some microscopic bleeding as a result of the radiation injury that's not like a cancer. It's just because of the radiation causing some inflammation. So it would still be better to get that before the radiation is done.
That's awesome. Never heard that. First time. That is fantastic. I'm going to leave side effects except for one that I've heard from doctor friends around the world that have received radiation, and that is the word stricture. Mm-hmm. I've had a couple doctor friends get strictures, and when they tell me about them, they have to be dilated and all this. I go, oh, that's a narrowing of the urethra from trauma or from multiple reasons. Are you worried about strictures at all? Is that very rare with SBRT?
I mean, thankfully, strictures are rare, but they can happen. Again, anyone treating a lot of patients will have seen someone that has developed a stricture. And obviously, that's one of those things that keeps you up. You don't want to cause a stricture. Things that we're trying to do to minimize that are trying to avoid high doses of radiation to the urethra. So that's actually an area of active research. How can we see the urethra better and avoid it during radiation? Because, the urethra runs right through the center of the prostate, and we need to treat the prostate right around it, but we don't need to treat the urethra. It's very hard to see and very hard to avoid dose of that. But that's, again, an active area to try to minimize the chance of a stricture.
Okay, so I think we've covered side effects well. Again, the Moyad rule is it's not just your treatment, it's preventing and treating the side effects of treatment. So go to your radiation oncologist if you're concerned about a side effect and how to prevent it, or if you're concerned about a side effect you're experiencing and how to treat it. That's what he's saying, and that's fantastic. Now I'm going to move into the subject that has slayed many an interviewer, not the person answering the question, but the interviewer. And that is ADT, androgen deprivation treatment. If you look online in the chat rooms, you'll see them go on forever as, am I supposed to get hormone therapy with radiation, or am I not supposed to get hormone therapy radiation? And I've heard about hormone therapy with IMRT and long-term radiation. I've heard nothing about SBRT and hormone therapy. So my question is, how does this whole game work with hormone therapy? In fact, I actually made something for you. This is how much I was obsessed with it. Androgen deprivation therapy. Who needs it when they come to your office? When do I need it? And for how long do I need it and why? So if you walk us through this, you get the gold donut, you get the gold star.
So, yeah, I mean, obviously that's a great question. It dominates a lot of the time that I spend discussing with patients as well. And it's a huge area of research interest for us too, because nobody likes to give the hormone therapy either if we don't need to. And so first, just to level the playing field again, what is hormone therapy? Because the number one thing I get is, am I getting female hormones? And it's not. And so it's like you wrote there, it's androgen deprivation therapy. What we're trying to do is shut down or inhibit the action of testosterone, either shut down production of testosterone or block it from working. We're not giving, female hormones to somebody in modern times. And why are we doing this with radiation is kind of like a twofold answer. I'll try to break down. One is it makes the radiation more powerful. So I mentioned at the very beginning, radiation is killing these cancer cells by damaging their DNA. But cancer cells are smart. They can repair their DNA. Prostate cancer repairs its DNA using testosterone. So we want testosterone to be low, or it acts to not be working, so that we can consolidate the impact of the radiation. As we get to these more aggressive prostate cancers, we want to add that bang to our buck. So that's number one reason. It actually makes the radiation stronger. Number two is, in case there is any microscopic disease outside of what we see, perhaps we can sterilize and kill that off too by depriving the body of testosterone or blocking the action of testosterone. And so that's why we do it. Who needs it? An area of active research, I would say patients getting with high-risk prostate cancer definitely need it. And, there have been a lot of trials looking at this, including our own trials, that patients that don't get the hormone therapy, they don't have as good of an outcome. Now, there are exciting new research questions, like maybe we can use some tests to figure out who needs it. But, at the prime time, I think the base assumption is that everyone with high-risk prostate cancer needs it. And most patients with intermediate risk prostate cancer probably need it and benefited from it as well. But the other answer to that question is this topic of absolute and relative risks, which I like to try to explain to people. Let's say that your chance of developing a failure or a metastasis from your prostate cancer is 15%, and the hormone therapy drops that to 7.5%. For a lot of people, that 50% reduction is worth it. You're taking 15% to 7.5%, no brainer, I'll do it. But if your risk of developing metastasis is 2% and you're dropping it to 1%, that's a 1% benefit. For a lot of people, that is not worth it. But that benefit was the same magnitude. It was still 50%. And so I think that's where, that's why everyone in theory could benefit from hormone therapy. It offers some benefit to everybody, but the magnitude of that benefit is highly variable depending on the risk and aggressiveness of the prostate cancer. So for me, high risk prostate cancer, definitely need it. Intermediate risk prostate cancer, unfavorable, basically generally would need it as well, but favorable, that's where you're getting into this, like it's a low chance of failing. So it might help, but minimal absolute benefit. And then you asked another great question, or brought up the point, do you need it with SBRT? And the answer I think is still yes. And why? So there has been this idea that if you can deliver a high enough direct dose of radiation, you don't need the help of hormone therapy, in terms of like preventing DNA repair. You're killing it well enough that you don't need the help from the hormone therapy. Unfortunately, that doesn't appear to be true. Maybe you can get away with a shorter amount of hormone therapy, maybe, and that's an area of active investigation, but it's not that you don't need it. It still offers a benefit. Again, the absolute benefit might vary, but it's still helping the case to do it. And then, the last question he asked is, how long? How long do I need the hormone therapy?
Question. How long? You got to put me through this.
And so for someone with intermediate risk disease, 4 to 6 months. For someone with high risk disease, 18 to 36 months, but sometimes we do 12 months. And the reason sometimes we do 12 months is when you're getting these very high dose of radiation, and SBRT is mimicking in many ways this very high dose of radiation, it may be appropriate to drop that the duration from 18 to 12 months. That's still, again, an area of active investigation, and it depends on a multitude of factors. But essentially, short-term hormone therapy for intermediate risk disease and long-term hormone therapy for high-risk disease.
Okay. And I also mean when, if I take that further, am I getting my first shot or pill or whatever I'm doing? Am I getting my first hormone suppressive treatment before you start the SBRT? Am I getting it during those 5 treatments, or am I getting it right after I'm finished?
Very good question. And I think so. There's different ways of doing this. Our field is moving towards backloading as much of the hormone therapy as possible in general. There have been some early data to say that might be better. You start it at the same time, and then you have the majority of the 6 months after the radiation is done. And actually, that's what they've always done in Europe. If you look at all the European trials that used hormone therapy, they all started the day that radiation started. It's in America that we had done this lead-in period of 2 months before the radiation begins. Now, so that's mainly what I do. Sometimes there's some logistics involved in radiation planning. You got to get authorization, scans started. So yes, we start it maybe a little bit earlier before the literal first day of radiation, but we're backloading the majority of the hormone therapy. The exception, if someone has a giant prostate and we want to shrink it before we do the radiation to help with side effects, then we want the bulk of that hormone therapy before the treatment was done. Right. And the other thing is the pandemic. Sometimes patients, they couldn't come in for radiation, but we didn't want the cancer to progress. So we started the hormone therapy to at least put the brakes on the cancer before we began the radiation.
So the majority of the people are getting it either around the time of SBRT or essentially afterward, because you have a lot of publications, and lately you've been using this word adjuvant a lot in your publications. So I mean, like you said, it seems like you're a big fan of, as you say, backloading it or using it, unless there's a huge prostate, right? Using it around the time you give the radiation and then just following people then, correct?
That's correct. And just so, patients don't get confused or feel bad, because sometimes they've already started hormone therapy before they come to see me. And it's not that having it beforehand hurts. And when someone that's getting like a long course of hormone therapy, when we say backload, that doesn't mean all of it is afterwards. It could be that you're getting 18 months and 2 of it was before we got the radiation. That's okay. Or 3 of it was beforehand. The majority of it is still afterwards. So, not to fear if you've started the hormone therapy, but yes, if I'm starting the process anew, I typically start the hormone therapy like right before the radiation, a month before the radiation, or at the time of the radiation.
Okay, that's really, really helpful. You ever use the C word with any of your SBRT patients? Chemotherapy? Chemotherapy is kind of bouncing around, high Gleason scores, all these things. I mean, do you have these discussions that maybe a couple courses of chemo after the course of SBRT might be helpful? I mean, where is that? I don't read anything on that.
Yeah. So another great question. I think that the data for chemotherapy in high-risk prostate cancer, which is where is studied, are not as strong as they are for metastatic prostate cancer, which is a different ball game, and that's a different discussion. But if someone has prostate cancer that has not spread, there have been trials looking at this. One of which actually initially showed a benefit using chemotherapy, but they recently updated it and they didn't show a benefit with long-term follow-up. So we're not recommending chemotherapy, which the way I hear that from patients is actually them asking me if they need chemotherapy, and I'm happy to tell them they don't. And most of them are happy to hear that.
I also want to go back for a second to talk about prostate size, because I don't think a lot of people realize that when you throw all this radiation at a prostate, it shrinks. Right? It shrinks over a certain period of time. I don't know what the agreed upon rad-onc world is about how much it shrinks, but it shrinks a significant amount. Can you talk about that? I'm not talking about with hormones. I'm just talking about whammo. When you hit it with radiation, that thing shrinks, especially if it's big.
Yeah, no, so it does. And I mean, in the very short term, it swells up a little bit as it's getting inflamed from the radiation. But then, as you said, over time, it kind of shrinks down. And the magnitude of that shrinkage in the time course is not super well studied, but it's like, say, if you get an MRI a year after the radiation, oftentimes it's 30% to 50% smaller than it was before we did the radiation.
So you would assume if it's going 30 to 50% smaller, and that's a pretty big prostate, that there are some patients that actually have improved urinary function after radiation. Yes,
there can be. There are some that do with longer term follow up. As the prostate shrinks down, some of the obstructive symptoms may get better. So that is a possibility for someone that has a big prostate causing a lot of obstructive symptoms. But it would be in the long term, like playing the long game, basically.
I see. So here's the MIT Harvard question. I've asked a couple of rad-oncs and they've gone, interesting question. My thought is, I just want your thought. If you're shrinking the prostate by 1/3, something's got to go. What's going that's shrinking it? Is that the normal tissue? Is that the BPH tissue? Or is that the cancerous tissue? Or is it all the above?
I actually think it's probably all the above. Most patients, thankfully, don't have a kind of large gross tumor, although the tumor itself will shrink, and someone that does have a bulky tumor, they might get benefit from that. I think it's the stroma, the normal tissue of the prostate, that's just getting fibrosed or scarred down, and it just shrinks in size.
Before I go to these other ones, I want to talk about my favorite topic that never gets enough attention in radiation, and that is lifestyle. First, I want to talk about lifestyle in the concept of a diet you're supposed to do around the time of planning or during treatment. I know one of the biggest fears of radiation oncologists is prostate movement, right? So some people have argued for 30 years that if you change your diet, I've seen it all over the place with no consensus. If you change your diet, if you go to a high fiber diet, if you go to a low residue diet, less fiber, you can possibly change the dynamics of the gas bubbles that exist in the intestinal tract and other places. What do you tell patients during planning and when they're being radiated about what could make that prostate move? Or do you have that discussion about diet and prostate movement at all?
Yeah, I mean, so with some of the modern technologies that are a little bit better able to account for some of this motion, it's less of an issue, but it's still an issue. And I do try to mention that I don't think, it's a short course of radiation now. A long time ago, we were talking about like 2 months, right? Now it's 5 days. I don't think it's too much to maybe not change your diet for that amount of time. Okay. Eat something consistent for that amount of time. And then we should minimize the chance of, say, like a new diet throwing off the gas you produce, which could happen and would cause a problem.
Yeah. So, I mean, but is that just becoming a more minor and minor problem, just the gas production in the intestinal tract, rectal gas, in terms of what a patient's doing? Or is that something the technology is able to move beyond that?
I think technology is able to move beyond that a little bit. And also because the course of radiation is so short and the precision with each session is so high that it's less of an issue over time.
Which makes me think of another question I should have asked before that. Everybody agrees that radiation can cause fatigue. Why? But
yeah,
is this because you're creating a temporary inflammatory response that is becoming an energy sink? Is this because a lot of people today who get radiation, I'm not saying everybody, are not exactly the healthiest parameters, and it exacerbates? I mean, what's your theory as why some people experience fatigue and others don't?
Great question. We don't know the answer. It's actually something that a lot of people want to find the answer to, because it's not just prostate cancer. It's any type of radiation anywhere can cause fatigue. And because it is generalizable, we think it's probably the former thing that you mentioned, which is that it's causing this inflammatory state somehow. The body is sensing that it's getting radiated and it's getting this kind of minor inflammatory state that leads to fatigue. Now, what you brought up is certainly true in the sense that I tell my patients, first to watch your videos, but then also kind of follow the lifestyle advice that you give, which is to be active within reason, because being active, even when you're tired, that helps, right? That makes you feel less tired. It's good for your overall health, and it probably can combat the fatigue from radiation. So I do recommend actually exercise to tolerance to combat the radiation-induced fatigue.
Do you recommend exercise during the time of their 5 treatments if they're going every other day, or is it during those 5 treatments every other day? Are you saying just take it easy, don't do anything, let's just get through this?
No, I say, if you want to exercise, go for it. I mean, I hopefully the treatment isn't impacting you so much that you won't be able to exercise. Now you have to use the bathroom more frequently, so maybe you have to moderate the amount of exercise you're doing, but you should still do some if you can. Okay,
so you allow that during the. Has anybody studied the effect of someone who has lost a lot of weight before? I mean, does weight have any impact? A large amount of weight, a small amount of weight, average BMI, has that ever shown any impact with these radiation treatments?
It has, I think, particularly in the past, that treating a patient who's on the larger side, there might be some physics considerations into how kind of the quality of the images we're getting to look at the prostate and stuff like that. Overall, though, in modern times, no. But as you've talked about so many times, the most important thing in these men is to focus on their overall health and their cardiovascular health, particularly if they're going on hormone therapy. So whatever that can be done to minimize weight gain or get to a healthy weight is very important. And I've heard you say this to so many people, but the overall survival, I mean, prostate cancer is highly curable. I mean, sometimes, unfortunately, it isn't, but in most cases, it's highly curable. We don't want to lose sight of the overall health. The most common cause of death is not prostate cancer, but other things that can be modified with lifestyle and diet and exercise. Yeah.
Amen, brother. So and now here comes the soundbite of the entire interview. And I have no idea what you're going to say. And I just think it's a question that doesn't get answered enough. And I've seen the answer move all over the place. And that's the simple question of, I'm taking a bunch of supplements and I'm about to have radiation. In the old days, they said if you took supplements with radiation, that could provide an antioxidant effect that would hurt the effectiveness of radiation. Other people say it reduces the toxicity. Some people say go cold turkey. Other people say it's fine. I talked to one prominent radiation oncologist recently that said, I don't care anymore because the radiation's so strong, it doesn't matter. But the truth is, we don't know the answer. But what's your opinion on it? Because I've always thought less is more during the time of radiation, but I don't know. You're following the data much better than I am. What's your stance on someone taking a ton of supplements or wanting to take a ton of supplements during SBRT?
Yeah. So as you mentioned, the data are not very strong one way or the other. The theoretical concern is that taking antioxidants, might blunt the effect of the radiation on killing the cancer, which we obviously don't want to do. My approach and what I tell patients is don't start taking a bunch of things right before the radiation, because then maybe you will kind of throw off your body's balance. You're making a lot more antioxidants and it could, in theory, hurt. But if you're already taking a bunch of antioxidants, your body has honestly probably gotten to a steady state in which it's not going to impact so much, that you've already taken these that you necessarily need to stop them per se. Yeah. Of course, because the radiation now is only a couple of treatments, it's not that big of a deal to stop them either. It's not like we're asking someone to stop something for a long period of time here. But I think if you've taken a certain amount of antioxidant supplements for a long time, your body is used to that. It's not needed to stop them before you do the radiation. But I wouldn't start a bunch right at the time of radiation either. Yeah,
not to no, that's helpful because we need guidance on that. And I understand there's not phase 3 data. We're never going to have phase 3 data, but we need people who are on the front line telling us, is this a big deal or not? But it is a big deal because most people take them who have prostate cancer. So the question has got to be answered. All right. The last few questions are random because we've gone way over and it's my fault, but it's your fault because you've been so good. Can I combine SBRT with other things, other types of radiation? I've heard of people getting SBRT, then getting a couple other types of radiation. Can I combine radiation treatments or is this an island of itself?
In theory, you could combine radiation treatments. I wouldn't necessarily recommend that outside of the context of some kind of a clinical trial where they're specifically investigating that. I use SBRT as the treatment. So we're delivering SBRT to treat the prostate cancer. We're not combining it with something else.
But you had a big time publication in 2018. You've had a lot of big time publications. The Kishan publication of JAMA 2018, you said for these like high Gleason 9, 10s, you were seeing, you just have to explain this to the audience because they're going to find your name everywhere. You explained EBRT plus brachytherapy boost in hormones. These men were not only living longer, but you use the word in epidemiology as all-cause mortality. In other words, you were increasing their lifespan by treating this more aggressively, the Gleason 9s and 10s. Can you comment on that?
Sure. And so the idea there, we looked at patients that had been treated in a historical context, 2000 to 2013 to be specific, because we had long-term outcomes to follow. And so in that context, the high dose radiation option that was available was EBRT plus a brachytherapy boost. And what we found was that particular combination with on average 12 months of hormone therapy performed very well in comparison with general radiation with hormone therapy or upfront surgery. And it was a retrospective comparison. My takeaway from that, and having done subsequent studies, et cetera, is that the idea is good local control and appropriate systemic control. So you want a good high dose radiation to the primary tumor, and you want to add the hormone therapy. On average, there it was 12 months. So you might have recalled I said, 12 months possibly with certain types of high dose radiation. That's the key. It doesn't have to be EBRT plus brachytherapy. Okay. It could be, SBRT is the doses that we're using anyway are trying to recapitulate that dose of EBRT plus brachy, but doing it, from an outside in perspective. So it's a non-invasive. It's not the combination of the implanted radiation. And so that's my takeaway from it. So I am offering SBRT to patients with Gleason 910 prostate cancer. Obviously, EBRT plus brachytherapy is an option, and I've published on it. And so, it's a discussion point. I think the difference in side effect profile is a major consideration because brachytherapy can be done very, very well and be very, very safely tolerated. But one of the potential drawbacks is the increased urinary side effects that has been seen in some studies when you're doing that combined radiation. But more broadly speaking, I think what that paper was showing was good local control with good systemic or kind of medication-based control is the key for those types of aggressive prostate cancers. And we don't necessarily need to anchor ourselves to EBRT plus brachy. Specifically, it's whatever is good local control.
What do you do with all these guys who have a ton of cancer in the prostate? You can hit them with SBRT, but they got this, because you guys have been in the forefront also of, PET CT imaging, PSMA, and almost they got this one little node that lights up and all this cancer in the prostate. What do you do then? Do you do 4 treatments here and 1 here? I mean, how do you work that out where someone's got a little bit of cancer outside the prostate and the rest of it's in the prostate, but they want SBRT?
Ourselves and some other groups have studied what's called the technical term is a simultaneous integrated boost. That's where you're actually treating everything at the same time. So there are multiple targets in the radiation plan. We're treating the prostate. We're also treating the pelvic lymph nodes. And if something is bright on the PSMA PET, for instance, we treat that too, because it's intuitive, right? That a visible amount of cancer probably needs a higher dose than a microscopic amount of cancer. So we are treating those patients using SBRT. I think it doesn't mean that's the only option for these patients, but it can be done and we are doing it.
Okay. And then that leads me to the last few concepts of oligometastatic disease. We always heard the term cyberknife and all these things to hit these sites that were outside the prostate. Oligometastatic disease has become a hot topic, and just hitting, a pattern of sites, possibly in the nodal areas, maybe it's on the bone. Can you tell me where SBRT is now with oligometastatic disease? Even though I know that's an entire 2-hour lecture, but the SBRT comes up constantly in oligometastatic disease. So I want people to understand when they leave how it's applied there.
Sure. And so the idea with oligometastatic disease is that the cancer has spread, but it's only spread to a few spots, typically 1 to 5. And maybe if we treat just those few spots, we can meaningfully alter the course of disease. Whether that's a cure or delaying the need for further treatments, we can meaningfully alter the course of the disease. And so SBRT in general allows you to deliver that very high dose of radiation to a very specific point and place. So it's in many ways ideal for something where you got a tiny spot in a bone, you can hit it hard with a high dose of radiation, minimize the dose elsewhere. That can be CyberKnife, but again, that's a brand name. So it could be other types of machines as well. Novalis TX, TrueBeam, the Meridian, these are just other lunar accelerators that concept ablative dose of radiation to a particular point. And if you have oligometastatic disease, that's 1 to 5 spots that you're treating generally, with the intent of altering the course of the disease.
And that's something you do with that machine?
It's something we do very frequently. As you mentioned, I'm fortunate to work with a world-class nuclear medicine department that does the PSMA PET. So we see a lot of patients that have these PSMA PET scans, and there's 1 to 5 spots lighting up. We treat those spots.
So as I'm ending here, the only thing that's going to confuse people are going to say, man, this was a big thing on SBRT, but that's what I wanted on purpose. But in closing, and I have a few other thoughts, when you go to UCLA or someplace else, this is a center of excellence for radiation oncology plus urology. It's got a lot going on. There's no question. you've got some top-notch people doing what's called HDR, right? They're doing these types of brachytherapy. Plus you got your SBRT, plus you got your regular type of EBRT, what patients know about. I mean, it's almost like you need a multidisciplinary clinic for radiation. So how do you just tell patients who are watching this, because they could qualify for some other types of radiation, even at your own place at UCLA? What do? Do they just set up different appointments, one with the HDR doc, one with you, one with Stein? I mean, how do you do this? Because you got a lot of hot types of radiation going on right now.
Yeah, no, exactly right. And I think it's hard to cover all of the topics in detail. So what I try to do is I present a general overview of kind of, the branching points, implanted radiation brachytherapy versus the external approaches, and then, talk about the external approaches. I describe the brachytherapy in some overview, but I do defer if patient wants to hear more about the brachytherapy after hearing an overview. I would refer them to see one of my colleagues in the brachytherapy division, like Dr. Albert Chang, for instance, or Alan Lee or Pooja Venkat, to talk about the brachytherapy in more detail. But I try to introduce the concept to everyone. And some patients, they do want to see the brachytherapy physician. Others, after hearing about it, maybe don't want to, and maybe others have come from the brachytherapy people to talk to us. But unfortunately, the care can be, it's such a specialized procedure that it can be useful to have a second consultation.
Okay, that really helps, because the compare and the contrast, who might be better for HDR brachy, who's better for your radiation that you offer, and there's overlap there, right? I mean, there's clear overlap. And so, but your advice, besides researching the other types, is maybe you do need to set up 2 visits, and that's no big deal.
Yeah, especially in the telehealth world now, video visits are available too, and you can talk to someone from the comfort of your own home.
That's a good point. But when people come and see you, because a lot of people are going to see you, they're going to say, okay, now you tell me all the things about SBRT. Now, if I got HDR, do you answer those questions too? If they just want to know right in the moment, hey, how does this compare with HDR radiation?
Yeah, so I would answer those questions and talk about the overview of the HDR treatment and the outcomes, which are good. I don't want to minimize that. HDR is a great option for patients as well. But I do feel strongly that they should see someone that does HDR routinely to get kind of a more holistic picture as well.
Okay, that's a really good way to end it. Unless I have a quiz question for you, but unless you can tell me about some clinical trial we're not aware of that you're really excited about that may change the way prostate cancer is treated with radiation that you're a part of or of. Do you know is there any clinical trial that keeps you up late at night and goes, man, I can't wait to get that answer? Is there anything that comes to the top of your head?
Yeah, actually, one thing that might be topical because it was just recently approved is the use of lutetium-177 PSMA drugs. And that's like a radio-labeled tracer PSMA. And one thing we're looking forward to open soon at UCLA is maybe combining that with SBRT for oligometastatic disease, what you just described, someone that has a couple of these spots. Maybe we can take out the spots we see with SBRT, and we can use the lutetium-177 as an insurance policy against microscopic disease we couldn't see on the PSMA scan. So that's something we're hoping to get open soon.
That's really cool because 3 days before our interview, it got FDA approved. I mean, the timing is incredible, right? And so that's interesting that you brought up. That's the one that excites you. All right. I'm going to ask you a quiz question, and then we're going to give you a gift, and we're going to let you go. And I really appreciate your time. But this will be one of the toughest questions you probably have ever had to answer in your career, so you might want to buckle up for it. And this concerns your chairman, your chair, Dr. Steinberg, okay? So here's the quiz question. Your chair boss, Dr. Steinberg at UCLA, here's the quiz. He was an actor or an extra in a movie. Was that movie Back to the Future, Planet of the Apes, Speed, Star Wars, or this is a trick question Moyad's throwing at me. He has no time for movies because he's a radiation oncologist and chair of the department. So I'm going to give you 3 seconds. Think about it. And which answer are you going to go with to get your gift? You have to get this right.
I'm going to go with E on that one, although I could be totally wrong. Yeah.
That's awesome. The answer to the question is, sorry, Dr. Steinberg. He was an extra on Planet of the Apes. we're still going to get, these are these LA boys and girls,
Yeah.
right? So in his off time, he would go be extras in sets. That's what I learned about him in last year's interview. And, he's telling me about all this great stuff in cancer. And I won't lie to you, I sort of had a moment. He goes, I was an extra in Planet of the Apes and I almost fell off my chair. I thought it was so cool that this head of radiation oncology has been in a bunch of movies. And so I didn't know if you knew or he'd been bragging about it, but we tricked you. I can't believe it. We tricked you.
You did.
But let's have him open his gift anyway. Alex, are you there that we can give him his gift so he can open that before he goes to work? He's got to see patients.
Well, thank you so much for this. And I'll be sure to try to wear it in clinic as well.
You should. I'm a radiation oncologist.
Yes, I love it. I love it. Thank you so much.
Absolutely. Listen, I want to say this again. I can't tell you how much I appreciate it. You were everything advertised that the patient said, just like the video I watched. I just think that this will become the primer on SBRT, and hopefully people will also seek other opinions. But it's a real honor for me that you're doing this, and you're doing some incredible work. And I really hope that when people are thinking about SBRT, you're one of the people they have a talk with, because behind the scenes and just in general, you've just been great. I really appreciate you.
Well, thanks so much. And again, the honor is mine. It's an honor to be here and talking to you and to the PCRI.
Great. I'll see you at the donut shop. All right. I'm buying, but only the first round. And then you can drive us home. I'm not driving on 2 of those donuts. Thanks, man. I'll see you soon.
All right. Take care.
Thank you, Dr. Moyad, and thank you, Dr. Kishan. That was an incredible presentation. A quick reminder that we are doing a giveaway on our conference page. Visit pcri.org/2022-MYU. Up next, we have Dr. Nicholas Vogelzang. He is the chairman of Medical Oncology at Comprehensive Cancer Center, and he will be giving us an update on the new developments in treatment in advanced prostate cancer. I hope you find this informative.
We're about to interview one of the most famous oncologists in the world, Dr. Nick Vogelzang. And this has something to do with you a little bit. So make sure you say hi to everybody in PCRI land. What's up? What's up? Hey, Dr. Moyad's the best. Everyone should love him. He's amazing. He's my fave. See, my dog talks. I know my dog's smart because I said, Grazie, what's 2 minus 2? And he said nothing. All right, I just wanted to share with you. Look at his little coat. Next time you'll see his U of M coat. It looks actually better on him, of course, because it's U of M on there. And then, because he was so nice to Daddy, he gets a treat. All right. Wave bye, buddy. Would you get a witch? Bye, would you get a witch? Here we go. Back downstairs, buddy. Hey, everybody, welcome to, I don't even know what it is. Is this the 20th annual, the 80th annual Moyad Scholz PCRI conference? And this is one of my favorites. And people say this is one of my favorites when they're just trying to suck up to the speakers. But the reality is I'm always asking him to come on and spread knowledge. And that's Dr. Nicholas Vogelzang, who I've known for a long time. And I don't know why, but he keeps saying yes, even though he has full clinics. So I said, all right. We're just going to tonight, over all the years in the past with Dr. Vogelzang, we make him write all these slides and it's just too many slides. We make the guy work too hard. So I said to him this time, look, we're going to do this in 2 parts. Part 1 is you'll be at home. I'll be at home. No slides. I'm just going to ask you some basic questions and get your thoughts. Part 2, later in the year, I'm going to show up in the room where Dr. Vogelzang is at, which is in his house. And he also has a wine cellar, I think, which just makes it very attractive and formidable also, the interview. And I'm going to do part 2 with him there sitting in his house. But for part 1, we're zooming in at our own places. So first of all, I want to welcome Dr. Vogelzang. And before I welcome you, I Googled your bio and I started laughing. I started laughing because I'm not just saying this, I'm going to chuck this. the reason I'm chucking this at comprehensive cancer centers, I'm going to do this because you're one of the most famous oncologists in the world, and people are trying to tell me what's on your CV. So I'm not even going to go over the fact that you moved over from Chicago to Vegas, now comprehensive cancer centers there. You're handling research. You're in phase 1, 2, 3 different trials. We're going to talk about some of them. You have a full patient load. You've been doing this since the beginning of time. And there's nobody more adroit, more specialized in the area of prostate cancer than Dr. Nick Vogelzang. So it's just an honor to have you. And I think that's a good enough introduction. If people don't like it, they can Google you and they can see where you're mentioned 8 zillion times about all of your work. Yesterday I looked at PubMed and you're on over 500 publications. I mean, that's kind of nauseating. So that's my introduction. One of the best all around, probably one of the best oncologists we've ever had in prostate cancer. Thanks for being with me.
My pleasure. And oh, by the way, the number is closer to 1,000 now.
Okay.
See, that's what you do in academic medicine. You one-upsmanship.
I know, but that's why if you look at my bio, I put primary author. I've written 170 papers. So I figure it's not 1,000, but then again, it's not bad either, right?
No.
One day, if I reach to be the age of 180, I'll reach Nick Vogelzang's number.
Yeah. And I've had a lot of fellows and students and fellow faculty members who've drugged me along on their projects. So, I get a little credit for that.
No, it's prolific and it shows dedication. But before we start, I sent you a FedEx to your house.
You did.
I did. Do you have that FedEx with you?
Sitting on my wine cork-filled half barrel.
Okay, so now I am busting at the seams that you open up that FedEx package. We don't care how long it takes. This is my present to you for being so dedicated to me and the PCRI. I decided I want to show you not only how important I am, but when someone's important to me, the links that I will go. See what I wrote? My wife wrote that. Please do not open until Mark Moyad asks at the beginning of the interview. That's classic.
At the beginning of the interview.
Yeah, I emailed your wife also, I think. I was so nervous. So, I mean, that's sealed pretty well. You may need some kind of machete, but I think you're really going to enjoy this. And then this is the best way to start an interview I've ever done. Ever.
Yeah, well, it is well wrapped, I must say.
At the Moyad house, we use plenty of tape.
Yeah, this is the favorite of frustrating taping. It's all gooey and held down with tape that I probably can't even open. Did I bring a knife?
Yeah, if you have a knife or, if you have very strong pair of car keys.
There it goes. I found the solution.
I mean, you were a surgeon in another life.
Yeah, I don't think so. I learned not to be a surgeon when I was working on construction in college. And really? I found out very quickly that I was a very bad surgeon. Try being a carpenter and not being able to get a wall fixed. That's how I learned. All right, here we go.
Here we go, the moment of truth.
Voila.
What do you give the guy who has everything? You give him something that he doesn't have. And I figured it out 2 years ago during an interview, what you don't have. And nobody's ever given you a gift like this. Right. And there it is. So, see, let me explain this. When I interviewed him a couple of years ago, his dog barked. And I said, "What's the name of your dog?" And he said, "Doug." And I said, "What kind of name is Doug?" And he goes, "I named it from the movie Up." And I told him, "I know the guy that wrote that movie and was the voice of Doug. His name's Bob Peterson." So I made some calls out in Hollywood, and he did your family an autograph photo. The voice of the movie, the voice of Doug in the movie Up, Bob Peterson, wrote your family a personal note and I'll get you a photo.
He said, "For the Vogelzang family, thanks for naming your dog after me, Bob Peterson, otherwise known as Doug." Oh, what a great
Come
name.
on, honestly, do you love that?
I love it. Well, Doug, our Doug is not as smart as Bob Peterson's Doug. Our dog just looks at you and goes, "Give me food." This Doug is actually smart enough to figure stuff out.
I know, but how incredible is it that you named your dog after one of my friends? He's actually the brother of my best friend from college. And I called him and I said, "Google Nick Vogelzang. You've got to do me this favor." He goes, "Oh my God, this guy is prolific. This would be my honor." And so this guy has done everything at Pixar that you can imagine. If you look at Bob Peterson, he's done Doug Days recently from Disney. He did going back to Monsters, Inc. He's had voices and everything. He's had his hand in the writing. He's had a hand in the directing, and he had his hand all over Up, not just the voice of Doug. He was also the voice of the robotic dog. So you got to put that in your medical office.
No, this is going up in the wine room.
Yeah.
I got to figure out a place for it. I've got Zion National Park. I've got a wine room in France, and this has got an elegant spot.
I know, but you've got to admit, have you ever received such a great gift during an interview? This guy did Toy Story, Finding Nemo, Monsters Inc. He was the voice of Roz also in Monsters Inc. And
Wow.
I know, and he was a mechanical engineer at Purdue getting a master's, and he started to do comic strips. He gets hired by Pixar and ends up doing all these incredible things. So he was the voice of Doug and Alpha, co-director and writer of Up, and he's been nominated for an Oscar.
Holy mackerel.
So
I wish I was that good.
he's amazing. And it was incredible because I haven't talked to him since I was with him in a wedding for my friend, which goes back 20 some years. And he immediately texted me and said, "Of course I'll do it." And so I've never been so excited about giving a gift. So now Doug, your dog, is the most famous dog in the history of oncology.
He is a lovable big golden retriever who's not so smart. He fits the name Doug to a T.
That's perfect. So
it is.
I just can't believe it. So you just saw the movie and named him, and that was that simple.
That forever, my heart to yours. Thank you.
Thank you. Is that Diane?
Yeah, it's Diane.
Hi.
That guy was the voice of Doug.
Hi.
Yes.
That's
How are you?
Hi.
So
Incredible.
the guy who helped create and write Up and has been with Pixar during that whole run since Monsters, Inc. I stood up in a wedding with, because I was in the wedding of his brother. He's been my best friend since college. His name is John Peterson. So this is Bob. So
Awesome.
Bob's always been the famous one we like to hang out with. And I've never asked him for a favor. And I said, "You've got to do a favor for this family." And he said, "When, where?" And he FedExed it to my home in Ann Arbor. And then we just sent it to you. And I've never been so excited to give a gift.
That's so awesome. How fantastic.
On top of that, Mark is going to come out in the fall, and we're going to sit here, do our interview part 2, drink good wine, and Doug has to be hung somewhere.
For sure.
Yeah.
And you need to make sure he sees what the live Doug looks like, right?
Yeah, live Doug is not as smart as that Doug.
I gotta see what Doug looks like. And then we wrote all over it, "Please don't open." I've never been so excited to give a gift because 2 years ago when I interviewed him, I heard the dog bark, and I said, just randomly, I said, "What's your dog's name?" He goes, "Doug." And I go, "Doug? How did you come up with that name?" And he said, "From the movie Up." And I went, "Oh my goodness, there's a light bulb. I know the voice of Doug."
That is so
Isn't that
cool.
cool?
That's the
Right.
best thing ever. I'm so excited. I might be as excited as him about this.
She's going to put it up in her, she does counseling.
Yes. Yeah, because we looked at Diane, because my wife's a social worker, and she was running a clinic before she started coming she's now doing her art business. And so there was that affinity there I saw with Diane. And I said, oh, you got to write this to the Vogelzang family. Diane's going to love this. Nick's going to make it about the family. And he said, whatever you want. And
That's
so
great.
we were excited for the two of you.
Thank him so much, and thank you. That's fantastic. I love it.
Yeah, that was what was hiding.
Boy, that is that makes my day. I got to see Diane, your better half. And so thank goodness. All right. I'm so excited.
Thanks.
I'm so excited that you got to see Doug. And for people who don't know the movie Up and Doug, all you have to do is type in Doug, because now he's got a series on Disney, and you'll get to see this hilarious voice and how funny the dog is. And this was way before dogs became super popular in the past few years, right? I mean,
Right.
And he's such a lovable character. And I love this guy. This guy is so genius, and I love his characters. Anyway, so I'm looking under cancer on PubMed, and there's these authors that are saying, let me quote them. They're from Israel, and they said it was a major paper, and they wrote, there's been limited progress in the development of systemic approaches in the treatment of advanced malignant mesothelioma for years following the publication of the pivotal phase 3 trial of Vogelzang. This is what it says on the cover of their article. And so I realized, wait a second, you became famous in early 2000 for doing a phase 3 trial on mesothelioma and showing an effective therapy. Can you just give us a little bit of background into that, and then how you transition into prostate from mesothelioma?
I was doing lung cancer in Chicago with Phil Bonomi, a good friend of mine. And I took the job at Minnesota, being a fellow and a young assistant professor. And I was handed the lung cancer portfolio. And I saw probably about 12 patients, all from the Iron Range part of Minnesota. All of them had mesothelioma, and all of them had a connection to the iron mines. Well, taconite is the ore that the iron is in. And when taconite is busted up and ground up, you get this wonderful thing similar to asbestos. Makes the cement strong, and they use mostly the iron, but they throw the wasting away. And these taconite mines are filled with asbestos type fibers. So I wrote a paper about that. I had two patients who were twins, and they both got mesothelioma, which I thought was interesting. I drew a map of Minnesota showing all these clustered patients up in the taconite mine area. And so when I got to Chicago, there was nobody wanted to do mesothelioma treatments. So I said, well, I'll take it. I was, by that time, had been lured into prostate cancer again because of my work with prostate cancer and Charlie Huggins. So I learned a little bit about prostate cancer in Chicago, learned a little bit more. When I got back to the University of Chicago, they said, well, we want you to do prostate, but also want you to keep the mesothelioma franchise alive. And so I did. And, I published about, 20 or so papers. And once the prostate cancer activities took off, I stopped doing mesothelioma. I then hired a woman by the name of Hetty Kindler, and she took over the mesothelioma work for me so that I could become more administrative and more focused on prostate cancer. So I haven't published much lately.
This was the trial. I pulled it. It was a phase 3 trial. You published it in the Journal of Clinical Oncology to show you how much I do my homework. And this is why I have no life.
Good.
And what I thought that was interesting about your pivotal trial is it was a combination of two drugs. And one of the drugs, now this is going to come 180 degrees to my world. One of the drugs is a very famous drug. It has an anti-folate effect. So,
Right.
right? Pemetrexed, is that how you
Yep.
pronounce it? So this has an anti-folate effect. The reason I found that fascinating is that there's been a resurgence of studying anti-folate drugs or looking at anti-folate effects in other cancers, including there's been some work going on lately in Texas, at the University of Texas there in San Antonio. They're looking at the effect of reducing folic acid intake or folate intake in active surveillance patients. So can you comment on that? These anti-folate drugs, they've been around in other cancers. They're not going away. Is that correct?
Well, they were the first drugs developed for leukemia in the 1940s. And so the fact that they've never had a fair shake in a lot of cancers suggests that we still have more learning to do. And in fact, they're very effective drugs against just a whole range of cancers. And they work for benign diseases such as rheumatoid arthritis and variety of other inflammatory conditions. So yeah, it's a field that is still growing. And pemetrexed and cisplatin have now been supplanted in part by immuno-oncology drugs, nivo-ipi being the prime example. But now that doublet is still being looked at with pemetrexed, or vice versa. Pemetrexed cisplatin is being added to immune therapy. So it's a very active field. I mean, Joe Bertino, the first publisher of, no, I guess he was editor-in-chief of the JCO, our Journal of Clinical Oncology, was a anti-folate guru. So it's been around a long time.
Yeah, I think, don't you think it's made you a much better oncologist that you had some background in an area that wasn't prostate cancer before you became mostly urology-based, prostate cancer-based? Because there's so much going on around prostate cancer outside of urology, and it's so fascinating to keep studying it because it gives you all these great research ideas. But I mean, I hate to throw such a softball, but don't you think that to start out in mesothelioma and to start there, and then you transition, don't you think that gave you a little bit of a leg up or some kind of?
It did. I still, and then when I got to Chicago, they asked me to do mesothelioma, which is not a big load. Then they asked me to do sarcoma, which taught me a lot about sarcomas and other therapies. And then I got involved in starting up the phase 1 program there with Rich Shilsky and Mark Retain. And doing phase 1 is very humbling because it's such a tough problem, and you're trying new drugs in patients with refractory cancers. Many of them were prostate cancer, but many of them were kidney cancer and bladder cancer and lung cancer and pancreas cancer, you name it. So when you do phase 1, as I've done for 30 years, you get really a deep look into cancer biology and why does one drug work and why does another drug not work. And in my patient practice, I basically tell my patients, well, we're not giving up. We got 100 other drugs to try. Now they're not FDA approved for prostate, but it does give me always some hope that a drug which has not been heavily used in prostate cancer might work. And even today, I'm treating prostate cancer patients with drugs from the 60s and 70s because there's no other options for these guys. And they want to keep treating. And you can see the relief on their face. I go, oh, I got plenty of drugs. Don't worry about that. You just stay healthy enough for me to treat you.
I can't tell you how many people have called me and said, Vogelzang says he's got other drugs. And I said, that's part of the reason people come and see you from all around the world, because you always you always believe there's other options, there's other hope, you have all these things available, and people need those options. I think that's one of the reasons so many people have gravitated towards you. And that's funny because you say you go back to phase 1. So I have one last question on mesothelioma I just thought of. So basically what you're saying is mesothelioma, even today, is mostly or primarily caused from environmental stimuli, right? So it's environmental impact based on what you were saying about Minnesota.
Right.
Right. Okay. So has that ever made you think in your mind? Because we've never been able to really get our hands around it. In prostate cancer, do you think there's something out there externally? I remember in the old days at Michigan, they were studying, and not that they found some correlation in other places with Agent Orange and prostate, but where do you think the whole environmental impact with prostate cancer is?
It's at least 25% of the patients. The guy I saw late this afternoon flew in Vietnam. He flew C5. He was a navigator. He's got the most classic Agent Orange induced skin lesions that you have ever seen.
Really?
If no one maybe does understand that, but Agent Orange causes a very peculiar skin damaging effect. It looks like warts all over your body. And I asked him, I said, hey, did you get Agent Orange settlement? He goes, no, those damn blank, blank, blank administrators think I didn't get exposed to Agent Orange. And I said, well, all they've got to do is look at your arms and they'll know you got Agent Orange exposed. So I said, keep fighting and, get your disability for Agent Orange. I firmly believe that Agent Orange is one of the drugs. There's still genetics. 25% of patients have a genetic germline abnormality.
Mm-hmm.
And, then there's Agent Orange. We just heard lately that Zantac might be a cause for some prostate cancer patients. It's been withdrawn from the market because of its risk of prostate and bladder cancer. So yes, definitely real, hard to pin down on a given patient. But
wow.
When you hear these guys with Agent Orange exposure, you go, yeah, that was it. And it damages DNA. That's what the dioxins do. It's dioxin. They damage the DNA.
Yeah, they're DNA disruptors. I mean,
yeah.
Wow, that's a long introduction. I didn't expect to cover all that, but that's how we go. Sometimes we go off on these tangents. So I thought we would start my Q&A because we're going to jump all over the place in the next hour. I thought I would start. Do I want to start, I thought, with good news or do I want to start with bad news? So I thought, why don't we start with good news and just get that out of the way. And then we'll just talk a little bit. It's not so bad news. I mean, you're going to help us. You're going to clarify some things, but here's what I thought I would do. Here's the good news.
Yeah, that is good.
Lutetium 177 PSMA. Here it is, right? Can you explain what this is? And then can you tell me how long do we have? This is the next treatment that's going to be approved in prostate cancer. Can we agree on that?
Yes.
Okay. So this is going to be the next FDA approved treatment for prostate cancer. But they put the application into the FDA a little while ago, back in 2021. So how much longer do we got to wait? And what the heck is this? Can you tell the audience?
All right. So PSMA, prostate specific membrane antigen, is really a folate receptor. Remember that?
Yes. Oh, I was in Utah yesterday and I tried to explain that. It's a folate receptor. Thank you.
Right. And it's found on blood vessels and tissues of many cancers, but most commonly prostate. And so when you stain the cells, you see this PSMA positivity. And it took a while for everybody to put it all together. But then they figured out that if this is found on 96% of prostate cancer cells, maybe we could put a radiation drug on the PSMA and link it so that the radiation would go to the prostate cancer drug cell. And a little company in Purdue, at a spinoff of Purdue called Endocyte, took the first leap. They had developed anti-PSMA drugs. And so Dan Petrolak from Yale and I were among the first to use that drug. And it worked because we were putting chemotherapy right to the cancer cell. But Ron Messman and the team at Endocyte had bigger visions. They said, let's make this linker able to withstand the radiation effects. That's not a small deal because radiation loves to damage proteins, et cetera. So they finally figured out to get the PSMA far enough away from the lutetium, and they started their study. Well, Novartis was able then to buy them out, I don't know, billions of dollars, some large number, and they took over the phase 3 trial. That trial was called Vision, and it was a randomized phase 3. And Mike Morris and Oliver Sartor and a lot of really smart people did the study. And lo and behold, people who got lutetium PSMA better than people who got standard of care. Now, there are some doctors who think that the standard of care was not very good. Because many of the patients had already had everything. They had chemo and had radium, et cetera, et cetera. But no matter what, the people who got PSMA lutetium lived about 4 to 6 months longer than those who got standard of care. And the standard of care patients were allowed later to get lutetium. Some did, most did not. And the benefit was not just in living longer, but living better. They got less pain. They had less need for pain medicine. They had less need for radiation. And in general, it was considered a home run. The FDA, though, has been dragging its feet because the study, the Vision trial, needed to prove that the patients had PSMA on their cells. Well, it turns out you probably don't need to do that step, but Endocyte and Novartis, now called Applied Accelerator or something, I don't know, sort of a joint venture, did require that all patients have a PSMA scan, which is now pretty readily available. And the FDA, we don't know what the FDA is going to say. Is the FDA going to require that everybody get a PSMA scan? And that will slow the drug utilization down because, for example, we don't have a PSMA scan in Nevada. Well, I take that back. We got a scanner about 6 or 8 weeks ago, but it's not covered by insurance yet. And right now, people are paying $3,000, $4,000 out of pocket to get a PSMA scan or going overseas. So that's been the problem with getting lutetium PSMA approved. Now, on a slightly different angle, if you have PSMA antibodies, you can put anything on the antibody. You know, you can put new drugs, which Endocyte did, or you can take other radioactive compounds. So it's really a backbone for utilizing PSMA-directed therapy. Moreover, PSMA is found in other cancer cells, and many times I detect other cancers by the PSMA scan that I originally did for prostate cancer. In fact, one of my guys today had a PSMA scan. We found a lung cancer. Because why? It's got folate receptor in the cancer cells. So it's really a very promising thing. Unfortunately, it it cures some patients, but not many. But it makes almost everybody live longer and better. It does cause dry mouth and damages the salivary glands.
So when this gets approved, is it going to be the next few months? Is it going to be 6 months? But let's say in the next few months when this gets approved, who's going to get it? Is this going to be for people who are at the very latest stages of the disease, very advanced, has received everything? Are these people going to get it before chemo, after chemo? Like, who's going to come out and get this new drug that's going to get approved?
So my bet is it'll be this month.
Okay.
I helped Novartis with their marketing launch in California about 6 weeks ago, telling the sales force what this was about. And Raina McKay from San Diego was there and so on. So most of us think it'll be this month. I'm now taking all my patients who I think are candidates for lutetium and sending them to radiation oncology, because the drug will have to be administered every 6 weeks IV by a radiation oncologist who has to be board certified in the field and holds a radionucleotide license. So I think I've sent about 6 over there. Oliver Sarter's been treating, that's in New Orleans, has been treating patients on a compassionate use study, and he can treat patients. And there's other sites like that are treating patients in the United States with the compassionate use drug.
So there is a compassionate use program up for this drug now that people could look at all around the country, right? So I didn't realize that they have a compassionate use program up and running for that. So that means people.
Well, it's been limited. It's been very limited.
Okay.
Oliver's the big guy, but the guy at Omaha, I'm blocking on his name right now.
Yeah.
He's got a program where he's giving it with radioactive copper. So PSMA linked to copper might be another option. Any of the heavy metals, actinium, lutetium, and so on, might be also useful once they link to the PSMA.
Well, I've known for years there have been very desperate patients who've gone over to Germany. They've gone over to Heidelberg. They went and got lutetium. They got actinium, or they got a couple of the heavy metals. And now it's coming here. So again, can you just kind of, so at Nick Vogelzang's office, and you've been sending a couple people. So what's the makeup of these kind of patients again? I mean,
well, they're
the perfect candidate.
Yeah, they're usually healthy and have had multiple prior therapies. I mean, these are people who've managed to survive their cancer. So it's not usually bad cancer like liver or brain, but cancer that is resistant to the FDA-approved drugs. There's only 5 or 6 FDA-approved drugs. And once you're out of them and have tried them and they've been unsuccessful, you're allowed to give lutetium. Now, we don't know exactly what the label will it require what the protocol said on the VISION trial, or will there be some wiggle room? And I said that the big limiting step will be the cost of the drug. It's going to be very expensive. And the insurance companies are not going to just say, oh, here you go, I have $10,000 per dose.
So I looked at the original protocol of the New England Journal of Medicine, and I think it said the average patient received 4 or 6 doses, right? And then what happens after 6? You're done, or can you keep going?
Well, you run the risk of getting bone marrow damage by the lutetium. The lutetium is radioactive. and it can cause bone marrow problems. So we're not sure how long to go on the lutetium. It also causes the tear duct or salivary duct problems, dry eyes, dry mouth. And we're not certain what that means, how long that takes to go away. And the bone marrow might get a little weakened by it. So right now, I think most of us will stick with the FDA approval of 4 to 6. Insurance will probably enforce that because it is going to be expensive.
So you're excited. You're excited about it. It's and you know, for people who are just kind of getting into this, there's been a form of lutetium already approved for a certain type of pancreatic neuroendocrine tumor. It's called Lutathera, I think, Luta Thera. So it's been out there in other fields of medicine, but it's working its way into prostate. But here's what when I did an interview on this a year ago, I asked the question that I saw in the paper that it said something, I'm going to make up this number, but it said 85 or 87% of the patients had a PSMA scan. They had a majority. So then I thought, what does that mean? So that are you telling me that some people without a PSMA scan actually responded to this drug, even though they didn't have a scan, which is more predictable of a response? Are you saying that some people without a scan could theoretically respond to this?
Yeah, it's, when 90+% of the prostate cancer patients have PSMA on their cells, that's a pretty good number, and you probably don't need the scan to prove that. The problem is that some cancers evolve and they don't continue to make PSMA on their cell surface. Some of these cancer cells are evolving. Cancer cells evolve all the time. That's why some patients don't make PSA. Some people, prostate cancer goes to the brain. We don't know why. But the cancer cell may delete the PSMA gene. And I think that's one of the concerns the FDA has, that there will be use of a PSMA-directed therapy for cancers that don't have PSA on them. And that's been documented in a big study from Australia. So, we'll see how the FDA cuts that Gordian knot. And they may not come up with a great compromise. We may be left with do the PSMA scan on everybody.
Well, I mean, just to play the advocate from the other side, when they were doing the vision trial and you're getting these treatments, whether it's 4 to 6, I mean, are you seeing responses within the first treatment, or would it generally take many, many treatments to see anything happen?
No. You see pain relief right away. I mean, you see the PSA drop right away. It's not a subtle response. It's very strong.
Well, doesn't that argue that you don't necessarily have to have a PSMA if
You got it right. And I hope the FDA gets it right.
Wow, man, that is really interesting. All right, now do you want, oh, by the way, you're the first person I have come across in years that understands that the PSMA actually has multiple names. Glutamate carboxypeptidase 2, it's a folate receptor. People don't realize. So here's what I did so you can appreciate this, and the researcher in my head, right? I talked to the group in Texas, and I had them do a talk for me on this folate and reducing your folic acid. And mostly I was concerned about overexposure from supplementation, because some older men take huge amounts of folic acid and they're not sure why they're taking it. So we know that it's either doing nothing for you or it could be potentially encouraging things. So I said, what happens if one of these guys takes a ton of folic acid from pills and you got this folate receptor, PSMA, what then happens to the scan? And they said to me, that's a good question.
There's no answer.
Exactly.
But theoretically, it could make the cancer grow faster.
Exactly.
That's what we saw in mesothelioma, that if you took too much folic acid, the cancer grew faster. But on the other hand, in the pemetrexed work, if you had low folic acid and your cancer was starving to death for folic acid, the pemetrexed was gangbusters against the cancer, but also gangbusters against your normal body. So Kletnaya and I figured out that if you gave just the right amount of folic acid, sort of like Goldilocks and the Three Bears, if you gave just the right amount of folic acid, you could help the body from getting side effects. So it's now standard. When you give pemetrexed to lung cancer or bladder cancer or mesothelioma, you are required to give folic acid at 1 milligram a day. That's it, not 10 or 20.
Exactly. And so if you take methotrexate, these other sort of anti-folic, you take a little bit of folic acid, it can prevent toxicity, but you're not taking a mega quantity, right? So the question that has to be answered, so this is what I said at yesterday's prostate meeting in Utah. And yeah. I don't know if I walked out popular or unpopular. I said, listen, we're not going against folic acid. There's no question it reduces neural tube defects. And if you're thinking about becoming pregnant as a female, or you are pregnant, you want to take folic acid. What I'm talking about is if you're a 60 to 65-year-old man who doesn't intend on becoming pregnant anytime soon, this is what I said because I was passionate. I said, you don't need all this folic acid because it's either doing nothing, or it could be messing with the PSMA test, or it could be encouraging the tumor growth. And you just made my day because I walked out of that meeting going, did anybody hear me? Am I making sense or am I just?
No, most people don't understand the folic acid pathway. One of the reasons I learned it was because Rich Shilsky, who was one of my fellow faculty members, worked with Joe Bertino and worked in the NCI, and he's a folate guru. Now, there's not too many people who would consider that a compliment, but he is. He knows all about folic acid. We use folic acid in colon cancer therapy to prevent 5-FU side effects.
Right.
So we give folic acid analogs to prevent mouth sores. Mouth sores and diarrhea are the common causes of drug-induced side effects, and folic acid analogs prevent those side effects. So the world is still exploring that. It's been around a long time. I don't know if we're going to see any breakthroughs, but there's still more to learn. Always.
I just think there's a chance for interference in the scan but it has to be investigated. And I'm telling you, you made my entire interview night by covering this, because this guru in folic acid to me, that kind of person to me walks on water, because someone who knows the folic acid pathway is one of my heroes. So that's great. But there'll be more on this topic in the future. I promise you that, right? Because of PSMA, and it's a really interesting thought. Now, do you want to go to my not so good news?
Let's pick up some bad news.
So I wouldn't call it bad news, but I want to just say it's a little bit personal, because I'm traveling and all of a sudden I look and there was a trial, and I think it's important because this will move us into the next topic, which people are interested in. It was called the Viable Phase 3 Clinical Trial. Yeah, and your name was first on the paper. It was a Phase 3 trial, and this thing came out just February 10th. It just came out February 10th in the main journals. And can you walk us through, this did not work, is how I looked at it. Can you walk us through this viable clinical trial, why you think it didn't work? And then I want to ask you some immune therapy questions after that.
Yeah. So 8 years ago, maybe or so, the Czech researchers were studying a immune therapy. They were taking prostate cancer cells and making them express on their cell surface antigens that would stimulate the immunity against prostate cancer. And they had a small number, but maybe 25 patients or so, where the PSA went down and the patients got better. So they got some funding and designed this gigantic trial of docetaxel chemotherapy against docetaxel with the drug, and it was 2-to-1. So for every one patient who got docetaxel, 2 got the immune booster. It was given as an injection under the skin, and they got at the same time T cells, which were extracted from the body's blood. And so you got the chemotherapy, and then there was a fairly elaborate timing. So you had to wait just long enough, about 3 weeks, to get the immune stimulator. And giving them the T cells back also added complexity. And I sort of, at the time, I said, you guys sure you want to do this trial? There's been about 8 or 9 other trials like this where nothing worked. And this is pretty complex. And they said, no, we're going to press on. And then right after we started the trial, abiraterone, one of the new pills, and enzalutamide, another one of the new hormone pills, came in the market. And that, again, threw another monkey wrench into the works. But we've pressed on, finished the trial. It was mostly done in Central Europe, Czech Republic, Hungary, Germany, a little further west in a beautiful country called Ukraine, some in Russia. And at the end of the day, there was no discernible difference between chemotherapy and chemotherapy with the immune booster. So, it's just frustrating. A lot of effort, a lot of strong science died. And, it's a good example of how hard it is to make progress in prostate cancer. This was 1,000 patients who were willing to give up their time and treasure to volunteer for this trial. And it was negative. It was hard. We initially didn't get it published in the first 2 or 3 journals. And then JAMA Oncology said yes. And, it's in the literature now. Now, whether they'll be able to resurrect this immune therapy and make it work in prostate cancer, I don't know if anybody's got enough money and time to do that again.
But what
So
was
right now it's dead.
for the layperson, which includes me? For the layperson looking at this, what was the concept? The concept here is if you combine chemo with an immune therapy, you would just more likely get a home run versus by themselves, right? That they would be synergistic. That's the whole idea.
Right.
But here's the thing that's so funny about this, that's so odd, is that I just realized that in the past few days, the FDA approved an immune therapy as an adjuvant in resectable early stage non-small cell lung cancer. It's the first one approved, irrespective of the molecular status. In other words, could this just be an example that we're not using it early enough? I mean,
well, we picked a pretty bad population. They had already had their hormones, they'd had their chemo, or they had not had their chemo, but they had multiple hormone therapies. And, you never know. I mean, should you have started earlier? Look at Vision. I mean, they had the even more advanced patients, and they hit it out of the park. So when a drug works, it's going to work. And if this immune therapy was going to work, it was going to work in these patients. None of them had prior chemotherapy, so they were not that sick. It just leaves me with a strong concern that immune therapy for prostate cancer is still a long way away from fruition. We do not yet have a good immune therapy. Maybe a few patients with Lynch syndrome get benefit from Keytruda, but yeah, it's not very common. And so you just have to wait more time for a better immune therapy. Many people believe that prostate cancer is just intrinsically resistant to immunotherapy. I see doctors giving the drugs, but I don't see much benefit.
But so then what would be your comment as we kind of move out of this for a moment that you might not remember? I remember. When you first moved over to Nevada and Las Vegas, you invited me for a talk, and I went to give a talk, and you said, this patient wants to meet you. And I walked upstairs and I said, hey, how you doing? And he goes, do you know what I'm getting? I'm in a clinical trial here with Nick Vogelzang. I said, no, what trial are you in? He said, I'm in the Provenge trial before it was approved. And so then Provenge ended up, I'll never forget that. That patient was there getting Provenge while in a phase 3. The drug got approved. So Provenge is still the immune therapy that's out there that patients can get. Do you still use it?
All the time. And the answer is that Provenge may have been a window of opportunity drug. It was used early. It was used with no chemotherapy or minimal chemotherapy. And there were no follow-up drugs to muddy the water. And all the newer studies, we have drugs that are probably better than Provenge. And so although I feel a bit like a dinosaur giving Provenge, I still do. I have not been able to get rid of it from my mind because Phil Kantoff is a very good investigator, and he led the trial and it was positive. Tiagano, a lot of us didn't expect it to be positive, and it did show a survival advantage. So what do? Just say, well, that didn't matter. You can't throw it out.
Right.
You have to build science on another. So there is a study of Provenge with another immune stimulator. That study is smaller, and they're hoping that that will boost the Provenge immune reactivity greater and try to build on it. But Provenge has been struggling. I mean, they're just, it's hard to convince the company to spend a lot of money. They're not well funded anymore. They're living off their income, and when they go, when they do end up in a patent expiration date, there's probably going to be no competitors who want to take up that flag. The viable study was the closest thing to Provenge added to chemo, and it didn't work. It was not exactly Provenge, but it was similar enough to hope it would work.
So I don't want to belabor the point, but I just have to mention that I read that whole paper that you were first author on that just came out, the viable study. There were two things that struck me about the paper. One was over half the patients had Gleason 8 to 10 disease. Wow. Right? I mean, you're talking about really aggressive tumors. That was the first thing I observed. Second thing I observed is what you wrote in the discussion. I think it was the discussion that patients that had received multiple treatments, 10 or more, seemed to have a survival advantage. So any comment about those two comments?
It's just the luck of the draw. We took patients who were good, healthy, but they were cancer getting worse type patients. And that is the group that has Gleason 8, 9s, and 10s. And as far as the benefit is concerned, I think it comes down to, data mining. We look at subsets and we try to find a clue to what else to take or what else to do with this drug. But bottom line is this is the number 10 study that has not been able to improve upon docetaxel. And I think we just have to say that's where it stands. If the company wants to do another study, I think there will be interest, but there will also be skepticism.
Okay. So for those watching right now all around the world, when they watch this, Provenge is still out there. And who's Dr. Vogelzang's dream patient that should get Provenge immediately? So who do you target to give Provenge? Who says, "Oh, I definitely want to give Provenge to that person"? Like who? What kind of candidate?
Patients with rising PSA,
Okay.
who have minor amounts of cancer on their scans. They have to have some metastatic disease. Now, interestingly, my very first patient ever treated in Nevada, at the Comprehensive, not at Nevada Cancer Institute, is still alive 16 years later. Now, I don't think that had anything to do with Provenge, but I can't prove that it didn't. And some of these guys live a long time. And so I continue to give it. I am afraid to say too much positive, but these guys have cancer that's growing, and they want to try something. And Provenge is remarkably simple and safe. Mm-hmm. That's the one advantage. It's not going to lower your testosterone. It's not going to cause hair loss. It's not going to cause nausea and vomiting. And, we just published a paper, Tia Gano and Oliver Sarter and I, showing that it has some interesting effects, particularly in African-American men. Mm. And the African-American population, prostate cancer seems to be more immunogenic. And across the board, we saw that in our registry of over 3,000 patients in the clinical trials that were done. African-American men were relatively underrepresented, but they also seem to get the greatest degree of benefit. So there may be something there about their tumor antigenicity that we are stimulating. So, it's like anything else. There's still more to learn and still more work to do.
So it's fair to say it's right at the beginning of CRPC. They've become castrate resistant.
Right.
Minimal, right? And look what I had pulled in case you didn't mention it. It was your paper on African-American survival and how it was so profound with Provenge. And that's incredibly fascinating. I didn't even know this paper existed until I searched your name, but so I don't know how to explain that, or if you can, but
we don't have a handle on what are the main drivers of response to Provenge, but there are some amazing responses that are long lasting, and we should never throw that out. We should always keep that as an option for these patients.
Absolutely. I mean, we're talking so much now about health disparities and equal access to care. And so you come out with a paper like that, and regardless of what peer review thinks of it, it's observational. This is what you're seeing, and it's important to get out there.
Yeah, and we need to do more research into this. The immune basis for Provenge benefit is unclear.
Yeah.
As we learn more about the immune system, this may become very clear, but right now it's quite murky.
The only last thing I want to say about immune therapy, I think, is it's about COVID. This could have been, you can give me your observations about COVID, but I can give you many coming from a public health background. I thought what was very strange during this entire pandemic, and probably still is going on, is that cancer patients have to understand all their options the moment they get COVID, including monoclonal antibody treatment. And McKay did some of this work, and other people, where, these are vulnerable groups during the time of COVID. I just didn't understand for the life of me that whenever I looked at the vulnerable groups, 65 plus, diabetics, you name, I just never quite on many lists saw the name vulnerable group cancer patients. That's just my beef today. You can't imagine how many patients who called us and called me and said, well, I've had leukemia, I've had this. I said, well, if you ask your doctor about monoclonals, you got to get it within the first few days, ideally, and then they've shown that this helps. But can you comment on this? Why did I find this so frustrating? And can you set the record straight here that cancer puts you at a higher risk for COVID severity, a cancer diagnosis and during treatment, and including prostate cancer? And I'm just ranting and raving for a moment, but can you just have your comment on what I just said?
Well, the answer is we think that there is some underlying immune deficiency in some, but not all, prostate cancer patients. But that's the same across many diseases. Chemotherapy, we know, lowers your immune system, but we don't have a simple way to measure your immunity while you're dealing with prostate cancer or any other disease. So the guy I saw today he'd been treated for prostate cancer, metastatic disease. He's cancer-free now. His testosterone had recovered. His PSA was 0. He got COVID, and then his testosterone plummeted for no obvious reason. So his testosterone 6 months ago was 300. After COVID, 20-pound weight loss, his testosterone was down to 70. And I'm sitting here looking at this going, what's going on? Did COVID affect his testicles? If COVID affects your testicles, does it affect your immune system? It must, because it lives in your blood. The blood has immune cells, but we don't quite understand. The first cases of COVID occurred in some Dutch twins who had combined immunodeficiency syndrome, not quite that, but something similar. So, and 3 of the 4 died of that, 2 sets of twins. So I've always believed that the COVID virus is disproportionately affecting the immune compromised, and we don't know which people are immune compromised. That's the problem.
Oh, but I didn't understand why in all the groups of all the listings of vulnerable groups, I didn't know why, even though what the data was saying, you can even look at blood cancers, but why it wasn't screaming that cancer patients treated, going through treatment, are part of that vulnerable group, meaning get vaccinated. If you get it, we have monoclonals, we have antivirals, and I just felt like I was preaching that to the point where why aren't we seeing that on lists? So I don't know if you saw it on your lists.
No, I did.
You did see
I
it.
I had a lot of people come in saying, well, I have cancer, I'm susceptible. And the answer that I would give them was, well, I don't know how susceptible you are. I know that if you're getting chemo, you're very susceptible. I know if you have heme malignancies or stem cell transplants, you're very susceptible. But what does a 12 millimeter lesion in your prostate have to do with your immunity? I don't know. Does it affect your immunity? That's a cancer patient. Where does the line get drawn? So
I just think it was an awareness issue. And I think it's nice to hear that you heard the patients knew I have cancer, but I think there was just an awareness issue with monoclonals, or when a patient had COVID, hey, go home and rest, check your temperature, maybe have a pulse ox. I don't know.
No, it was, but believe me, at my end, I saw a lot of people become very paranoid about even though they had either no cancer, been cured of their cancer, they were exquisitely, just petrified.
Yeah.
So I think that was perhaps an overreaction. But again, we don't know the interaction between a little bit of cancer and COVID. We do know if you have a lot of cancer and are on treatment, that's bad, but we don't know about a little bit of cancer and how much that will affect your immunity to COVID.
But you agree, what we saw in ASCO and other places from many of the physicians you've taught and worked with is that if you've had cancer, chemo or not, and you get access to monoclonals of these treatments, you have a profound chance of surviving. You have a good,
absolutely.
Right? I mean,
the monoclonals and hopefully soon the oral antivirals will really make COVID a thing that looks in our rearview mirror. I don't think it's going to be with us much longer. It might mutate again, but we'll see.
Yeah, but if we get a subvariant and it mutates down to being a little bit more benign, well, we have 4 coronaviruses that cause 30% of the common colds out there.
Right.
They got to start from someplace. And so my hope is it just becomes another one of those, right? I mean, that's our dream.
That's what I agree. I agree it'll probably become that. But what I want to emphasize, though, is guys who have under active surveillance or have had surgery, or those guys are not at high risk. Now, whether the radiation treatment patients put them at higher risk is unknown. Whether hormone therapy puts them at higher risk is unknown, because there was the original paper from France saying that it protected them against COVID. And then the second paper from Cleveland Clinic said, no, there's no protection, but you're also not at higher risk. Mm-hmm. So, the data are, not clear.
So this is a perfect segue into the next topic. This is perfect. Chemotherapy. I just want to talk about it in terms of generalities, if you want to go into specifics. But first of all, since we just talked about COVID, when you're dealing with someone who's about to receive chemotherapy, are you adamant about just making sure they get their vaccinations, their adult vaccinations? I mean, is this something that in the oncology clinics that goes on? Because if you look at the data, 50% of adults, I'm being nice here, 50% of adults are even caught up with their adult vaccinations. I don't care if it's shingles, pneumonia, you name it. Is this something that is stressed before chemo starts because you're about to become immune suppressed? Or is that a dream world?
No, I always, in every one of my medical records, almost every one, not all, I guess, I emphasize to the patient, what's your COVID vaccination status? The difficulty is, like the guy I saw today, fully vaccinated, comes down with terrible COVID. Vaccinated in March, and by December, he's hospitalized, getting antibodies, and 30-pound weight loss, terrible. So, the vaccination has sort of fallen on skeptical ears because of patients like that, right? Mm-hmm. They did all the things right. They got their vaccination, and bang, they still get bad COVID. Didn't die, but he said he felt like he should have. And those are the problems when I say, well, should you get your COVID vaccine before chemo? And no, I don't. I just simply say, have you had your vaccine? And if the guy says no, I say, well, you should. You're going to get immune suppressed. It might help you. And then I have the COVID skeptics and the vaccine skeptics, and I'm not going to push them. I'm just not going to push them.
What about the guy who's 3 or 4 cycles in your clinic and goes, you know what? I want to get a COVID vaccine at this point. I know I'm in the middle of chemo. Is that something you say is fine? Or do you say, look, we're right in the middle of the process? I mean, how does that work with the person who decides in the middle of the process they want to get a vaccine?
I have no objections. The studies that have been done show that antibody production is still good. You don't get negative effects of being vaccinated in the middle of chemo. I've never seen it. Now, I'm not a public health or an infectious disease guy. The one thing I do worry about with the vaccines is that there's a pretty high rate of low platelets and blood clots. And chemotherapy does cause both of those as well. And the vaccine, about 20% get mild thrombocytopenia and some DIC. So I do warn them. I go, well, you might have some problems with your blood while you're getting the chemo, and the COVID vaccination might worsen that risk. So, I try to just be gentle and say, use your judgment.
Yeah.
But most of the people are now vaccinated before they start chemo.
Yeah. So just a couple of generalities on chemo, and I, for the rest of the time, nothing necessarily highly specific, because I want to get your take on this. Part 2, we can cover some of those other things.
Yeah.
But first, I want to ask you why, and this might just be me because I'm out there, but why is there still such a negative perception about chemotherapy and prostate cancer? And I will admit, going back 15, 20 years ago, I maybe said some negative things, but you finally look at data and you finally see, can you just tell us, there's a couple questions, you can answer them in any order. Why are we still playing this negative perception game when the reality is different? And maybe are we just not educating healthcare professionals as well as patients well enough in terms of the effect and how chemo has actually changed lives for the better in a lot of cancers? And maybe we just are late to the party with prostate. I just want your general commentary on why I'm still talking to docs around the country, my friends, who patients will refuse to get chemo because it's chemo.
Right. I have no idea. I think it's Jack Nicholson's fault. When he was doing the bucket list, you saw that scene when he's in the bathroom, vomiting and sick all night. And that's the perception that started with the words chemo. There was no antiemetics. There were no steroids. I remember those days when I was a fellow in Minnesota. We would basically give these testicular cancer patients platinum for 5 days, lock them up in their rooms, and just give them Ativan until they could barely move, because it was so nasty. And that collective memory, it's not an urban myth. Those were bad chemos. I mean, Hubert Humphrey, who was at Minnesota when I was there and had chemotherapy for his bladder cancer, refused chemo for that reason. Wow. He had to function as a public figure. So that history went on for, when did Gralla write his paper about Reglan? 1979. The first antiemetic IV was Reglan in 1979. Then came the other papers of olanzapine and all that. I mean, ondansetron. Those did not come up until the 81, 82 era. And when they became available, it was like night and day. Suddenly patients weren't vomiting. And yet, even with those drugs, this week alone, I had one guy who just, I don't know what happened. He just got really sick, diarrhea, nausea, in spite of the antiemetics. So the problem is the drugs are toxic, no question. Nausea medicines, anti-nausea medicines work about 85, 90% of the time, but it's that 10% that patients hear about through family, friends, Twitter, and so on. And they go, I don't even want to risk that. and therein lies the problem. The historical data were terrible against chemo. The antiemetics work really well, but not for everyone. And the other problem is that patients don't understand that there's 170 different chemos, and each chemo is different and has different nausea potential and different side effects. But usually once the patient has gone through chemo, subsequent chemos, Gevtana, carboplatinum, are much better. Then they're saying, oh, this is nothing. Let me come in, get my chemo, and go home for the afternoon. It's new now, but it's better.
I mean, I don't know if this perception will ever change in my lifetime, but it seems to me the history of chemo and prostate has been, okay, in early 2000, we're going to approve it, and we're going to give it to the very sickest, later stage. And now I want you to try to explain it to me, because no one's ever explained it well and been pithy about it, because I think it's not easy. It's now being used all over the place in prostate cancer, it seems, earlier and earlier, correct?
Yep.
So can you kind of give the layperson out there a quick summary of how do I know when to ask for chemo? Because it seems to be used all throughout the spectrum of prostate cancer lately.
Right. Well, we'll cover this probably a next meeting, but the best two papers that have come out have been from Karim Fazazi from France, looking at chemo, Lupron, and abiraterone. And the next best paper, New England Journal of Medicine, by Matt Smith, looked at Lupron, darolutamide, and chemotherapy. Now, the flaw of those two studies is that everyone got chemo. There was no non-chemo arm, but the people that got three drugs, Lupron, an oral antiemetic, and docetaxel, had superior survivals. I, for one, do not think that it's wise and good science to go back and look at Lupron and abiraterone compared to Lupron, abiraterone, and docetaxel, because that was done in the Stampede trial. And the Stampede trial said that Lupron, abiraterone was equivalent to Lupron and docetaxel. So then if suddenly Karim Fazazi comes out with a paper saying a 3-drug is better than a 2-drug, I think that's compelling. And we have evidence now that 3 drugs for relatively early prostate cancer, although still spread to the bones, is the way to go. But I have people turn me down all the time, Mark. It's the same problem. Guys saw 2 weeks ago, PSA 273, bone mets, pain, and nope, I don't want chemo. I said, you realize your likelihood of surviving more than 3 years is less than 20%? He goes, yeah, I'd rather have quality of life. Okay, what do you say?
Well, you say that in the patients that I talk to and the papers that I've read and my travels, that I've learned that when you get a PSA response and chemo is effective, sometimes you get a quality of life benefit, actually.
Well, you do. But
right?
Guys, this particular guy's PSA went to 0 when he got Lupron and Xtandi or enzalutamide. So he's sitting sort of in the catbird seat saying, well, my cancer is in remission. I don't need that chemo. And there is part of the problem. The hormones are still a very good alternative. Not as good, but still a very good alternative.
Then I'm going to play angels or devil's advocate again with this. So you don't want chemo. I understand the negative perception, but when you learn more about it, wouldn't it be fair to say that when it comes to COVID, what happens with viruses is they mutate, they want to survive, so they become less virulent. We know that. But cancer is different. It kind of goes the other way.
Right.
Right. So we get the other direction of the pendulum swing, where variants happen, resistance happens, almost like an antibiotic, where it becomes more and more aggressive. So what chemo does is it can go after some of those variants that are aggressive or before they become aggressive, and therein lies the beauty of something I never wanted to find beauty in, which is chemotherapy.
Right. Exactly right. If you give chemo early, it probably kills the worst of the worst cells. And, I can't prove that. That's the problem. I don't have proof that that's what the chemo does, but everything we have points to that fact. At some point, you get enough cancer cells in the body that those cancer cells have begun to evolve to bad cancer cells. And that's when the chemo is most effective. I'm now giving almost everyone that I can, pending insurance, 2 chemo drugs. I'm using cabazitaxel and carboplatin, and it's better tolerated than docetaxel.
So you're giving Jevtana and carboplatin, the trade name.
And Lupron or Leuprolide and an oral anti-androgen. That's above the standard of care. And I get a lot of turndowns from insurance. But if the insurance doesn't stop me, I'm firmly moving in that direction. Namely that if we could, leukemia takes 7 drugs to kill, lung cancer takes 3, breast cancer takes 3 or 4. So you need more chemo. And we now have at least enough evidence from Paul Korn and the folks at MD Anderson that those 2 drugs are better than 1 drug. So if it's better than 1 drug in the advanced setting, it stands to reason that it's going to be better in the earlier stage disease. And believe me, giving Jevtana and carboplatin is easier than giving docetaxel.
That is really interesting. That's another ditty for this entire interview. So patients should ask their practitioner about Jevtana and carboplatin, because those names don't come up together often, right?
No.
And okay, but all these people watching, I know so many of them right now hanging on to their seat going, I have a very aggressive tumor and we think it's in the prostate or it could be outside the prostate. Seems to be still early, but Gleason 8, 9, 10. Do I ask my practitioner, how early can I go before I ask my practitioner, my doctor, about whether or not I can at least get a couple cycles of chemo? When can I push that button? How early, in your opinion? No one has ever answered that for me, so you'll be the first.
I wrote an editorial about that and said that there are at least 2 or 3 studies that looked at early chemotherapy. One was James Eastham in CLGB. There was a French study, a few others, and they clearly show that early stage patients do get a benefit, but most of the patients do not. So we don't have a way to test who will benefit from early chemotherapy. We just don't know. And, we're going to be battling this for the next 20 years.
Yeah.
We just don't have an answer. So if our audience here says, well, I want to get Jevtana and carboplatin in place of docetaxel, there is a vast conspiracy that says, no, you cannot get those drugs. You have to take docetaxel first. And it includes the NCCN guidelines, it includes the insurance guidelines, and it includes very powerful academic people who basically would laugh me out of the room if I told them I was doing that.
I know, but I think it's something to ask. It's fascinating. So if you're getting that, at least ask. But I cannot, even though we're not going to spend that much more time together, I cannot let you leave here tonight, especially since I gave you the Doug gift. I can't let you leave because there's so many people hanging on this question. I have friends, Gleason 9s. They have it in the prostate. That's probably in the lymph nodes someplace, and they're being treated with everything but chemo. And the doctors seem to say, when I bring it up around the country, just ask your doctor. They say, well, if you want it, I think it's overkill. I think it's too much, but I would be willing to give you some cycles. And so don't you agree that if you've got a very aggressive disease early on and they're throwing a bunch of things at you, you got to also have the chemo discussion?
I agree. And the reason is that 25% of the bad cancers have BRCA and other mutations. And Heather Cheng, at WashU and SWOG are trying to get a study off the ground. It's been 3 years, they haven't been successful yet, of giving chemotherapy to BRCA mutation Gleason 8, 9, and 10 patients, neoadjuvant prior to surgery. Okay, so the study is designed, written, academically certified, but now it's got to fight its way through the CTEP and NCI hurdles. And we got to find the patients who are willing to volunteer.
Well, I get calls from people around the country that PCRI does. They're getting radiation. They've got cancer in the prostate, high Gleason scores, probably a lymph node positive here and there. And they're getting abiraterone. You know, they're getting the tons of energy from radiation therapy. They're also on Lupron. And the discussion of chemo, even if it's 6 cycles, has never been brought up in the conversation.
No,
and don't you agree that that's a disservice?
It is. You know, I always remind patients that you don't die from prostate cancer in your prostate or lymph nodes. You die from this cancer spreading into your bones, your liver, your lungs, and throughout the body. The reason to give chemo early is that there are those outlaw cells. We can't see them, we can't measure them. Someday maybe, but we don't know what they're doing. And those are the outlaw cells that chemo is hopefully, not always, but hopefully going to kill. And it's a leap of faith. It's logical, but it's still a leap of faith. And most scientists, most clinical scientists are very conservative, and they don't want to run the risk of, quotes, overkill. And I go, well, you know, if you got a Gleason 9 and node positive disease, I'm going to give you chemo, and I'm not going to rely just on hormone therapy.
I love that. That's the Nick Vogelzang school of chemo that I have always been following. I've been drinking that Kool-Aid since the first day I met you, but it's true because we got caught up in the early days saying more men die with prostate cancer from it. But in your line of business and what PCRI does, you see so much destruction by prostate cancer that if you have another quiver, even Scholz will say this, if you have another arrow and you can use it, and because you only get so many cracks at this thing, it's got to at least come up in the discussion. So my whole day was made by this discussion because just more people will bring it up with their doctors. Whether or not they do it is not the point. I just think it's an awareness issue.
It's an awareness issue, but it's also a knowledge issue that prostate cancer is 5 different diseases, grade 1 through 5. If you got 5 cancer, a Gleason grade group 8, 9, or 10, those cancer cells are itching to kill you. Don't let it happen. You've got to do more than just sit back and say, oh, surgery or radiotherapy will take care of it, or adding hormone therapy will take care of it. Those cancer cells are damn smart, and they're going to get around the blockade that you throw up with hormone therapy. Not everybody. You cure a lot of people, but it's the ones you don't cure that should burn in your memory.
Yeah, and you're talking about a short course of chemo here. It's a very short course, then you're done in some of these cases,
Yeah.
like 6 cycles. And I think a lot of people will call and say, I heard all these terrible things, but this is 6 and I'm done. And I just feel better that I threw something at
Do
it.
this for breast cancer all the time.
Oh man, this just makes my day. So I'm going to ask you one other question I've never asked you, and all I need is the simple answer. And of course, I know the answer, but I think you have to. I just want you to explain it from the Nick Vogelzang standpoint. Why do I have to take a steroid with chemo? Why do I got to take prednisolone or prednisone? Because you hear all these terrible things about steroids. If you look at the side effects of steroids, you go, "Oh my gosh, why is he giving me a steroid with my chemotherapy?" Can you just give us the Nick Vogelzang answer as why steroids are always given with chemotherapy?
Well, we use it for nausea, but you don't have to take it for very long. You only have to take it for 4 or 5 days. For abiraterone, it prevents adrenal insufficiency. So abiraterone knocks out your adrenal glands to some extent. 30% of people really do need methylprednisolone or prednisone. Because when we randomized patients to the question, they were found to need the prednisone in some percent. But I start my patients on the abiraterone without prednisone. I give them a prescription for it. So I say, if you get hypertension or fluid retention, which is a sign of adrenal insufficiency, then I want you to start your prednisone. The insurance companies are forcing us to give prednisone with abiraterone.
I want to ask you about something I've never asked you, which is people become obsessed when because a lot of patients now just look at their labs, right? They want to look at their labs. They want to get a copy of their labs, but we become fixated with the PSA. Is there another lab test in the area of prostate cancer you think patients should really kind of look at when they look at their own lab results every once in a while besides PSA? I mean, are we talking about LDH, alkaline phos? I mean, is there another lab test that you kind of think that patients should just know about while they're being treated for prostate cancer?
Yeah. Susan Hallaby and I and Eric Small wrote a paper in, 2010, 2008, when we looked at PSA as a predictor of who was going to do badly. And people assumed that the higher PSA number, the worse. Not true. The worst are the low PSA producers. And in fact, a combination of blood tests using alk phos, LDH, and clotting parameters, D-dimer or fibrinogen, give you a much better predictor of how bad the cancer is. So I try to explain to patients, don't fixate on the PSA. We have better tests than PSA, and it's unidimensional to look at PSA. For example, we're doing this study with CAR-T, not CAR-T, but BiTE therapy from Amgen. And what they want to do is every time I see the patient, we have a full coagulation parameter, D-dimers, fibrinogen, et cetera, LDH, alk phos, and the PSA they only do every 2 months. They don't even care about the PSA at the beginning of this immune therapy. So I think we're over fixated on PSA.
Wow, I didn't expect that answer. So the 4 you mentioned again: D-dimer, fibrinogen, alk phos, I think you said, and LDH. And you watch those to see the direction they go in. And if they're going into let me put it this way, a positive, a healthy direction, that bodes well for you.
It does. Yeah, if I didn't have PSA, I would still do LDH, alk phos, and a clotting parameter. The clotting parameters are probably most interesting because they tell you that the prostate cancer cells are activating your clotting system. And that means there's a lot of cancer cells. So many years ago, when I wrote about circulating tumor cells, Lou Fink and I at the Nevada Cancer Institute wrote a paper showing that if you have a high number of circulating tumor cells, a surrogate, a very good surrogate, are the clotting factors. But nobody does those in real life. They all look at PSA and say, "Oh, it's going up." I go, "Well, relax. It's not a very good test."
That is really interesting. So for example, fibrinogen D-dimer starts to increase. You're seeing a lot of activity with clotting factors. It could be that the cancer is gearing up, right?
Exactly.
Or it's starting to do more subtle damage that's being picked up by these other tests.
I mean,
I have never heard that before in an interview.
Yeah, the clotting parameters are a secondary result of prostate cancer cells in the blood. And when they activate and the clotting factors start going up or down, it compensatory going up and down, meaning the cancer is winning the battle. You better be careful.
That's interesting. You just brought me a PTSD flashback from med school when one professor said, remember Virchow's triad? I think it was Virchow's triad.
Virchow,
remember
right.
that? That explained when clotting was happening, that could be due. Basically, I'm paraphrasing that, cancers can make things go wrong cardiovascular wise. And
that's probably why we get heart attacks.
Yeah.
When there's advanced cancer, the clotting parameters stimulate your cells, your vascular endothelium to probably go haywire. So it's very dangerous, and people go, that's not related. And I go, no, it is related.
No, it makes complete sense. Fibrinogen, D-dimer, and then, tissue and bone damage, LDH, right? ALK phos. Those are basic tests.
Lucky Laura just wrote a paper that was from SWOG. We looked at hormone therapy, and the best predictor of outcomes were related to bone blood tests like ALK phos and clotting parameters.
Wow. And so, but that probably again, we're talking about more advanced patient, right?
Yeah.
As the disease become more advanced, these other little hints out there provide not just hints, but shouts, right?
Yeah.
Wow.
Yeah.
I love that. Okay. The last questions I had is that, can you leave us with one of the greatest miracles or responses you've seen lately in the clinic? Can you just give us a summary of it? Have you had a patient recently where you just went, what was that?
Yeah.
Can you share that with us?
Usually the best results are with the genetic abnormality patients. BRCAs, BRCA1, Fanconi anemia, PAL-B, CHEK2. They have tumors, although they're wired to grow fast and speed through the body. When they get hit with chemo, those cancers melt. And, it's impressive. A platinum-based therapy for some of these patients is life-saving. And so, these are the patients that I actually look for. I say, you've got a BRCA. And the patient goes, oh, I hear that's bad. And I go, yeah, but it's also their Achilles heel. So that will tell me that chemotherapy, radium, lutetium, DNA damaging agents should be tried. And you get a great benefit in those DNA damaged patients. Not everybody, but enough to make you go, those patients need chemo. And the BRCA mutation patients should get it more ahead of time. They should get it early and often.
So these BRCA 1 or 2 patients, when you're saying, oh, you've got a BRCA, is this coming from germline? They were born with this? Is this coming from tumor, or are you testing both?
You test both.
Okay, so you're always you're testing what they were born with on a blood test or a cheek swab, and then you're also testing part of their tissue. So
Yeah.
you're just looking for it. You just want to
I
find
look for it all the time.
And
It's
so
it's the one test I think that if I find it, I can convince the patient to get chemo. We don't have a lot of other ways to predict for benefit of chemo, but that is a predictor of benefit. It's the Achilles heel of the cancer. It grows fast, but you can find it. And I mean, I have a Fanconi anemia guy who has just littered with cancer in the family, leukemia, breast cancer, brain tumors. And he's an artist from Chicago. And I told him, I said, let's go for broke here. He had it in all of his bones. PSA was 800. That was 5.5 years ago. Cancer free. PSA 0, LDH and alk phos 0, and bone scan negative. So he would be considered a complete responder. They're not common, but I think it's related to his DNA deficiency, his Fanconi anemia gene. It made the cancer exquisitely sensitive to not just chemo, but also the hormones. I gave him radium as well, because that's a double-stranded DNA breaker. But that's one example. There's others. And so you hope these people do well. I had another guy, Army vet, who had filled his liver. He looked near death. And Scott and I had this chat. He couldn't even really get out of the wheelchair when I first saw him. But then I found out that he had an ATM mutation. But before I started him on therapy, I told him, Scott, I'm going to make you sicker than stink, but we're going to try to beat this. And his liver has remained cancer-free for 3.5 years.
Wow.
With chemo and hormones. So you got to look for the miracles, and you really have to expect the miracles. You know, you shouldn't be timid. If you're going to be brave, be brave. Just say, we're going to do this. And you reward yourself with some spectacular benefits.
Yeah, that's an incredible story. And you mentioned Xofigo earlier, the radiopharmaceutical that's FDA approved. It's exquisitely sensitive to those, right? I mean,
well, Evan, you and I have talked about that. We're still not 100% certain that it predicts the benefit of radium, but we have enough anecdotal cases to say that a BRCA mutation or another type of mutation does predict for benefit of radium. And therefore, it also should predict for benefit of lutetium, because lutetium does the same thing as radium.
So then my last medical question is going to be at a prostate meeting I was at, where, sometimes I just get up and I sometimes regret what I say, but someone said the game of this meeting was people wanted you to predict where we were in 5 years. And I said, from my standpoint, if you want to know what I believe, this will be interesting. This is an extension of your answer. I said, I don't understand. We have all this genetic testing going on, germline and somatic. We're testing the tissues, you're testing the blood. Vogelzang tests all these advanced patients. Why don't we just test everybody when they're diagnosed? Why not when you're just newly diagnosed to check whether or not you have a mutation in BRCA1 and 2? See, if we do that in breast cancer, nobody says anything. We haven't had prophylactic mastectomies. But I just don't, can you leave me with this then? If everybody's getting tested later on for all these genetic mutations, especially BRCA1 and 2, we agree. Right. Why not just get tested when you're diagnosed?
Well, part of it is that there's this problem of age in prostate cancer. And many men don't make it long enough to get that benefit of the drug. So the 88-year-old retired sheriff I saw today, I'm ordering a genetic test. I'm ordering BRCA on him. But, is that going to change my management of him? He's got widespread bone metastases. Am I going to give him chemo? Well, maybe. And if he has BRCA, the answer is yes, I will, even though he's 88.
Israel did a study of all these active surveillance patients, and it wasn't a small number. They were active surveillance, and they were coming up BRCA too. And I'm thinking, I'm sorry, but I know they don't know the answer yet. But if I'm active surveillance and I come up positive BRCA2, it should at least be part of the discussion whether or not I still want to stay on it. I mean, I'm just saying, so you see where I'm going with this?
No, I get it. Right.
So are you in the Moyad camp, or are you saying not yet?
I'm in the Moyad camp because they harbor the seeds of their own destruction. And you want to know that ahead of time. The sooner you know it, the better. Now, would it be good for Gleason 6, grade group 1? I don't know.
We don't know.
But
could be harboring something else sitting in there.
Right.
We can't find it all.
The guy I saw this week again, 3 brothers with prostate cancer. He's got Gleason 6, grade group 1, and he's only in his early 50s. And I said, sorry, but you should have your prostate out. You're just sitting on a potential time bomb, and do it right. Get your prostate out and be done with it before down the line, the guys who want to do active surveillance. And I said, no, I don't feel good about this. Not because of the gene, but because he's got 3 brothers with prostate cancer. Right. So there's the dilemma. You can't always rely upon genes because we don't know every gene that causes prostate cancer. I mean, we have a list of 13. Is that going to be all we ever get? I mean, the new genetic profiling is so powerful that we can go back soon and look at all of these families that are many families with prostate cancer of 2 or 3 generations, and they're gene negative. The test is negative. And you say, something's not right, but we don't know what gene is broken. So you got to start thinking that the genetics have to get stronger and better as well.
But you have to agree that there's some that really scream. They don't whisper. And BRCA 1 and 2, they scream.
Oh yeah.
Right?
Oh yeah.
Right.
Yeah.
So guess what? 23andMe or another company for women, you can get it OTC. You can over the counter.
I know.
So
crazy.
If you're out there making OTC for prostate cancer, you'll make a fortune.
Yeah.
I'm saying someone watching, right?
There's your next company, Mark.
I don't. This is my only company.
I know.
I don't have a side. I wish I had a company. I would have retired long ago. All right. So that's the end of my medical questions. I leave you with 2 softballs. When last time I saw you in Vegas, you and I had dinner at the Vintner Grill.
Yeah.
And you said it was one of the favorites, and I loved it. It was awesome. In fact, I've been there twice in my life. Both times were with you. What's your favorite? I don't even know if it's still open, but what's your favorite restaurant in Vegas if people are going to get back to real life? Which one do you recommend now?
I'm going with one owned by my friend. It's called Marche Bacchus, Bacchus.
Okay.
Marche Bacchus, French. It's got a built-in wine sales. You walk in the front door, they have about 400 or 500 different wines for sale, along with eating on the outside overlooking a lake in Las Vegas. It's just lovely. And in the winter, it's enclosed. They have fire going on. In the summer, it's a little warm, but they have sprayers and misters, and it's just still my favorite restaurant.
Wow. Marche Bacchus?
Yep. They say Marche Bacchus, but
yeah,
Bacchus.
Yeah, Mercy Buckets. So that's the place to go. Interesting.
Yeah. We go to Vintner's Grill because it's very close.
Yeah.
But it's also owned by my neighbors, so I got to go there once in a while.
You know everybody in town. Well, I'll leave you with we did a paper in 2015 on statins.
Yeah.
And it's looking hotter than ever. That paper looks like we had foresight. You know, we talked about statins, metformin. And, you know, of course, we're not saying that they'll change your prostate cancer. We're saying that they're at least heart healthy. And I still see how many downloads that people have downloaded our paper since 2015, and I've lost count. So I'm really proud of that. That's my claim to fame working with you.
I ask every single patient with prostate cancer, are you on a statin?
Mm-hmm.
And most of them are not. But then I send them to the cardiologist and say, get a cardiac workup and then come back and talk to me.
Good for you.
Still a high issue problem, not well addressed by most urologists.
High issue problem. And as I gave my lecture yesterday, I explained that they had their best year in the history of me following this in 30 years, causing plaque density, calcium density. In other words, reducing the risk of a plaque from breaking off. We now have that data. There was a finished trial in the past few months that showed it might reduce the risk of non-significant cancers, looking at a randomized trial from Europe. This is all in the past 12 months. The largest review of reducing the risk of biochemical recurrence, looking at some over 10 studies, concluded that it might be a good thing to take after you've been diagnosed. We know it reduces the risk of heart attacks, certain types of strokes. And now the U.S. Preventative Services Task Force is going to agree in the next few months that taking a statin might actually impact your all-cause mortality in primary prevention. Name another pill that you take when you're perfectly healthy that extends your life potentially. We don't have it.
But remember, the other thing we talked about earlier was coagulation in prostate cancer. What do statins do? Stabilize the plaques and get rid of the plaques that are the starting point for clots and potentially prostate cancer dissemination. So we're on the same page still.
Absolutely on the same page. Statins they're basically the new aspirin. They're probably going to put aspirin out of business in primary prevention because it does everything right. And it does everything and safer. In our paper, we were excited about aspirin, but I'm not as excited anymore because statins are doing everything that aspirin wanted to do, but safer and better.
Yeah, couldn't do it. They can't lower the cholesterol.
That's
the
right.
Brain. Well, you get the point. So do I.
know. But it's a good way to end the program, that drug repurposing and looking for answers in other places. And you know what? I apologize that if you take a statin and all it does is reduce your risk of dying from the #1 cause of death in America, which is cardiovascular disease. I apologize if that's all it does for you.
Right.
Like, come on, man. Come on. Anyway.
I have to step it up.
Yeah.
My game is slipping.
All right. So did we miss anything? But that's part one. Part two, we're going to cover my myths and misconceptions. It's going to be no slides either on part two. It's just going to be wine in your basement. And I'm going to take you through a 30-year career, 25 years at Michigan, of all the myths and misconceptions I've heard out there. And I want to see what your thoughts are about them, whether they're true or false. And then we're going to take a lot of questions from the PCRI audience for the next time we meet.
Wonderful. I look forward to it.
Me too.
Mark,
Thanks for everything.
I'm sorry I made you stay up so late.
That's okay.
But this is fun. It's learning experience.
It is a learning experience. You got to understand, for a guy like me, even though I'm getting old, I mean, I'm get to interview a legend. I mean, plus, I know you can't comment on that, but a true legend in the field who is just as sharp and just as active as he's ever been since the day I met him. And so I don't care if you would have asked me to stay up till 4 a.m. I don't give an S. I'm not going to use the word. I would do it.
Well, the answer is, number one, curiosity. I'm endlessly curious. Number two, I've always been eclectic. I don't believe a lot of what I read. A lot of it is sort of made up. And I'm very questioning. That's why I did the viable study. I didn't think it would work. The company said, "Oh no, we're sure it's going to work," and it didn't. And I sort of chuckled to myself. I go, "Well, I told you." But it's what we do in science: test the theories, test. And as University of Chicago's motto is, "In God we trust. Everyone else bring proof."
Well, I mean, it's all the negative trials that led to the positive trials, right? I mean, I hate to put it that way, as such a glass half full, but it's true. We've had more failures than successes, but those failures allowed you to adjust the strategy. I mean, you've taught me this, and then you get to the answer, right? You get there. So
exactly. Well, I'm going to go grab some dinner.
Yes.
And have a good glass of wine.
Yes. Have a great glass of wine.
And I will see you next fall.
You'll see me at fall in your house. Tell your wife I'm honored to meet her, and I think the work she's doing is amazing. And also tell Doug, I love him.
I got it sitting on the wine table right now. So I'm enjoying Doug. I forgot he was that big a nose.
All right. Well, all the best to you. Lots of hugs. I'll talk to you really soon. And thanks again for everything you do. And you know what? I actually forgot. I made a sign for you. See? Thank you for all you do and for just being you.
Well, thank you, Mark.
Yeah, took me about 10 seconds.
I love being I love doing what I do, and I love being me. So thank you. Thank you. Thank you. And thanks to the PCRI for all their work. I mean, they've been a wonderful help to a lot of our patients.
Yeah, no, I appreciate that too, because, and I want to give a quick shout out to the PCRI audience and let you know, I can't tell you how many times over the past 20 years that somebody said, we can't go further. And they went and saw Dr. Vogelzang and he said, I've got other things. We can try them as long as you're willing. Because I get so sick of that story of somebody sent me home 6 months, put your affairs in order. You've heard that story. And sometimes, people, it's just a story that gets repeated a lot. But the bottom line is there's always people willing to keep trying if someone wants to try. And I think what I have always heard is that if you go see Dr. Vogelzang, he'll tell you how it is, what's really going on. And if there's other things he can use, if he can, he will use it. Right.
Well, shout out to Mark Scholz because that's what he does too.
That's exactly what Mark says.
We're kindred spirits in that respect.
That's so true. And, there couldn't be 3 more different guys on this planet. Mark Scholz, myself, and you. We occupy such different planets. But I really think what brought us together is this concept that if you can get me up to bat another time, well, damn it, I want to find the guy who's going to get me up to bat one more time. I want to know who can help me do that. So I have people seek out you and Scholz, and that's what you guys have in common. Right. You don't give up. If there's hope and there's a chance, you don't give up.
Yep, we agree.
All right, have a great glass of wine, sir. Enjoy your gift. Tell your wife thank you for letting us take your time, and I'll talk to you soon.
Okay, see you, Mark.
Right. Bye now.
Okay, here's the moment we've all been waiting for. Dr. Mark Moyad with the University of Michigan, our beloved PCRI moderator, and Dr. Mark Scholz, the executive director here and founder of PCRI. I love when the two of them get together. Their brains are so powerful. They have so much information on prostate cancer, but they're able to contextualize it for all of us. They're able to help so many patients, and today they're going to be answering our questions. They're going to be reviewing the previous presentations from the last 2 days, and I know that I will find it educational, and I hope you do too. Here they are, Dr. Mark Scholz and Dr. Mark Moyad.
Welcome to the final chapter, the final stage of the conference. We entitle it the Moyad Scholz Free-for-All Questions, Bring It On. And we just kind of go for 2 hours. We don't know what the HE double toothpicks were doing, but we just go for 2 hours. Isn't that correct, my friend? In fact, since we don't know what we're doing, I thought it'd be interesting to, I don't know if Alex can hear me, I thought it'd be interesting to bring up the fact that you just had a birthday. Is that right?
Yeah, I got past 66. So each extra year, this is a wonderful thing. Living in Southern California, still able to go to work every day. So
yeah,
I'm great.
And today I went running in the snow, and you probably are in the sun, right?
You can see it's a little overcast today for California. We're hoping the sun will break through later.
Oh, don't worry, it will. You guys are the hotbed of global warming, so it's probably going to be 105 as a low today. Happy birthday, brother, Doc Scholz, right? Because I missed the sign. And if I really want to be sarcastic and just have a good time with it, I was going to give you my other sign that said, happy birthday, happy 95th.
Well, that's what we're all shooting for, right? That's
Exactly.
really, that's kind of the theme of this as we care for aging men. Not only get to 95, but still have fun too.
I agree. Have quality of life, not just quality. So I thought, you know, I got to admit something to the audience that they don't know, that many years ago, you were kind of high and excited about this whole YouTube thing. And I thought, the guy's might be a little caca. Maybe we just do stuff in person. We don't do stuff on video. And I gotta tell you, you called it. I mean, this thing turned into this gigantic thing, whatever you called it. So we just want to say happy birthday because we're all family, because I appreciate you, and you had incredible foresight. So we're going to bring you out a gift that I guarantee you that I know for sure that you've never had. It's quite expensive, and I want to see if you like it. So let's bring his gift out, please, and see.
Oh
if you
my
like
gosh.
it. How do you like it? I got you a red jacket.
Now maybe, do you think it'll fit?
I think it will fit. Isn't that beautiful? I mean, you've been wearing all these eccentric colors lately, really loud colors that when I turn off the light in my office, you still glow. So I thought what we would do is we would go into your closet and we would pretend like we bought you a new red jacket and give you your old red jacket.
Oh, so it has to fit. Actually, I have more than one red jacket. Can you believe that? So I wasn't immediately sure that you weren't robbing my closet.
I'm sorry. This was the greatest gag I used to do to my kids. I used to go to my kids' drawers at Christmas time, wrap up some of their socks and underwear, and then give it back to them.
Well, I didn't have quite the cojones to just jump out here with my red jacket, but now I can blame it on you. So you're going to have to suffer with this the whole time now.
It's okay, but that's not all. Wait, there's like an infomercial. There's more. I guarantee you, you have never received what you're going to receive now, and you will, I think, cherish it, and it's quite expensive. What the audience don't know is that 5 minutes before we went on air, Mark Scholz was saying, boy, it would be great to have a Blue Star donut. I've never had one. And I said, we can have one in the fall. He had no idea he was going to get some. So you have now actually had a Blue Star donut recommended by many of the docs at LA, including UCLA. Happy birthday, brother.
Thank you. Thank you. And if I get hypoglycemic, during our talk here, I'll be more than prepared now.
Well, the incredible staff at
those are beautiful. You know, I was telling you before we got online here that I didn't even know about this place, and I can literally walk to it from my office.
See?
So I don't know that you've really done me a favor, Mark, because I do have a little bit of a sugar tooth.
I know, but you need to put on a little weight. You get skinny from those tennis matches, but I just want to show you. You could see the fatigue. You could see the fatigue already seep in. I said, and thanks to our wonderful staff at UCLA, and it's not UCLA, it's PCRI.
Those are good too, by the way. Being a donut connoisseur.
Yeah.
Those are good.
Yeah, these also come with the treadmill, I think, and we will cherish them. Now that we have our glucose levels intact and we have caffeine, shall we get started on the speakers? We'll go through them one by one and tell me, and just kind of go through the highs, the lows, and the middles. Does that sound good?
Yes, indeed. We're going to jump in with Dr. Cooperberg, right?
Yes, sir. Dr. Matthew Cooperberg of UCSF. He is chair at the VA. Plus, I still think he could be chair of almost any department in the country if he wanted to. I always tell him that, but he doesn't listen to me. And he's an active surveillance expert, and he kicked off the conference. And what say you about Dr. Cooperberg?
Well, I mean, we could have built a whole conference just around Dr. Cooperberg's talk. I mean, he covered everything, and he covered it in a lovely, balanced way, which is what we have to do with active surveillance. And because there's a lot of trade-offs. I loved how he said they're working on trying to rename Gleason 6. Gleason, or Epstein grade 1 disease, is not even being a cancer. There's never a history of it ever spreading outside the prostate. And this is half of the men that are diagnosed with prostate cancer every year. If you look at maybe 180,000 men being diagnosed, 90,000 of them are going to have Gleason 6, a variant that never spreads and shouldn't be treated. So he presented some nice slides about how only 60% of the men that have that type of prostate cancer, if 60% of 90,000 would be what, about 50,000 men, are getting treated with active surveillance, as they should be. And he showed how this has improved over time. Now we're up to 60% of men that don't need treatment, aren't getting treatment. Hallelujah. The sort of sad thing is, you're saying in this modern era, 40% are still getting unnecessary radical treatment. If the treatment was innocuous, if it didn't cause impotence and incontinence, it would probably be fine. We don't really need our prostates in this age group, but it's still, we've got a long ways to go. I tend to see those men who are unnecessarily suffering from treatment, and awareness is really what it's all about. That this Gleason 6 stuff really isn't cancer.
If we have a long way to go, then that's why, even though he wasn't initially advertised as wanting to do it, I forced him to do this, like I forced you to do a lot of stuff through basically emotional turmoil. And so what I said to him was, and I want to hear your opinion on it. I go to these meetings where people get up and go, look how great active surveillance is. All these men are on it. And I'm kind of going, I'm happy, but I'm not happy, because I'm not happy because maybe we should be doing better screening. So I started asking him questions of just about screening. Who would we screen? There's that new study that came from USC that said there's now more metastatic disease popping up because we haven't been as aggressive on screening. And so what were your thoughts? What were your thoughts about screening in terms of his comments? And what are your own personal thoughts about screening before we talk about active surveillance?
Very important. I mean, again, we could do a whole conference just on that topic. And he covered it, very incisively, talking about how PSA as a screening tool, obviously, is the de facto standard, but it's being used improperly. And I love how forward he was about saying that if we are looking at PSA in this modern era, what we really want to see is men starting screening in their 40s or 50s, and we want them to have PSAs less than 1. We've always heard 4.
Yeah.
And say, well, less than 1. What are we talking about here? This sounds ridiculous. We're going to end up doing a lot of unnecessary biopsies and these sorts of things. But it turns out that's where PSA is very accurate. That if your PSA is less than 1, you could be very confident that you don't have a bad cancer lurking in a corner of your prostate that's going to spread and hurt you. And so so what do we do to try and mitigate the need for unnecessary biopsies in the people with PSAs of 2, 3, and 4? Well, we use imaging, and you can see he's coming around to that. UCSF, where he works, is a good quality center for imaging with MRI, and of course that's a critical component. You can't rely on imaging unless you have high quality imaging, and UCSF, where he practices, does have good quality MRI imaging. So we're moving toward, I think what we will see 10 years from now, 15 years from now, is inexpensive MRIs used on men who have PSAs above 1, just as mammograms are used on annual screening for women to make sure they don't have breast cancer. And this is all built around the premise that cancers that are diagnosed at an early stage are almost always curable. We used to be afraid of the word pneumonia because we didn't have antibiotics. People would die like flies if you go back, into the 1920s from pneumonia. And we're not really that intimidated by the word pneumonia any longer. And I think the prostate cancer, if we're catching it that early, it's going to be a sort of a routine thing. We're going to be so far ahead of the curve that, and the next issue will, of course, be developing non-toxic ways to treat the men that have types of cancer that do need treatment.
And well, we also talked about the fact that, family history is a funny question, because there's some people that have, 3 or 4 people diagnosed in the family, and they were diagnosed at 75 and 80 and 85, and they think that there might be something in terms of family history. But then there are people who have a, really strong family history, very early diagnoses, aggressive disease. And I was kind of trying to push him on the idea of, well, what about in these families that have a lot of aggressive disease or prostate cancer? How are you changing the paradigm of that in screening? Do you have discussions with your patients on that?
Yes. And I think what's being ignored in that discussion, I'm glad you brought that up, that is, if someone in the family has a serious cancer, it causes an emotional ripple effect throughout the whole family. So it puts everyone back on their heels and frightens them. And if we're talking about a disease that, consistently replicated itself in all family members, that would be an appropriate response perhaps. But prostate cancer doesn't. When you look at family history for prostate cancer, it's really only the people that have siblings or fathers who were diagnosed maybe in their 50s, which is young for prostate cancer. And then there will be certainly some increased risk of diagnosis of prostate cancer, but often it's not the same bad variant that the sibling or the father had. It's a different type of cancer that isn't as serious. So the only thing I think differently with family members is just make sure you're not lackadaisical about your screening. The screening process should be uniformly airtight for everybody. No one wants to miss a prostate cancer. If it's a little more likely that someone's going to get a prostate cancer down the line, modern screening should pick it up. And so, I guess it's good for awareness, but sadly, I think sometimes people are overreacting because with screening, we'll catch whatever may occur in a timely fashion. We'll cure it.
So then the only other question I had on screening, which I didn't get a chance to talk to him about, is that as America and the world becomes bigger in terms of weight, we're becoming bigger and bigger every year. It's a fact of life. And if nobody believes how big we're becoming, just look at clinical trials done in prostate cancer 10, 15 years ago, and look at the average BMI, and then look at the ones done today. They are going from 24, 25. Now it's standard before someone goes on ADT, for example, or 29, 30. It's a totally different ballgame. What I'm trying to get at is, does it scare you that with a lot of bigger individuals, there's an increased risk also for bigger prostates that don't have cancer? So you have a lot of PSAs that are shooting up very high just because of benign prostatic hyperplasia. And so do you feel confident in the screening techniques that with very big prostates, you can still find cancer or not?
Yeah, because we have such a low threshold, we do imaging with color Doppler in the office. We refer people readily and quickly for MRI. Here in Southern California, we send a lot of the MRI referrals to UCLA. They have a very good MRI department, just as UCSF does. And you get an accurate read on how big the prostate is. So the thing that I use every day in my life is something called PSA density. We've come up with this topic before. People look at PSA velocities and doubling times and the logarithm of this and this equation and that equation. I don't usually bother with all that stuff, but I do look at the ratio between the size of the gland, which is measured on an MRI or an ultrasound, and how high the PSA is to see if I should be nervous. So people have a 10-to-1 ratio when they don't have prostate cancer between their PSA and their prostate volume. So if you have a 40 cc prostate, which is like a normal sized prostate in a 70-year-old, a normal PSA should be around 4. So we only set up alarms if you're 50% above normal. So that would be for a 40 cc prostate. If the PSA is above 6, then we start saying, well, why? Why is this PSA running high? And this is not only for screening purposes, but this is also for our men on active surveillance who are getting PSAs every 3 to 6 months. Some of men either are, it's not because of BPH, because we're making allowances for prostate size, but it's usually because of background inflammation, so-called prostatitis. And that's common in men. And then that may be related to the dietary things you're talking about, people being overweight, increased inflammation. It's not a very well understood phenomenon, but I will tell you that we're dealing with unexplained meaning prostatitis, unexplained elevations of PSA, probably in about 10, 15% of our active surveillance population. These men are running above the threshold of what we should see for their size gland. Their PSA density is abnormal. And this is where we've actually started to use these new PSMA PET scans. In the past, the default process, so the scans don't show anything. Should we harpoon the prostate a dozen times with a random biopsy? Can we? Maybe the MRI is only 90% accurate. Are we missing something dreadful? Well, now with PSMA PET scans, which accurately read not only throughout the body, but also in the prostate, you can find out if there's any unexplained occult higher grade cancer lurking in a corner of the gland. So this is a nice way that we can cross-check. It's made my life easier. I've been, living with these men with these sort of outside range PSAs on active surveillance, good MRIs, nothing to explain it. Almost certainly prostatitis. And it's very gratifying when we have these scans that come back and say there's nothing outside the gland. It really is just prostatitis.
That's why I wish, into discussion of prostatitis and BPH, I just wish maybe they should change the campaign from what is your PSA to what is your PSA density.
Yes.
I mean, because I'm not trying to imply that just because you have a lot of weight on you, you're going to get a big prostate. There's genetics involved. There's all sorts of things we don't understand. But even in talking to the folks who are running these BPH trials, they'll admit that as America and the world is getting bigger, they're seeing bigger prostates. Not the rule. It's just, it's a consistent.
Well, it's not only bigger prostates, but it's also more cancer.
Yeah.
And worse types of cancer.
That's right. Lethal forms. They call it lethal or aggressive forms. Okay. Any other comments on screening? Any other tips on screening from the red jacket, Dr. Scholz?
Well, we're seeing a lot of patients who are coming to a medical oncologist because their PSA is elevated rather than a urologist, particularly because, we've jumped with both feet into substituting high quality MRIs for random biopsies. So we haven't done a random biopsy now in my office. I used to do random biopsies. I do targeted biopsies, but I don't do random biopsies anymore. And we haven't done a random biopsy in over 5 years. So so far we haven't gotten our fingers burned with that, because you're saying many are saying, well, gosh, we can't miss a single cancer. So let's do if you believe in MRIs, Dr. Scholz, let's do random biopsies too, just to be safe. It's cancer.
Yeah.
But that kind of flies in the face of what we know about prostate cancer. No, this isn't pancreas cancer, lung cancer. This is prostate cancer. Something, thankfully, that even in its more aggressive forms tends to grow more slowly, spreads later. And if there is something brewing in the prostate, if it's not only the MRI that you did today that's clear, it's also the MRI that you'll do next year to make sure that something small that was flying under the radar hasn't enlarged enough to be detected on subsequent scans. And this is totally overlooked by the whole medical community, the power of sequential imaging when you're looking at two different images side by side. Is there any small change here? That's much more accurate than just doing one snapshot scan that says, oh, there's no cancer. Of course, again, you have to have a world-class place getting the images, a world-class place reading the images, and then you should have a good clinician who's interpreting the images. But it is going the extra mile. But people do random biopsies like they're no big deal. I mean, these are large bore needles that are jammed through the rectum a dozen times. I mean, doesn't that sound kind of medieval?
I don't know, but you make it sound medieval. I mean, I've known you for a long time. You're the one who originally came up with the word harpoon. And I thought, I'm laughing with you, in the sense that, people do have to realize, this is not just a walk in the park. So when you came up with that word, even though that stings a little bit, I understand the meaning behind it. This is a serious.
It was a life-saving procedure in the 1990s, early 90s when it came out. We didn't have any way to really sample the prostate outside of going to the operating room. And so it became an office-based procedure. To this day, about 1 million men are getting biopsied every year with random biopsies. So it's an effective and accurate way to make sure, with reasonable accuracy, not as good as an MRI, but not bad, to make sure there's not a bad cancer lurking there. It's an important breakthrough. Yeah. But when better technology comes along, sometimes the medical world sits on what used to be. That's what the insurance pays for. That's what everyone expects. I don't have to explain why I'm different. And so people are just defaulting to the old way of doing things because they don't want to go through the painful process of retraining, interpreting MRIs, learning how to do targeted biopsies, living with the ambiguity about not harpooning the whole prostate. Yeah, I do use that word a lot.
It's not a bad word. All right, so that makes me think of two things that I did not ask Cooperberg. I haven't asked you either, these two. So this is what comes to mind. And I'm going to apologize ahead of time for asking you this. It's just that the question never goes away. It never will go away, and maybe it shouldn't go away. Are you ready for this? We always get no, you are. You're always ready for this. I have more confidence in you. People don't realize we do this off the cuff. I have plenty of confidence, but I have never asked you, because remember, you get the questions that you can think about it. I get all these alternative and different questions. Not that it's bad, but they come from all angles, and you got to bring other people into the discussion. Do you think there's any chance that biopsies spread prostate cancer? I mean, this question's never going to go away. I grew up to feel like there's plenty of evidence that says it doesn't, but you know what? I haven't been asking enough people lately. Do you think there's any chance biopsies spread prostate cancer?
Yes, just like there's a chance that you and I could be eradicated by a meteorite, in the next 10 minutes. Anything is possible. So is it likely to happen? No. The reason being is that metastasis is much more based on the genetic capacity of the cells than it is on what you do with it. They see circulating tumor cells in prostate cancer patients that never develop metastasis. So these cells break free, get in the bloodstream and float around, but they don't have the genetic ability to land, put down roots and flourish in another part of the body. So I think the biopsies they've shown that there's an increased number of cancer cells in the bloodstream after a biopsy. But I never use that as a reason to avoid biopsies. The reason to avoid biopsies is discomfort. Some men will develop transient erectile dysfunction. I'm talking about random biopsies. Some men will go to the hospital with infections, and some men have ended up with chronic prostatitis. An infection is introduced into the prostate that never really clears up. Prostatitis is not usually iatrogenic. That means doctor-induced. It's usually just something that men get as they get older, and we don't even understand why. But there is an iatrogenic form of prostatitis that's come from previous biopsies. Men were normal, and then after a biopsy, they're never the same.
I appreciate. I apologize. I don't know what the opposite of a softball is. It's called a speedball, maybe. I mean, that's not an easy one. And now you're making me think that a meteor might hit us because I was watching Netflix. So, all right. So then here's the other one that I did not ask him. And I just forgot. I just plain forgot to ask him. And I wanted to ask him. And I haven't asked you in a while. There is a lot of debate going on right now about biopsies. Which direction do you go in? Do you go transperineal or do you go transrectal? And both camps, let me just set this up. It's like any debate, Republican, Democrat, you name it. There are both sides very passionate. The transrectal, hey, this is easy. Some of these statistics are overblown. I don't got to put them under serious anesthesia. Transperineal says less infections. I can get to certain sites on the prostate, better for bigger guys. What say you on this whole debate that's not going away anytime soon?
Well, it's like many things. It's nice that we have different tools for different people. It is more involved. You kind of outlined the major issues there with transperineal biopsies, which have negligible risk of infection. That's the obvious reason to be, can we go through the skin rather than go through the rectum? That's the difference between a perineal and a transrectal or a standard biopsy. Standard biopsies go through the rectum, and the perineal biopsies go through the skin. So you don't get the problems of introducing fecal material into the prostate. That sounds like a big upgrade. The problem is that it's further away and it's more uncomfortable, and so you will need more anesthesia. I'm not a big fan of putting people to sleep in our age group because there is a low risk of memory problems. You might know more about the statistics on that than I do.
No, I'm saying thank you. People talk about anesthesia like it's candy, and it's a great thing. It's a great thing when it's needed. The idea of sedating when you don't need to be sedated, there should be a lot more discussion. Sorry, go ahead. That's just
no. I think we need to spend time on that because awareness is low. As you get older in your 60s, 70s, and 80s, the incidence of lingering memory problems after anesthesia goes up and up and up. And of course, it's dependent on how heavy the anesthesia is. It's dependent on how long the anesthesia runs, how old you are. But I mean, some transient memory problems, fine. We deal with transient problems after radiation and all these things that clear up. We're all happy to endure that. That's fine. But lingering memory problems, that's disastrous in our age group. So anytime someone's going in for anesthesia, we always have to ask ourselves, is this a truly non-negotiable procedure that must be done? Or is this a convenience thing? And I want to get my chin lifted or something like that. This is there's a I don't know why this. I guess people there's a certain inevitability about it. It's just this is modern world. We do surgery. It's no big deal. You go in, you go out, you're fixed. And of course, it's quite miraculous. My 90-year-old mom just had 2 hip replacements. She wasn't walking, now she's walking. So,
Wow.
so that was non-negotiable. She needed to be ambulatory. So and she's come through the anesthesia just fine. But I don't know, what is the incidence, say, in a 70, 75-year-old that goes through a 90-minute general anesthesia, Dr. Moyad? What do you know what the statistics are for how many people are going to have lingering, ongoing decremental decline in memory?
I can tell you that I know of no agreed upon statistics because of all the variables involved. You know, we have some 77-year-olds who can outrun 47-year-olds, and you have some 77-year-olds who look and are acting like they're 177 because of all the comorbidities. So I can tell you that the statistics look worse. The worse the condition of the person going into the procedure, right? Like anything else. So so I could give you a number. I could give you single digits, I could give you even double digits, but the number that we quote clearly goes up dramatically with the health of the person that's about to go under. Now, that being said, you use a really good term. Many times, like my anesthesia friends, some of my best friends are anesthesiologists around the country. Many times it is a negotiable situation. It's not a non-negotiable. They have different alternatives. They have conscious sedation, they have other options. And this has to be brought up before. Because I'm always surprised when I'm talking to somebody, for example, or even on the phone, and someone says, "Oh, just put me out. I was out. It was great." And I'm going, I don't know if your brain likes that too much. I don't know if, being out for if you had another option, you want to actually pick that option. It's kind of like laughing gas. Every movie portrays laughing gas as such a great thing. And I think, hey, maybe it is a good thing once in a while. But the idea of getting tons of laughing gas, I don't necessarily think can be so great for the gray matter. And we're just beginning to touch upon that. And the place that they used to really pick on was the coronary artery bypass grafting surgeries. They would see that down the road, some people had some cognitive issues, and they're still trying to argue, is it because they had cardiovascular disease, or because they were under for so long? But the point goes back to, I do believe that everybody has to have a discussion on anesthesia. How long am I going to be out? This has got to be a standard part of your question. And the question that you posed to me, it's not that I can't answer it. It's just no one's ever answered it adequately, because it's kind of one of those things that is a hush-hush kind of thing. It's
yes, it is. That's right. The surgery industry, the anesthesia industry, this is kind of that dirty little secret that no one wants to talk about. But I think we're talking, let's say in a 70, 75-year-old, otherwise great memory, good health, maybe it's probably only about a 3 to 5% risk that they'll come out and they'll say, and the family will say, "Dad's not the same, and he's never been the same since." So it's not a negligible risk. It's not a high risk in a healthy 70, 75-year-old, but there is a real problem of permanent problems. And so every time we go into one of these things, we know there's also a risk of dying of a heart attack if you have general surgery. So it's not like we don't understand there are risks. It's just that if all the things we value, we're trying to preserve quality of life in the prostate world. I'd like to, as a 90-year-old, I'd love to be still getting erections and all these fanciful things that we hope for. But golly gee, what about our memory? I mean, that's the one thing that we all can sort of feel, we're losing grip on that as we get older. Yeah. And to accelerate that process, that's about as bad as it gets.
Yeah, no, it's true. And look at the clotting risks that go up, the blood clot risks that go up with size of the person, under anesthesia. And so, yeah, this could be a whole conference. I mean, me.
Let's go back to your perineal question. So I'm glad we spent most of the time talking about the fact that they have to put you to sleep. That's a big difference.
Yeah.
I will say that ever since we went to doing only targeted biopsies, where we'll do 2 or 3 sticks rather than a dozen, we have not had a single patient who's developed sepsis. And we know that the national average for a 12-core biopsy properly performed is about 1 in 50 will develop sepsis. And I see these patients. I have patients that have gone for standard biopsies to other reputable centers. And, we see a lot of people that get biopsies, and it's about 1 in 50 is going to end up in the hospital getting IV antibiotics, because even though they took Cipro and all the usual stuff, they developed an infection. So I think with targeted biopsies that are done, adroitly and quickly, the risk of infection is negligible. But if people are going to do random biopsies, then a perineal biopsy will almost eliminate the risk of infection. So that's an attractive thing. I don't know if I believe this thing of it's easier to get to the front of the prostate with a peritoneal biopsy, because it's easy to get to the front of the prostate with a transrectal biopsy. I don't really see why people talk about that as a pro or con. So I'm glad people are talking about the risk of infection, and peritoneal biopsies are a response to that, but it's a pretty big deal. I mean, you go into a surgery center, they put you to sleep and all this, it's a much more, for us to do a targeted biopsy in the office, it takes 10 minutes. If I'm going to go in and have a peritoneal biopsy, I'm going to have to take the day off. You're going to have to prep me, and I'll have to be NPO and do all the usual stuff. And of course, then you have to find someone that's actually skillful at this. It's not, still in their learning curve. They have to be doing a certain number of these procedures on a regular basis, or they're not going to be very skillful at targeting something.
Yeah, I always find it interesting. That brings up the point that sometimes the speakers look at me funny, but I think because you and I have been together a long time, that a lot of times whatever they apply to the surgeon should be applied across the board in prostate cancer, meaning, in any situation, you do want to ask about anesthesia. You want to ask about the duration. You want to ask about what's the learning curve? What does it take to be an expert in this area? That's true of the person reading your MRI. That's the person pressing the button when they do radiation oncology. Everybody has a learning curve, and everybody should be vetted in terms of their expertise if you're going to have a procedure done. And the surgeons, we know that, but it really needs to translate across the board. The pathologist, the radiation oncologist, right? All of that. So I appreciate that answer.
I think this is true for other areas of medicine. Neurosurgery, for example. If you're going to have a brain operation, people are very circumspect about who's going to operate on my brain. But the anatomic area of the prostate is similarly complex. And, if we're having an appendectomy, I go down to the corner hospital and they'll get the appendix out without much difficulty. Yeah. And I'm not going to be looking for the number one appendectomy doctor. On the other hand, hernia operations, which are a skill procedure, I do try and look for someone who's got above average skills, because there's a whole thing about, well, how tight do you make those sutures, and what's the incidence of these hernias coming back and complications? So there is a skill component. So it depends a little bit on terms of, if you have a cold, you can go down and get an antibiotic at your local outpatient emergency room. But in prostate, we're playing with high stakes things like your survival, your sex life, your urinary function. Things that you have to think about constantly, and therefore quality really makes a difference.
Yeah, no, that's a good point. Really good point. So what I think I asked Cooperberg this question, and I'm going to ask you before we move on from Cooperberg. Oh, and by the way, in the biopsy sphere, I don't even know what you call it, in the biopsy world, we're hearing rumblings that there are people out there that are going to be moving toward perineals that doesn't require such anesthesia. I don't know. I mean, they're saying it can be done. It's moving that direction. So you should also watch out for that if that becomes true.
You can do it under local anesthesia and Novocaine and whatnot. And it's going to take a little more skill to accomplish that because you're numbing up a larger area. But it is feasible. And so it's rapidly evolving. We're not as motivated, as I mentioned, since we only do targeted biopsies and we don't see infectious complications, to develop the skills. But I think it's a nice reaction, at least there's awareness that the risk of serious septic infections with 12-core biopsies it's on the radar now. At least people are aware of it.
Yeah, it's such an interesting debate. But my guess is that all this stuff moves toward the idea of putting someone under for some of these things as a rule of thumb is going to change. I made fun of Cooperberg for his big website. I don't know.
Well, he deserves it. What a star. I mean, he seemed to have his feet on the ground about active surveillance. I mean, they still do random biopsies and they still do surgery, neither of which I'm attracted to, but they are leading the way and encouraging people to do active surveillance. And not only the 3+3s, but they also are on the cutting edge of which patients with 3+4 can do active surveillance as well.
Exactly.
And they've got the whole algorithm and how they pursue that. And I love how emphatic he was about the fact that if you have a genre of prostate cancer that can be watched, that's the best thing for you. It's not like an option. It's not just one more choice amongst the panoply of seeds and radiation and surgery. active surveillance is the best way to go. You're postponing an irreversible treatment into a time in the future, probably when the technology will be superior. So there's a real advantage to doing active surveillance if you're a candidate.
Well, I threw this question at him and he kind of rolled this. I don't know if you caught it. It was about, I like to make predictions. I like to put myself out there in terms of predictions. And my prediction was that every man on active surveillance in the next 5 years will be tested for BRCA1 and 2 and other mutations just to see if they should stay on or not, or should they be worried? What say you about that? Because I don't think he wanted to answer it. I'm just telling you, I know where this is going. That one of the criteria for being on active surveillance, you're going to get a cheek swab, you're going to get a BRCA1 or 2 look, or whatever the other mutations we're looking at. What do you say, Mr. Red Jacket?
Well, it was a great question, and I liked his answer because a lot of people, when they see a person that's BRCA positive, this is a mutation that suggests that you're a little more likely to have a higher grade cancer, and that means that perhaps a higher risk of spread. That he wasn't intimidated by that. There's just too much evidence. We haven't known about BRCA testing for men, and I'll come back to the question about when to do it and why. But we haven't known about that, and active surveillance has been proven safe over 15 years. So if someone's BRCA positive, yes, you need to do active surveillance. You don't just go to sleep on people who have, whether they're BRCA positive or negative. You watch them all uniformly with a professional degree of intensity. And then if something looks like it's misbehaving or changing, then you reevaluate. And sometimes some men will have to undergo treatment down the line. And thankfully, the studies show that those men get the same cure rates as the one that get treated at the get-go. So are we doing BRCA testing in everybody? We aren't, but we are doing a lot of genetic testing. The one downside of genetic testing, which you're well aware of and you might want to speak to, is if we were to genetically test our conference members, for example, when we have our September conference, we'll bring hopefully several hundred people actually in person, and we'll all rub shoulders and have fun together. So let's say we were just to test everybody. So what would be the benefit? What would we find out of testing, say, 500 people? Well, we'd probably find maybe 2 to 5 patients with some sort of a treatable, worrisome genetic mutation that they would like come and hug us and cry on our shoulders and say, "Thank you, Dr. Scholz. Thank you, Dr. Moyad. I had no idea that this thing lurked in my family and that my future will be changed now because I'm going to take these measures to make sure that I don't die of lung cancer or pancreas cancer or prostate or whatever, because now we know."
Right.
And then you're going to have another 494 patients, some of whom, let's say 90% of them will have normal genes. Do they really know anything they didn't know already? Not really. I mean, everything's the same. Then you're going to have another 10%. So this will be about 50 people that'll have screwball, weird, unknown mutations, right?
No, you're right.
And they're going to get that emblazoned in their brain. I've got this screwball weird mutation. They don't know what it is. And sometimes they do know what it is. They say, yeah, it's absolutely terrible, but we can do nothing about it. So that when you do genetic testing, it's not an innocuous thing. You can have a psychological impact on the people you test. So I always go to genetic testing with a little trepidation in terms of, okay, what Pandora's box are we opening here? And as long as people are emotionally prepared for the possibility that they'll get some sort of an ambiguous thing, or rarely even a bad thing they can do nothing about, then genetic testing is great because there are some treatable things. And I am not using BRCA positive or genetic abnormalities as a reason to not do active surveillance. I think there are other doctors that do believe that's a necessary threshold to not have genetic abnormalities to do active surveillance. I disagree, and I was very gratified to see that Dr. Cooperberg, shares my opinion as well. So I'm not doing it routinely in everybody. I'm having a discussion with people. Do you want this information?
Yeah, no, I mean, that makes sense. That makes absolute sense. But, this topic's definitely going to come up more and more because what's happening in the real world is BRCA tests are moving over the counter.
Yeah.
So, there's a couple.
It's not just BRCA. I mean, they do all your genes, including BRCA. And this becomes really important. Like when we get to Dr. Vogelzang, we'll talk about how men with advanced disease may respond to olaparib, a specific type of a chemotherapy that works really well for BRCA.
Yeah.
So there, I think it would be malpractice to not test people. That would be serious,
that's a different scenario.
bad
So-
medicine.
But what you imply is sometimes overanalysis leads to paralysis is true. I mean, sometimes too much information is not good either. What he also mentioned was there was a focus on this. I know we're going over on our time for him, but you do so much active surveillance that to just leave this immediately would be a disservice. Plus, I'm really enjoying staring at your tie and your jacket now. It's kind of wearing on me, Get it?
Well, maybe I'll have the boldness to actually, instead of being set up for a red jacket, maybe I'll do it by my own free will in the future.
I know, but I think we should give based on our salary. So, my salary tends to be extremely low in general and what I make in life. So I thought I would just give you your own jacket. I mean, it's heartfelt, but what reflects my salary is the donuts. All right.
Now, let's go a little further. Now, did Alex go in and take video of my wardrobe so you could pick the right jacket, or did you just trust her to pick the most outlandish one?
Well, Alex and I and the rest of the staff have taken an oath never to reveal any of our secrets, unless, of course, there's cash involved in the exchange. So I am not allowed to reveal that. Otherwise, I could be cut off from the donut supply, which would hurt me.
Oh, boy.
So pattern four subtypes in the extent of pattern 4. His basic take-home message was, look, you can have some 4 and still have active surveillance. So this is a 2-part question, and then we can leave Cooperberg.
Yeah.
If you want to comment on the pattern 4 group, and by the way, I always educate the speakers. I want to let them know that I took Latin for so many years, it wasn't even lawful. In Latin, cribriform or cribum means sieve. So it means perforated. So that's what it looks like under the biopsy. Oh, you know what? This is really incredible. You can't believe all the stuff I got here. So this is like what see all these areas, these holes? That's sieve-like, that's cribriform. So comment on pattern 4, and then end on the question I asked him, which is, all right, now you put me in your active surveillance protocol. How are you going to monitor me going forward? Am I getting PSAs every month? So pattern 4, and then how are you monitoring me going forward? And I swear I'm done.
Yeah, that'll only take me about an hour to answer that. So the crib, what's really amazing is that we're talking about doing active surveillance in men that don't have pure 3+3. Historically, you actually had to have small amounts. When this started in 2005, you had to have small amounts of 3+3 to do active surveillance. Now, Dr. Cooperberg, and I agree with him, says that it doesn't matter how much 3+3 you have, do you have higher grade elements. If you've got a little bit or a lot of 3+3, it doesn't matter. Just make sure you're not missing a higher grade element somewhere. And that's what these things are that you're waving in front of us. These are higher grade elements. Well, it turns out that it's been shown to be safe that if you've got small amounts of higher grade elements, that your outlook is so favorable that you can still do active surveillance. So it comes down to quantifying, well, how higher grade is it? And we're not watching pattern 5s, for example, and how relevant is the cribriform thing? This is a subvariant of pattern 4. So I would say a more important issue is how much 4. I think that trumps a lot of this, whether it's cribriform and whatnot. And small amounts of 4 are acceptable. And interestingly, it's not just the quantity of 4, it's how much 4 there is in proportion to the 3. So there's got to be, if there's more 3, you can actually tolerate a little more 4 because it's the percentage of 4 that people use as a threshold for treatment. So they say you might be able to watch people with up to 5, 10, 15, 20% 4, assuming there's not too much cancer in general. So if you're understanding that this is an unfinished work from my sort of confusing explanation, it is. We just know that thankfully prostate cancer has gotten, as we understand it better, doesn't spread that easily, even when there's a little bit of 4 and even if there's a little bit of cribriform. I think that the process of how we're expanding to bigger tumors, higher grade tumors, and watching them is going to continue now even more, especially in the elderly with these PSMA PET scans. Wow, where did that come from? Out of left, back to PSMA PET scans. This is the most revolutionary change in prostate cancer, in my opinion, since the discovery of PSA. PSMA PET scans are a total game changer. So how could it how can it change a more elderly man who wants to do active surveillance? Well, we know that it takes 20 years for prostate cancer. One of our speakers shared a slide showing that, I think it was Dr. Cooperberg, that if your PSA is under 1, it's impossible to die in less than 20 years. So what if you're 75? Are you satisfied with living to 95? I would think so. So if these men have a more aggressive type of cancer, but their PSMA PET scans shows no metastasis. So they've had this aggressive cancer for some period of time. It got diagnosed. We know it's been in their body for 5 to 15 years. Still hasn't spread because the PSMA PET scan shows no mets. Is this a 75-year-old that you could watch an 8? Because so far, we know that not all 8s metastasize. Only about 25 to 30% of them metastasize. But we're treating everyone because in the past we couldn't be sure who already has metastasis that needs to get on treatment now. Yeah. So as a precaution, we're treating everybody. So I think we're going to see an evolution in the way we do active surveillance, especially in the somewhat more elderly, in men that don't have any metastasis today, and who no doubt have had the cancer for a long period of time. It still hasn't metastasis per the PSMA PET scan. And we're going to start doing active surveillance even in more aggressive cancers, not just the 3+4s.
What's your standard surveillance? I mean, you do PSAs every 3 to 4 months and an active surveillance person every 6 months. He kind of implied that in the first few years, every 3 or 4 months, and then we go 6, and then once. He almost said some people. I think he said some people once a year. I don't remember.
Yeah.
But
no, that's right. This is a really important, and I thought was very sensible. We realize now that if your PSA is misbehaving, that's not a reason to go off active surveillance because there's so much background noise from prostatitis. It's not a very accurate test. So as a result, yes, historically, everyone would get PSAs every 3 months because we were relying on PSA as a trigger to who we stop treatment in. We don't do that anymore. So now I think of it as the analogy I use, and I don't get a lot of aha type responses to this analogy because I don't have a better one. But if you think of the game of baseball, I think of the PSA sort of like the backstop. It's not a player on the field, but if the ball goes through the catcher's legs, the ball doesn't go all the way to the parking lot. So the PSA is just to make sure we're just not missing something dreadful. So as such, I'm typically doing twice a year. Maybe I'll do it every 3 months for the first year to sort of see what the pattern is in that individual to establish a baseline. Yeah. But then subsequently, we'll do it twice a year.
Okay.
And then we don't do follow-up random biopsies, which I do believe that you talk to any of the big, Dr. Cooperberg, for example, they do periodic follow-up random biopsies. They've stretched them out more, every 3 or 4 years rather than every year like Johns Hopkins. But we have abandoned that altogether. We just do annual MRIs, color Dopplers, and then we'll do a targeted biopsy if we see a change or a problem.
I see. And then I guess I didn't tell the truth. I said we were going to move on, but I live these interviews and they're playing in my head. That's why I don't get any sleep. And what played in my head is the fact that patients today, whether they have been biopsied or whether they've had a tumor removed in any circumstance, are being inundated with the idea of a different type of biomarker testing, right? Prolaris, Oncotype, Decipher. What do you say to patients about being inundated with all this idea that you got to test with these genetic tests? They could possibly tell you when a 6 is not a 6. Yeah. I mean, how do you play that out?
I am so glad you brought that up because I think we need to think of all those tests, which are useful and helpful, as tiebreakers. Okay. It's already established that if you have a 3+3, and this was actually Dr. Klotz that shared this in a previous video for the PCRI, who's obviously a brilliant man and understands statistics and risk and all this much better than 99% of the world. And he points out that those genetic tests are not like guaranteeing you what the future is. It's just another statistical projection. And right. 20% of the time, it can be completely wrong. So don't take a person who we already know can do active surveillance, who's got pure 3+3, everything's golden, and mess it up with a genetic test that could be completely wrong. That you can just, because we already know it's safe to do active surveillance in 3+3. We don't need more information. If the genetic tests were like 100% accurate, it would just validate what we already know, which is that's a good candidate for active surveillance. I would not use genetic testing in these pure 3+3s who are very, very safe and good candidates for watching.
Okay.
But in the 3+4s, the cribiforms, they have a little bit of 4. Those tests will actually give you a statistical projection of whether of what the risk of spread is over the next 10 years. That's a great metric. So you can actually share that information with the patient and say, are you willing to live with a 5% risk of spread at 10 years, a 10% risk, or would you rather incur the immediate risk of erectile dysfunction if we were to treat your whole prostate with, say, radiation? And allow the patient to get involved in the decision-making process. You get a nice, clean number, risk of spread at 10 years. In a number, not just like it's likely or it's unlikely, not some sort of vague projection, but an actual hard percentage.
I see. So that becomes another backstop when you need it. I'm just trying to play off of your analogy. That's awesome. That's great. I feel like we really did the active surveillance folk a good service because we really covered it. I don't want to leave you without showing you where I stumped Cooperberg. I mean, these were really easy. Michigan plays his alma mater, Yale or Dartmouth in football. What would be the score? And he said 53-3. And I said, wrong. Your teams would never show up. They'd be too scared. And he didn't get the joke. He was thinking of the next question. So it was a trick question. They don't show up. He was thinking of the next question. Then I said, you know, he married a dermatologist. So I said, there's basically no chance you ever go to dinner where someone's not going, hey, you know, my PSA is this, and I got this mole. And he admitted that basically he can't go to dinner with anyone. So that's it for, that's all I got for Cooperberg, except the only thing we didn't cover of all the patient questions, of all my questions was, do you really think there's a difference between the word watchful waiting and active surveillance? And can you explain why people still write that question today? The
idea is that since it takes 20 years for someone who has a small bad cancer, who's untreated, to ever die of it, then the default issue then was, well, in those individuals, once they get to a certain age, let's say they're 80, why not just ignore the stupid prostate cancer? And then if the dastardly thing actually does spread, just put them on some Casodex, a mild hormone treatment, and that'll keep the disease in abeyance for another 10 years. So they'll never die of prostate cancer. And you have a quote unquote, another good backstop, a mild hormone medicine that you can use to just keep it under control. The problem I have with watchful waiting in this modern era is it's not very hard to watch anymore. If you are a believer in random biopsies every year, that's not pleasant. You know, Johns Hopkins likes to, harpoon a lot. But if you trust in an MRI, why not do active surveillance? Just get an MRI once a year, and as long as nothing's misbehaving. So we don't do much watchful waiting anymore, unless you're talking about people that are, living in a nursing home and can't come to the doctor's office or something like that.
Yeah. I always like a question that comes from the audience with a little bit of humor. And this guy or gal said, what is active in surveillance other than my cancer? It seems like more like a game of chicken. And the reason I think you can, if you want to say, I think you've already answered that question, but I think what people have to realize is it's really easy to make prostate cancer the piñata of 2022 in terms of this. The reality is we're only going through what many other cancers are going to have to start exploring. Like right now, there's a huge discussion on different types of melanoma and which ones do you go after actually. And subtypes of breast cancers and different thyroid. Look at all the controversy on thyroid. So it's not that this is not just what prostate cancer is going through with active surveillance. This is becoming a widespread term throughout the cancer spectrum, right?
Yep. It's a wonderful thing. Anytime we have innovation and new things, it creates controversy, confusion, and challenges. And it's a wonderful thing that we have these problems. There is uncertainty, as Dr. Kwan was talking about what is going to be the role of all these new PSMA PET scans. That's a good problem to have, and it is a problem. Doctors that are unfamiliar with it, the fact that we don't have long-term follow-up for certain decision-making, it's going to be a challenge. It's going to take time, but it's such a powerful tool. We're willing to live with those challenges.
Yeah, no, absolutely. Because, there's a couple of words near and dear to my heart: public health, epidemiology. That's me. I read a great editorial. I wish I could remember the author the other day, who said, every cancer is going to have to figure out, what's normal and what's not normal for a certain age group. And he said that essentially we've been remiss is we're not doing enough autopsies to look at the natural history or progression of melanomas, thyroid type, breast. And he said, if we would do more of these, and that's where we kind of got in prostate. It was Dr. Sackers and other who in Detroit who saw that many men who were younger in their 30s and 40s harbored prostate tumors that were indolent, right? So what he was arguing was, why aren't we doing this throughout the cancer spectrum? Sounds a little macabre, but there's some merit. Don't you agree with that?
Oh yeah, yeah,
yeah.
I think that's the advantage of my own career, which is so narrowly devoted to just this one disease. That's somewhat unique, as I'm sure you're aware. Even the academic prostate experts are usually also doing kidney cancers and testicular cancers and bladder cancers, which are very complex, as well as prostate cancer. Yeah. And the advantage is that you get familiar with how the disease behaves over time. That's particularly important with prostate cancer because it moves slowly. So it's like raising a child. You know, you figure out parenting about the time that they're going off to college. It's a slow, evolutionary, and complex situation. And I suppose there are certain people that keep adopting kids and they get better and better with time. Most of us aren't willing to pay that high price, but it's in the prostate world, this is something that since I go to work 5 days a week, 8 hours a day, immersed in seeing prostate cancer all day long, you start to get familiar with the enemy, the way it behaves, how it's, and you also get familiar with how slowly it evolves. Everyone thinks cancer, it's happening quick. Prostate's the exception. It not only doesn't happen quick, it often doesn't happen. It just sits there. Yeah. So recognizing those variants and reassuring people is probably half of my job, because I've seen now bold patients. You know, I wrote a book with Ralph Blum, 10, 12 years ago, who had the boldness back in the 1990s to say, no, I'm just going to watch this. Yeah. And other such individuals like that, who were patients of mine back in the 1990s when active surveillance was really not even on the radar, who are still being watched today with the same condition that they had 20 years ago. These are people in my practice. Those sorts of trailblazers have shown me that it's not just a storyline that the cancer can sit quietly for decades.
Yeah, no, that's very well put.
You're getting me a little bit passionate now. All right, so
no, you're really. I was going to say before I forgot, but now you reminded me that I don't know if it's the red jacket, I don't know if it's the donut, I don't know if it's the 1,3,7-trimethylxanthine, which is also known as caffeine, that you had. But you're on your game today, so I'm just sitting back and kind of admiring this. This is pretty impressive. So
we'll see. It looks like you might fit this thing, Mark. Maybe
I might fit this thing, man. I've been running so much. I'm not only at my college weight. Well, I've always been at my college weight, but now I'm going down a little bit. It's kind of scary. I'm back to doing my.
All right. So maybe we'll be a matching pair at the September conference.
I mean, I would do it. I mean, I would take that Scholz challenge, the Scholz Red Jacket Challenge. I will accept, and I will gladly put that on. But I guarantee.
Right, I'm going to leave. Since you have a lingering personality, I
want to go to Brady.
Yeah, that's exactly where I'm going to. So let me just jump in and say thank you for inviting him. That man was amazingly balanced, obviously skilled, articulate. I was just so comforted to know something like that, someone like that exists, that we can send those problem cases to. He was very, he didn't sugarcoat anything. He was very, I think, so direct. And people who are thinking about trying to fix something, watch his video several times. They will be so much better off. And we can't go into the same detail as we did with Dr. Cooperberg. And there's no intention to do that. It's just, as you know, you and I get going on stuff and we can't stop us. But I wanted to mention his quote because as you know, I'm kind of an anti-radical prostatectomy guy.
Really? I never knew that.
So he said that he described two things that I hadn't seen. One, I was aware of the fact that unfortunately men often ejaculate urine after having radical prostatectomies, but he called something foreplay incontinence, which I was unaware of, and the statistics that he shared as the incidence of this happening was twice as high as what I've been quoting. I've been saying there's about a 20% risk of climacturia, which is ejaculation of urine after when men have had radical prostatectomies. And he said, no, 40% risk. So, and he talked about, how this is difficult and how maybe artificial sphincters will help. And sounds like, that's a pretty good operation. But, when you're doing operations to fix operations, you kind of wonder, well, maybe we'll skip the first operation and just do something a little less damaging. But that number, 40% incidence of climacturia and foreplay incontinence. Did you heard anything like that before? And this is coming from a surgeon. This is not the reactionary medical oncologist, trying to stir up animosity. This is him.
Yeah.
How'd that number hit? How'd that hit you, Marcos?
It hit me because he first told me that it's something that they really haven't followed accurately. And it hit me because he told me a lot of people don't admit it. And it hit me because now that I'm getting older, I have a lot of friends who have had every type of prostate treatment. I mean, friends I went to school with, and they started telling me about it. And I thought, so I was ready for any number, I guess is what I'm saying.
Well, and thank you, both of you. And he talked about this newer ProAct, expandable bulb. And again, he was so balanced in terms of talking about how people are still in their learning curve. This might turn out to be an effective thing. It sounds like sphincters in his hands are very effective. Mm-hmm. And we ought to bring him back to talk about the penile prosthesis question, because if you have a skillful surgeon that can do it right, satisfaction levels are very high. Exactly. But it probably is a fairly straightforward operation for someone that's doing it a lot. But the average community urologist may be doing 2 or 3 a year, and those people shouldn't be putting prostheses in men. But someone that has built a whole career in doing it, that can lead to very high satisfaction.
Yeah, absolutely. I think that was the place that as I grabbed some of my huge stack of notes on him, my gosh, I mean, talk about trying to get ready for that interview is like trying to get ready for, interviewing, I don't know, IBM Watson or something. It's very intimidating. I mean,
I agree. I think you both did a beautiful job. Yeah. Talking about but all the context of, the complexities of deciding who needs surgery and who has more or less risk of disastrous outcomes. Of course, I just skip right over that and say, let's find a better treatment altogether. But it's still popular. I looked high and low to try and find out how many radical prostatectomies are we doing every year in the United States. My best guess is somewhere between 60 to 80,000 a year. But it's really hard to find that number anywhere. I don't know. Have you ever come across how many RPs are being done every year?
We exist on your island. I'm on my island. There's definitely a bridge that connects them whenever we want to have donuts together. And, these are just numbers that I used to look at 30 years ago in my career and go, wow, that's interesting. I'll repeat. I haven't thought about these numbers unless someone asked me to go look for them, I haven't even thought about them. I got to be honest.
Yeah.
So
my guess is that we're in probably the 60, 70,000 men a year having radical prostatectomies. And I'm sorry to use this as an opportunity to beat up on it, but I don't even talk about radical prostatectomy. I just tell patients, let's talk about something else. But but there is this, it's still an ongoing thing. And I think that the satisfaction levels after a radical prostatectomy, say in an ideal candidate, a 60-year-old man, and he mentioned the trifecta, get cured, don't be incontinent, and don't be impotent. And of course, the definition of impotence is very, very vague. I think I'll say something about that too. But the so-called trifecta, you're looking at about it in the hands of superstars at about 50-50 at best, that you'll be happy having fulfilled all three of those criteria. And now, what's defined as impotence? If you ask a more definitive question, is your erection like it was before surgery? Only 5% of men say yes to that. And that's Dr. Mulhall's statistics, the sex expert from, he's from Memorial, right? Yeah.
Yes.
And so, whereas if you have some form of radiation, about 50% of people say it's just like before. It's a big difference in terms of quality of erection for the men that have had radiation compared to the men that have surgery. So, all right. Sorry for that.
I know that given the opportunity, you like to use surgery as your backstop, a different kind of backstop. However, I want you to admit for the first time in the Q&A, you have to admit, and I've learned this over 30 years, and I'm not even going to I'm going to play Switzerland on this. That's my job here. Sometimes I'll throw in my opinion. You have to admit there are certain guys that they have the personality, and so do the family. They just don't want any cancer in them, period. They want the cancer removed.
You know, I won't accept that because
I know you're not going to accept it, but I'm just
you're one of
telling
the
you.
best, Mark Moyad, you are one of the best communicators on the face of the planet. And I think it's our responsibility to transmit to these frightened people what we know to be the truth. In other words, you have to convince these people what they need. It's not a matter of letting them reside in their fears and their uncertainties, which are not based in facts. So I think that that we need to take more responsibility and step forward. Now, it's really hard to do considering how
Very
powerful the urology industry is. I mean, they own all the waterfront property. So it's not going to be a popular position at all, obviously. But
well, no, I understand. Look, I love my fact that I want to be one of the best communicators, and you're right. You know, but you also realize there's a certain amount of investment until there's no return. In other words, someone is going, you know, it's like we deal with different crowds throughout medicine. Some people are going to feel the way they do. And I also want to defend it in another way. And I've never asked you this question, and I'm sorry for getting us off track, but you have to face the fact that as much as I've learned through this process with you and radiation, how much I think it's become an amazing option, there are just a number of people also giving radiation out there that aren't experts. They're not they're not doing a good job, and they're jumping on the radiation bandwagon, and they're causing some damage, as we say in French.
Oh yes. Oh yes. So that's a quality is equally important for the radiation as it is for the surgery. It's not just the guy in the corner. And there is situations. I loved that Dr. Brady was talking about, if you've had radiation to your prostate, you will always have a fragile prostate the rest of your life. So don't, or maybe it was Dr. Kishan that said that you don't do anything to a radiated prostate until you talk to your radiation therapist first. You don't go in and carve on it. You don't do TURPs. You don't do procedures on radiated prostates because they're more fragile. So it's not like radiation is desirable. That's why we have active surveillance for the people that don't need treatment. But in comparison to surgery, it's desirable. And I'm only comparing high-level surgery with high-level radiation. Yes. If people don't do their due diligence and find quality practitioners, they're going to experience more problems. There's no doubt about it.
I mean,
all right, that's Dr. Brady. Dr. Brady.
I want to talk about Brady still for a second, because his last name is Brady, and Tom Brady, you know, is one of our most famous graduates. But I just want to apologize to the audience, because when we don't cover a topic at 2.5 hours, we said, okay, we're exhausted. No one's ever covered incontinence this well that I've ever been with. And so we were going to talk ED, but we agreed to do it in a separate session, talk about penile prosthesis, talk about the ED drugs. So for those of you who thought you were going to hear about other options, we covered them a little bit with Brady, but we promised to cover them further going forward this year at the conference, correct?
That'd be great.
All right.
So we'll move on then and talk about our wonderful and beloved Dr. Kwan, who's been so far ahead of the curve. Obviously, you brought that up nicely in the conversation, what a unique and brilliant person he is, and how he's been so transformational in the way prostate cancer is managed, especially with scans. Yeah. And I think there was a couple of things that I wanted to point out. He's very excited about PSMA PET scans. I agree with him 100% that these PSMA PET scans are going to replace all the other scans, and it's going to happen quickly. PSMA PET scans are now covered by Medicare, and people that don't have Medicare, that have private insurance, that should pick up steam over the next year or so, and they'll be covered by insurance as well. But the scans are so useful and accurate that if you have to pay for one, it's probably money well spent. Even if it's, $3,000, $5,000, $6,000 for these scans. But I thought one of the great things that he points out, because he has access to all these different scans, to the FDG PET, to the Axamin, to the choline, C11 choline scans, that 10-15% of people don't light up on PSMA. And that may be a somewhat more serious variant of prostate cancer. So what do you do in those people? Well, Mayo Clinic is the only place. There's 3 centers, as you guys pointed out, one in Florida, one in Arizona, and the basic Mayo Clinic that can do C11 choline PET scans. In my opinion, I don't think Dr. Kwan would agree with me. In my opinion, it's not quite as sensitive and accurate as PSMA, but it's still good. And someone who's PSMA PET negative that you're expecting to find something, C11 choline is a great backup. So is the Axeman PET scan, uses a type of a protein as a radioactive sensor to find the cancer. That's widely available across the country.
Yep.
And then in patients that have these really bad cancers, what's a bad cancer? Someone who has known metastasis, has been through chemo, and different types of treatments don't seem to be working. Those are the types of people that start lighting up on FDG PET. That's the standard PET scan used for lymphomas and lung cancers. Doesn't usually work for most prostate cancers, but in certain serious variants, it does. And these scans are accessible and they're useful. So I thought that was just wonderful that Dr. Kwan brought that. I think he's probably the preeminent expert in prostate cancer PET scanning and possibly in the world, because he does both clinical and technical. He understands both sides of it, and he has immense experience. Now, one of his things that I would like to contextualize, if people are picking up their luggage and heading off to the Mayo Clinic, you're talking about a certain patient demographic, usually who's in pretty tough straits. There's a spectrum of prostate cancer. You know, there's a lot of people in active surveillance. There's people that are going through early treatment, that are getting radiation and will probably be cured. There's people with rising PSAs. And then there's people that develop, metastasis, and there's people that develop hormone-resistant metastasis. And that's what he sees. He sees the hormone-resistant metastasis profile because, to fly off to the Mayo Clinic is a serious undertaking. And so it's the people that are in more desperate straits that are headed out there, and they should be going there. It's the right place to go. But his idea that everyone needs a PET scan, because even if their PSA is 0, should not be interpreted broadly to other people with early stage prostate cancer. Those people, they're not going to find anything. They don't have anything. His particular profile of serious prostate cancer patients indeed will have uptake of cancer sometimes when the PSA is 0. And there's still activity. And we do PSMA PET scans in men with known metastatic hormone-resistant disease with 0 PSAs. The PSMA PET scan, and this is hard to believe I'm saying this, is more accurate than the PSA. So we've taken PSA as the biblical truth now for 30 years. And now we've got a test that can actually reveal active cancer in people with undetectable PSAs. And I think it's a standard of care now. If you've got someone that had one of these more serious types of prostate cancer and everything looks good, I would get a scan and make sure everything really is good. And if it's not good, there's something you can do about it now. Let's say you find a hot spot here or there with SBRT. Dr. Kishan showed us that we can safely just zap those spots and possibly change that patient's future.
Yeah, I mean, that's well put. I mean, I was very terrified in bringing up the concept that your PSA could be flat and your disease could be moving and the scan would pick it up. The reason I was scared to bring it up is because I just felt out there in YouTube land that a number of people would think, oh my gosh, that's true of all the cancers out there. I need to get my scan. So I didn't want to create too much hysteria, right? I mean, we're talking about a small percentage.
Yes. And in that segment, the type of patients that are seeing Dr. Kwan, they've been through chemo, their doctors have told them there's nothing more we can do. They go see Dr. Kwan and he comes up with some useful, practical solutions for them. But that's a segment, actually a rather small segment thankfully in this modern era, that's maybe only 10-15% of men with prostate cancer. It's a lot of people because there's a lot of people with prostate cancer, but most of the men out there have a much safer, less dangerous variant of prostate cancer that's never really going to threaten their lives. They're not going to need to be doing PSMA PET scans with PSAs of 0. And I know Dr. Kwan would agree with us, but the segment, he's out there on the front lines fighting the worst battles with some of the most challenging cases.
Yeah, no, it was very, where I was disappointed in him is he didn't know the unofficial mascot of his college, which is the squirrel. And I was disappointed that he couldn't tell me what the official mascot of the Mayo Clinic athletic teams were. And it was so funny. He said, wait, he had to actually think. This shows you.
I had to think about it. I saw that. It's just like, well, maybe we have bad athletic teams that I didn't know. No, we don't have it.
And for those of you who are new to PCRI, I've been doing this for 15 years at the conference. I'm not making fun of them. I'm trying to show you that if your doctor is really good at golf, there's a problem. Meaning because the really top-notch players are the guys like, even, in your age, you're not that old, but even your age, you're in there, you're immersed in it every single day. And if you're not immersed in it every single day, you lose that edge. And so what I was trying to demonstrate when I threw this curveball at him is, this guy is so in his world, he has no idea that Mayo Clinic has never had an athletic team. And I said, if you do, I said, your mascot should be the PET CT scan. I actually laughed at my own joke.
I laughed at that. That was good.
So we talked about PSA staying lows. We talked about the different scans. We talked about Axumin, PSMA, choline. The two things that we touched on, you can touch on it now or you can wait till the end, but you can touch on this now because we didn't talk about it with Vogelzang at the end. I told him how frustrated I was that the FDA just okayed a PARP inhibitor as adjuvant therapy in early breast cancer. What I was trying to show is that, look, even PARP inhibitors are moving very quickly in breast cancer and other cancers. Pancreatic, they're looking at it. Do you want to talk about the PARP inhibitors yet, or do you want to wait?
Well, let's do it as part of our talk about Dr. Vogelzang, because he shared some really good stuff there.
Okay.
Let's see. Now, when we jump on to our Dr.
Kishan.
Dr. Kishan, the first thing that I wrote on my notes was Blue Star Donuts. We'll skip over that. We already got that. And then let's see. Oh, I know what I really loved how he articulated so clearly. I'm sorry to put people to sleep with numbers, but he said very succinctly and concisely, patients need to think about absolute risk versus relative risk. And, there's statistics, and then there's, what is lies, damn lies, and statistics, according to Mark Twain. Well, statistics is all we got in the prostate world. And if someone says, look, there's a 10% chance my treatment's going to cause you to be impotent, or there's a 30% chance the cancer is going to come back, but we're going to do all these dreadful things to you. These are the kinds of things that people use to make big decisions.
That's right.
And so you have to be careful when someone tells you, I will give you this hormone treatment, and it'll cut your risk of relapse by 50%. I'm in, let's go. But in the small print under there, it says, but your risk of relapse already is only 5%.
Yeah. So we might take it to 2.5 in that case. So
you're actually only cutting, it's only 1 in 50 patients that have that treatment will truly benefit. 49 patients will get all the side effects and no benefit at all. So people have to be very careful when they're listening to statistics. Are we talking about relative risk? Oh, it's going to cut the risk by 40%, 30%. Well, tell me what my risk is first.
Yeah.
Is there a 50% chance that it's going to come back?
Yeah,
wow.
Yeah.
Well, I love the idea then if it's a 50-50 chance that it comes back and there's a 50% reduction in relapse, then I'm going to go from a 50% cure rate to a 75% cure rate. That's big. That's worthwhile. So you can't look at risk reduction until you know the risk. I guess that was something that, and he said that so adroitly and so clearly, and people always go to sleep when you talk numbers, but it's unavoidable in this prostate world. It's all we got are these big profile studies that give us percentages. And these are this idea of understanding your relative risk versus your absolute risk. That is a very important concept for people that are good shoppers and looking at their options. Ask what my true absolute relapse rate is. And then how much is it reduced by this? You want to give me hormones for 18 months to improve, to cut my risk of relapse by 50%? Well, if my risk of relapse 50-50, maybe 18 months of hormone therapy is a prudent choice. If there's only a 10% chance it's going to come back and it'll go to 5%, that means there's a 1 in 20 chance it'll change my future. 18 months of hormone therapy and a 70-year-old, you'll probably have low testosterone the rest of your life.
It's interesting you brought up that, the statistics. How much I love that. I mean, that's true, though. He brought that up, and not many people bring it up in terms of the importance of really understanding your personalized risk, because statistics are based in populations.
Yeah.
Right. And
each one is an individual.
Exactly.
The other thing he said, and the reason I'm just talking over you today, Mark, is you've already done this for 12 hours.
I'm exhausted. I'm actually really enjoying this. I'm telling you, I've got 12 hours.
I'm taking Dr. Moyad on my back, and I'm carrying him to the finish line.
No, I'm glad, because I want the audience to know I'm sick of me. You have to understand. So I'm really enjoying this. I'm enjoying this educational session, and I'll throw in an opinion once in a while, but You keep
Well,
going.
you've been carrying
preach, as
me.
we say. We want you to preach.
You've been carrying the PCRI, and you've been carrying me for 15 years, Dr. Moyad. And we really look forward to seeing you in person in September. I know I keep coming back to that, but everyone is so excited about that. All the patients have, when are we going to get together? When are we going to get together? So September, unless we get a new COVID variant, we're going to be there. All right. So the other thing he mentioned was this proprietary genetic testing that can be done. There's a difference between getting SBRT over 5 to 10 days and getting standard radiation over 5 to 8 weeks in terms of how your immune system reacts to that. And Dr. Wheathouse, as he pointed out, has a mouse swab that can help people determine whether or not they are likely to get toxicity from one or the other approach. Pretty cool stuff. And he charitably said, we'll help you get this done if you need it. So if someone is considering SBRT, that might be something to give Dr. Kishan's office a call about. All right, so let's move on then to.
I can't let you move on because I didn't ask Dr. K about one thing because I told him there's no time, and he said you should just get a second opinion, and that's something that you're pretty familiar with, and that's HDR brachytherapy.
Yes. Yes.
Can you comment on who you like to see get that, or what's the situation there? Because you have to admit, the real appeal of SBRT, whether you've had surgery, whether you've not had surgery, it's the very few number of days in the treatment, right? That is just so appealing. I mean, when people hear 5 days, they go, "This is incredible." Now, I didn't give you.
And the fact that now I think with SpaceOAR, it is as safe, typically, as traditional radiation in expert hands. It's just as safe as the patients that go through 5 to 8 weeks. So that was an important breakthrough, the SpaceOAR, because the big concern with rapid treatment is the rectal wall going to experience higher burn rates than if you give smaller amounts over a longer time.
Yeah.
And that was, in some studies, there was this, maybe it is causing a little more problem. But now with the SpaceOAR moving the rectal wall out of the field, all of a sudden SBRT is prime time because of its convenience and its effectiveness. So that I think is not only the fact that it's more convenient, but I think we can be very confident in expert hands that you're not taking any increased risk with that wonderful convenience. But to answer your question, I think it's a good one. Is there a different demographic for people that do beam radiation? I'm not just going to call it SBRT. Proton therapy, IMRT, CyberKnife, SBRT. These are all forms of beam radiation versus some sort of brachytherapy. Well, there's a couple of issues. One, again, it comes down to if someone's going to be doing these complex things, who's going to do it? Just like if you were picking a surgeon, you should be picking your radiation therapist. Find an experienced, skillful person with a good reputation that really knows what they're doing. That's the baseline. So if you're comparing brachytherapy to SBRT, we want to be comparing top level. That's always my assumption. Why would anyone go to a second tier doctor if you can go to a top level doctor? They charge the same. What's the difference? All right. So with that assumption in place, the things I like about brachytherapy, perhaps a little bit more than SBRT, are the fact that none of the radiation gets beamed through your healthy tissue to hit the target. All the radiation stays in the target. And that does allow them to increase the dose a little bit. And so in the only randomized trials that we have, the brachytherapy cure rates were about 20% higher than the beam cure rates. So people say SBRT is recapitulating brachytherapy doses, but that's only a theoretical claim. So who am I using SBRT in? Well, the concern about radiation exposure starts to die out when we get to be 70, 75, 80. I mean, I know we all think we're going to live forever, but we're not. The onset of secondary tumors, which is the main thing you would worry about with all that radiation exposure, it takes 10 to 20 years to occur, at least if it happens at all. Mm-hmm. So if someone gets in their 70s, the convenience of not going in the hospital, going through anesthesia, having things, stuck into your prostate, they can just go as an outpatient, what did he say? It was like a 20 to 60 minute visit, 5 visits, a lot easier than going in the hospital to have a procedure, which is what brachytherapy entails. So I tend to default more to brachytherapy, and there's 2 types, as you know, the permanent seeds and the temporary seeds. They're both probably equally effective. The permanent seeds are much more convenient because those can be done in probably a 1 to 2 hour outpatient procedure, whereas the temporary seeds take a day or sometimes 2 days to deliver the whole treatment. So I tend to put the permanent seeds into the kind of the slam dunk cases. There's some men with 3+4, 4+3 that have negative PSMA PET scans, no Mets. They just want one and done. Get those permanent seeds are probably the best treatment for those folks. And then you have the temporary seeds. The beauty of that is that with the technology they have, they can treat outside and around the prostate. They can treat the seminal vesicles. So anytime you have a more bulky tumor or something that looks like it's outside the gland, I tend to go toward the temporary seeds for those folks. And then the beam radiations, and I think SBRT leads the pack now in terms of convenience and whatnot. I think it's for the people that have the sevens, relatively favorable types of cancer that does need treatment, who are perhaps in their 70s or whatnot, and just, hey, let's get rid of this. Let's make it simple. So those are the demographics that I think in general terms, there's always exceptions and unique custom aspects to many patients, but that's how I tend to think of the two different types of brachytherapy in the context of SBRT.
No, that's helpful. But what about the time dedicated to getting temporary brachytherapy? How much time? Because again, it's that 5-day thing with SBRT. Hey, we're 5 and everyone gets excited. I understand. But can you just enlighten the audience on HDR brachytherapy temporary? How much time do I got to devote to getting that?
Yeah, so think of it as like a day in the hospital with some porcupine quills hanging out of your perineum for 12 to 16 hours. That's temporary seed, but it's now they're past it. They're happy. They're cured. They have minimal side effects. So there is a risk of ED, just like with any type of radiation. But I have permanent seeds, that people go out, have the dinner permanent seed implant. But being in the hospital for 12 to 18 hours to get the temporary seeds and having those catheters hanging out of your perineum, people can go online and look at the pictures. It's very involved. It's involved for a reason. They're trying to deliver high dose treatment very quick and very precisely. There's a whole team of people that implement this sort of thing. And you need not only a good doctor, you need a good team. And it's teamwork. So anyway, those are some distinctions that come to mind. I go on and on about this, but
no, that helps because I didn't want this to be the SBRT show. Then I decided I'm going to make it the SBRT show because it is the #1 question that seems to be out there in terms of, can I get it? Do I qualify? What's the catch? And somebody had to cover it in 2 hours. And there's plenty out there apart from HDR. There's plenty out there on protons. There's plenty out there on just IMRT and going through 6 to 8. There's just not still enough out there for the 5-day HDR. So I'm glad you did that comparative. By the way, I was shocked that he didn't know that his boss was in the movie Planet of the Apes. Because let me tell you, in a department is like a mini village. If you hear anything good or anything bad, you hear it within 15 seconds. And so if I was in Planet of the Apes or Star Wars, let me tell you, everybody would know. And I was surprised he didn't know that his boss was in that movie.
Yeah, and it seemed like he's the kind of guy that knows everything, doesn't it? I mean, I was so impressed with him. It was, I'm familiar with Dr. Kishan, and I've referred patients to Dr. Kishan, and he's just so low key in the interactions. He always knows all the answers. And your interview of him made me realize, well, this is why he knows all the answers. This guy's one unusually smart person. Yeah. Thank you for your time with him. And SBRT, I think, is leading the pack in terms of the most desirable variant of beam radiation. So I think it was very appropriate that you spent that time.
Yeah, I think so too. I mean, he wanted to talk about getting SBRT after a radical prostatectomy. This is off camera. We didn't have time. Can you get SBRT after you've had a radical and now you have recurrence? And so do you want to answer that? But I wish I would have given him the time to answer that.
Yes, it is feasible. You do need to go to a center that's been doing SBRT for a while. And I think this is something the PCRI always struggles with, the fact that when new technology comes out that we know will be the standard of care in 5, 10, 15 years, we don't pull any punches. We say, go for it, go get it. The problem is that maybe we don't communicate as clearly as we should, is that all the different centers across the country and around the world, most of them, because it's new, are still in their learning curves. And they are still in their learning curves with SBRT. They're still in their learning curves with learning how to read PSMA PET scans. They're still in their learning curves with many of the new innovations that we're pounding the drum for. So that is our patients who are seeking out state-of-the-art optimal care, which is really worth your time to do that, definitely need to seek out the places that have done that. You don't want someone in the back room thumbing through the manual, figuring out, okay, SBRT for PSA relapse. You want someone that's done it enough. And there may only be a few centers in the country, but if it's only a 10-day treatment, why not go to one of those centers?
Yeah.
Hang out in a hotel room for a week and a half, go to a state-of-the-art place that's done a lot of SBRT for a PSA relapse. Don't go to someone that says, oh, yeah, I think I can do that.
Yeah. You remember that book you did with Blum, Invasion of the Prostate Snatchers?
Yeah, we got a new second edition out. Thanks for mentioning it. And that's my.
No, that's not why I mentioned it.
No, but it's okay. We're going to talk about that now. That book is very near and dear to my heart, and it is designed for patients to help them convince their friends that they know are going into making a bad treatment decision, to get them to slow down and to know their options. So, Invasion of the Prostate Snatchers. Now, you had something less important to talk about? I'm sorry, go ahead.
Look, it's a great book, but I'm going to come out with a book called Invasion of the Prostate Radiators. In other words, those are all the radiation folks that shouldn't be doing radiation, that cause all the side effects, and then they got to go and see Brady, and he's got to go do all those complicated procedures. You got the PROACT, you got the sling, you got you got the artificial sphincter. So I love your message, but the truth is, and the only reason I'm trying to corner you here is that I have learned is that radiation has become the golden child of prostate cancer. And when you have the golden child of prostate cancer, a lot of people want in on the action, even though they might not be that competent. So I'm just telling you that once your book comes out, I'm doing a follow-up. I'll let you write the foreword. It's called Invasion of the Prostate Radiators, or the Prostate Burners. And so I would be honored if you would write the foreword to that book.
Well, if we can't talk about seeking quality enough, we can't be repetitious enough, because people want to believe that the doctor sitting across the table, it's just too hard to find a good doctor. So everyone sort of defaults, well, I hope this is my guy. I hope this guy with this nice smile, I hope he knows what he's doing. I don't really have the ability to find out if he does or not. I'm stuck. I'm just going to go for it. And how do you find out if they're really good? Well, I think one unbiased resource is patient support groups. Patient support groups don't have an axe to grind. And there's been people that have been through this, people that have turned out well, people that have had problems, and you can look at that. The other thing is, believe it or not, as sad as it sounds, I think some checking of online reviews is useful. And you would hope that the person you're seeing has got a significant number of reviews. If they don't have a large number of reviews, then they're probably not seeing a lot of patients with that problem.
Yeah.
So to not only have a significant number of reviews, but also have favorable reviews, that seems to be like, why would I go to anyone that doesn't have favorable reviews? It's just like, so those two basic things, support groups. Yeah. Then the third one would be your family doctor. If he's referred a significant number of people to this particular physician, he has, unless he's playing golf with him, hopefully not, that he is,
or she.
Yeah, I mean, there can be, sometimes there's an interplay between physicians, they're referring back and forth to build their practices. That's not what you're looking for. You're looking for an unbiased primary care physician that is looking out for his patients, that is seeking quality. So those are your three resources for finding good quality doctors. And the fourth one is, if you already have one good doctor that you know is world-class, they tend to be able to pick other world-class doctors, but it's not a universal. I've found a lot of world-class doctors that don't recognize that they're different from everyone else, and they think that just kind of everybody's like them, which is certainly not the truth.
No, those are really good things to look for in your check. I would add as extra credit is something I just wish I would change. And that is, if I get another phone call or a letter that says, if I get a second opinion, do you think that's going to offend my doctor?
Well, it might.
No. But I understand why they're asking the question. But the fact that we are still playing, and we are a 1940s or 1950s game where you can't go up against a doctor and get a second opinion. I am going to say what I constantly say in lectures all the time, and I say in front of healthcare professionals. You have to accept the fact that you are the business, they are the customer. The customer can decide to get pizza, not just at Domino's, but they can also go to Little Caesars and see how that tastes. And if they don't like Little Caesars, they can always go back to Domino's or another place. Medicine is a very similar fashion. If your doctor is offended by a second opinion, that might be a red flag that might not be your doctor in the future. That's someone who's not looking out for you. I love it when people go, you know, I really appreciate your advice on lifestyle or supplements or whatnot, but I'm going to go to Joe Blow and ask him. I go for it. I've been doing this 30 years. I'm perfectly comfortable in my knowledge. And if there's something else out there I'm missing, I want to know about it. The good people want to be challenged. It's like, give me something I don't know. So you helped me bring up something that's really important, that all these check boxes, but you know, I still get those calls like, am I going to offend my doctor so that my doctor won't see me anymore? And I just go, you know, and I'm not mad at this person. I'm mad at the fact that we still have to think that way.
Yeah.
Anyway.
Yeah, it's the stakes. The stakes are just too high.
Too high.
To not risk offending people. Yes, the doctors, like everyone else, we have sensitive egos, and sometimes our feelings are hurt. But on the process of people getting to the promised land of cure without damaging their quality of life, there can be some battles along the way. And you know, polite, good, courteous communication goes a long way in terms of you know, handling the, you know, smoothing ruffled feathers, and some of us have more skill at that than others. But if you are lacking in that area, you know, it could create more waves. But I agree with you 100%. If you have a doctor who's so offended by someone looking out for their own best interests, that could be a sign that that's not the right doctor.
Yeah. Wow. Okay. Now I'm gassed. I got too emotional there. Do we want to go?
We're getting it. We have one more. We got Dr. Vogelzang.
No, I know we only got 15, 20 minutes, but I can bring up this last point after Vogelzang. So let's go to our last speaker.
Great. Well, so Dr. Vogelzang, it was very enjoyable seeing how, I know you guys are old friends, and getting him to talk. I mean, there's so much. Everyone obviously needs to spend time looking and thinking about what that video was about. But the big breakthroughs in the advanced oncology space have to do with patients that have come through the door and they haven't been screening their PSAs, and they already have metastatic disease. And there is new information out about that now. Unequivocal, high quality, first tier science that shows that you're going to live longer if you don't just do Lupron alone. And believe me, there's still centers that are just giving, oh, you have metastasis, we'll just give you Lupron, and then if that stops working, we'll add something. Big mistake. So there's a number of studies that show that you want to be on a first and second generation hormonal therapy, Lupron plus Zytiga, Xtandi, Nubeqa, or Erleada. That's a no-brainer, randomized prospective trials. But people say, well, the results of that have been so good, we don't no longer need to give the Taxotere chemotherapy that used to be the standard in these people with advanced, you know, that come in the door with advanced metastatic disease. And so they would get either, when they were in the past, they would get Lupron plus Taxotere. And then when Zytiga and Erleada and Nubeqa and Xtandi came along, they said, well, that has less side effects than Taxotere. So we'll stop the Taxotere and we'll give them the second generation hormone therapy. We'll get lots of bang for the buck, postpone the bad things that were destined to happen because of this more potent treatment. Now, it's logical, since Taxotere and the second generation hormone therapies work by different mechanisms, that you might get even better results by adding all three, Lupron plus second generation plus Taxotere. And we started doing that years ago just because it made sense. And Taxotere is not that bad. 4 to 6 injections every 3 weeks, and you're done. So there are now 2 randomized first tier clinical trials showing substantial improvement in survival when you take Lupron, second generation hormonal therapy, plus Taxotere in the people that have metastatic disease. All right, to me, that's the standard of care. Not to me, to all of the medical field now, that's the standard of care. And people that aren't being treated that way have to ask why. Is it because you're 90 Is there some other extenuating circumstance that maybe you want to pull back a little bit? Otherwise, it's non-negotiable, standard of care. So now, what can we imply from these facts? These are absolute immutable facts. Well, what about the patients that have other earlier metastatic disease? Let's say they've had a radical prostatectomy and they found a couple lymph nodes. And now the PSA after the operation, let's say it was a Gleason 8 or a 9, they had a couple lymph nodes, now the PSA is 0. The surgeons want to watch those folks because a certain percentage of those, maybe 50% in some cases, if they only have one lymph node, probably not that high, will remain permanently in remission and they won't have to endure hormone therapy. They won't have to endure chemotherapy. But this is where that absolute risk versus relative risk argument that Dr. Kishan talked about comes into play. You say, well, doctor, really, what is my cure rate? I had a Gleason 9 and my PSA is 0 now. And the doctor will say, honestly, well, there's an 80% chance that this is going to come back in the next 10 years. Wow, if I could reduce 80% by half and reduce it to a 40% risk it'll come back, I like those. I like that. Where can I buy that? And it's very logical then to consider, well, we know it works in men that have cancer all over their body to give 3 different types of anti-cancer therapy, Lupron, second generation, and Taxotere. Why wouldn't we apply it in these men? And the principle has been there for years in breast cancer, colon cancer, lung cancer. It's not like we've come up with a brilliant way to utilize these treatments. It's like almost a no-brainer. So, but you'll find that the standard of care, if someone has surgery for high-risk disease and you can, based on historical factors, you can predict who's going to have it come back, the surgeons are going to tell them to watch it until the PSA goes up. Well, now you've just given the cancer, 12, 15, 24 months head start, and now we're going to try and cure it. Why are we doing that? So I think that's the power of these phase 3 trials that show that for advanced, newly diagnosed metastatic disease need 3 different types of treatment simultaneously. And realize the patients that in these studies that only got 1 or 2 of the treatments compared to the 3 who did worse, it's not like they never did get Taxotere or they never did get second generation. They just postponed it until the cancer progressed and they did much worse. So we want to attack the cancers at an early stage when they're vulnerable, not the ones that are already cured. We can figure out who those are, but the ones we know we're going to have a problem in the future. We want to start to use more aggressive stuff right away. And this is was stated by Dr. Kwan. I'm quoting him. He said, the standard, unfortunately, in the community is to use sequential palliative treatments till the patient dies. And it's basically a self-fulfilling prophecy. We're saying it's hopeless, therefore we concede that we can't cure it. Well, it's not true. Now we know with these powerful drugs that we can improve the cure rates, not just we will extend their lives, but we can also improve the cure rates.
I think doctor speak in vernacular has kind of thrown a curveball in the game, meaning that, so when you say, so we're all on the same page here, this idea that chemo is not going away. Chemo is as strong as ever in the field of prostate cancer, arguably, right? But when people say, we even give it in this case, those 3 drugs when they're metastatic, I guess what I'm hoping more people do is define what the word metastatic means. Because some people define metastatic as that means I got disease all through my bones. Other people define metastatic as they're no longer in my regional lymph node area. It's my non-regionals or something. They call that metastatic. And then there's a third group, oncologists I've noticed, they'll call anything outside the prostate that's moving already within the pelvic area metastatic. Can you comment on that? Is that part of the problem here?
Yes, it is part of the problem. And, us insiders are so immersed in it, we haven't delineated it as clearly as you just did. And the answer in my mind, now, if I find a couple of lymph nodes in the pelvis in someone who's 84 years old, with these new PSMA PET scans, the last 2 patients that I've seen this, oh my God, it's in the lymph nodes after, they may have had this for 20 years. And let's say the PSA is 8, but there it is, it's metastatic. And the last 2 early 80-year-olds, healthy guys, I said, this technology is so powerful, I'm not sure that we need to treat it. So what I'm going to do is I'm going to get another PSMA PET scan in 3 to 6 months and see if this is changing over time. You're 84. Okay. Do I want to put you on hormone therapy right away? Well, if it is starting to progress in the next 3 to 6 months, we'll put you on some Casodex, and that'll keep it in check for 10 to 15 years. You'll be fine. So that it's a context of age. Now you have a 52-year-old that has a radical prostatectomy. He's got one lymph node. You've got a cancer in that individual that has proven biologically it can get outside the gland, put down roots, and grow in another part of the body. That's terrifying.
Yeah.
So it may take that cancer 25 years, 20 years for it to progress on to actually being life-threatening. But then he's 75. You know, we're aiming much higher than that these days. So that's the kind of person when I started thinking, let's buy some insurance against the possibility that there are other specs out there, and let's see if we can get rid of them now. So you contextualize it. So metastatic disease, to answer your question, for me is anything in a lymph node outside the prostate. Seminal vesicle invasion, extracapsular extension right outside the prostate, that's a different thing because the cancer grows directly. It hasn't proven that it can break free into the bloodstream and land somewhere else, or in the lymph and land somewhere else and grow. That's not been demonstrated in that patient. But if you find just one lymph node, I'm calling that metastatic, and I'm treating it if it's a younger patient. I may watch it in an elderly patient, but younger patient, that's metastatic.
And you're treating it with all those heavy hitters?
Well, I will talk to you, absolutely, because it's only a minority of people that have prostate cancers that can spread, and they're the ones that give prostate cancer a bad name. They're the ones that, you know, you try one thing and then it goes away for a while, and then it's back worse. And then you try one thing, it goes away for a while, it's back even worse. And then we're looking at a 10, 15-year horizon. We're not looking at, the doctors tend to think if I keep this patient happy a couple of years, I've done my job. But not in prostate. We're looking at decades of where we're going to be 10, 20 years from now. And this is one thing I think that maybe a good lead in for us to talk a little bit about, something that we always touch upon, and which, of course, you're one of the world leading experts in, and that is the fact that most of our prostate cancer patients are not dying of prostate cancer. They're dying of heart disease. They're dying of other unrelated problems. And lifestyle issues, for that reason, have as much or bigger impact on longevity than all the things we've talked about today. We're winning the battle against prostate cancer. And the goal is to, live into your late 80s, early 90s with a good quality of life. And people aren't doing enough in the other departments. Thankfully, people that are online looking at YouTube videos, visiting people like Dr. Kwan, they're going the extra mile to make sure that they've done all they can do. But as you know, the hard day-to-day choices about what we eat, our exercise patterns, have far more impact, not only in longevity from the prostate cancer, but also to the broad spectrum of men that have prostate cancers that will never hurt them.
It's really unbelievable. And like that's why I said, sometimes some of the researchers are looking at me funny. I'm going, you did this trial in 2001. Did you look at the average BMI? And they go, yeah. And then I said, did you look at the average BMI? I don't care if this is Canada. I don't care if this is Europe. Are you looking at the average BMI of the man now who's in the clinical trial? I'm not kidding. The BMIs have gone from 23, 24 to 29 on average. This is before getting hormone therapy.
Well, we've all seen it walking around the sidewalks.
Exactly. So people want to talk about people want to talk about this obesity epidemic, but they don't really want to talk about it. Meaning, let me tell you how it's really impacting. And this is why I decided, I was just going to dedicate the rest of my life to education, because the reality is you can pretend for so long about the elephant in the room until you have got to face the fact. And I joked with you that if you were going to treat someone with prostate cancer and you thought that they were going to live for 20 to 25 years, I said this at the meetings, that they had to sign a contract that said that they would do everything possible to reduce their risk of cardiac disease down to zero. That means they would really be improving their quality and quantity of life. But let me tell you, Mark, how things have changed in my lifetime, because when I said heart healthy is prostate healthy in a 2003 publication, I didn't realize I'd be one of the first people using it in PubMed. Second of all, if I would have trademarked it, I'd be rich. I'd never have to work another day in my life. You'd be buying me donuts, man. That's all I can say. But think about how this has changed in 2022. It's remarkable. So not only does this paper come out in the SEER database that says, this is the trends and incidence of metastatic prostate cancer in the US. This was just published March 14th. And so there were two papers, one, the Gill group that said we're seeing more metastatic disease. And then there was another paper a few months ago that says, okay, we're seeing more metastatic disease, but a lot of these men are still dying of cardiovascular disease, even though they have metastatic prostate cancer, right? So first of all, you got the high incidence, the increased incidence of cardiovascular disease, the #1 killer of men for over 100 years in a row. It's the #1 cause of death in men with prostate cancer. And paradoxically, I wrote this recently in a column. Paradoxically, many of our effective prostate cancer medicines, if you don't watch out for yourself, will increase your risk of a cardiovascular event, right? So now it's some of the drugs we use. Now it's just your average risk. Now the trends are going up. I could argue COVID was a cardiovascular disease in one sense, how it increased the risk of strokes and heart attacks and blood clots. So really, people always say, what do I tell my kids? Or what do I tell my friends? Or what do I say to do? And I always go, one thing has never served me wrong. You try to take your cardiovascular risk to as close to zero as possible, and it will pay off for everything else from head all the way down to the toe. You're doing everything possible. And it's not demeaning prostate cancer. It's respecting prostate cancer. And what did Vogelzang say, which you know as an oncologist, that as the disease spreads, the chance for a cardiovascular event also increases because those metastatic sites go mess with the endothelium and the blood vessels, right? So there's an increased risk for blood clots. One of my friends, for example, suddenly had a bunch of blood clots, and then nobody could figure out what it was. And then one smart doctor at an institution said, I thought he might have advanced cancer, and they found an advanced cancer, right? So cardiovascular disease is also an expression of the cancer as it spreads. So if you look across the spectrum, it's really the word of the day is reduce your heart disease risk to as close to zero as possible, regardless of what you think you might succumb to.
Do you remember Dr. Matt Budoff that we had, I don't know, 10 years ago? He was a proponent of these heart scans to see how much plaque you have on your coronary artery.
CACs, coronary artery calcium scans.
Yes. I think we should think about someone of that skill set for September, because I think we haven't visited that for a long time. I mean, if you've talked about statins, metformin, and baby aspirin as the alternative approach to supplement prostate cancer treatment. All of that is very much along that theme as well.
Yeah, no, that's a really good point. I mean, I know you've sent people for coronary artery calcium scoring. It doesn't require any dyes. It's no contrast. It's basically a CT that takes a picture of your coronary arteries. And the more calcium you have in those arteries, the higher the risk of a future event. I mean, there are more direct methods, but those are more invasive. And it's turned out to be this thing that was kind of interesting. And now it's really grabbed a foothold in terms of risk assessment, especially for all those men and women watching today, where nobody can figure out where you belong. Are you high risk for a cardiovascular event? Are you low risk? We're not sure. Some of your numbers say you're looking good. Some of your other numbers say you're looking bad. Your family history might be okay, but then you had this thing happen. And so what a lot of people are doing is they're getting these CACs, these CT of the coronary arteries to try to break the tie, to add more information to tell you exactly where you are. And they've really been dropping in price. They become more safe. It takes minutes to get a picture. And as long as you know the pros and cons, I'm glad you brought it up. And I'm definitely going to bring it up at the conference too. It's become a powerful way of assessing your cardiac risk when you're not sure, and neither is your doctor.
Yeah, and it's a wake-up call, because coronary artery disease, as we've known it traditionally, first is you had a heart attack. And and so this gives you some advance notice. Going rate for these scans, and insurance will often cover it, but if not, it's like $150. Takes 5 minutes to get the scan, and it helps you know where you fit. With 10-15% of the people come back and there's zero plaque. I mean, they'll do another scan in 10 years. They're golden in that regard. I mean, it's not uncommon for us to find people that have a lot of coronary plaque that they had no idea of, and there's things you can do. Statin drugs and whatnot can help stabilize or even reverse plaque. So it's not like, wow, we found the bad news, we're stuck with it. There's actually things to be done.
That's the thing. We are on the precipice of incredible work going on in cholesterol lowering. So what's happening is you've got all these statins out there. Most of them are generic. You can work with them. And now you have these things called PCSK9 inhibitors. So these are injectables that if you can't take an oral drug, it's an injectable you give yourself every 2 to 4 weeks. And this thing can take your bad cholesterol from 130 down to 50 easily. And a lot of people really like it. They used to be very difficult to get covered by insurance, but now it's becoming easier and easier. More people are getting in the game. This cholesterol has had an incredible year, and an incredible year by meaning all these trials to study it, to see if it can reduce the risk of prostate cancer recurrence. We know it basically downregulates some adrenal androgens. In the past year, there was a study that suggested it might increase the chances that if you're going to be diagnosed with prostate cancer, you'd be diagnosed with significant disease, not non-significant disease. It stabilizes the plaque, on and on again. But as we finish up here in our 2 hours, I want to make sure we get a couple of the main points from Vogelzang across. And one of them we've been teasing out for the past 2 weeks. And there it is, right there. Pluvicto, I assume, is the name. This just came out 2 days ago, Thursday. What are we, Sunday?
Yes.
Thursday, right. So do you want to talk about this and also tell the audience why it's not just the men with metastatic prostate cancer that should be watching this, but all of us should be watching this new FDA-approved drug. And before I let you talk, I got to tell you, if you want the best reason of all, I'm so glad we did this conference and doubled the size finally after 8 years. And for the audience who doesn't know this, we're sitting at a hotel room eating peanuts and having water. And one of us goes, hey, why don't we just do 2 conferences? And that was pretty much it. That was the genius behind this. And now we're moving to this conference being as big as the fall conference. And here is a classic example of why you want 2 conferences a year, because this came out a few days ago. And if we were talking about this in September, it would already be too late. We need to be talking about this now. What say you, Dr. Red Jacket?
Yeah, it's thrilling. I mean, how many arrows do we have in the quiver for someone who has developed hormone resistance? We have Provenge, which is an immune therapy. We have Xofigo, which is an injected form of radiation that treats the bones. We have Taxotere, Jevtana, carboplatin, which types of chemotherapy that Dr. Vogelzang introduced and you talked about as well. And so the second generation hormone therapies presumably have already been tried. So if these things aren't working, then we are dealing with a really serious situation. We're running into what kind of experimental therapies can we do? By definition, we're talking about the type of prostate cancer that's life-threatening. So when it's something relatively non-toxic, this is just an injection every 6 weeks that can cause some mouth dryness, something relatively non-toxic that's proven to prolong life in people that don't have a lot of options, it's absolutely thrilling. As you have mentioned also with the other doctors, as this has come up appropriately in your discussions with them throughout the conference, there are already trials starting up to see what is the role for this going to be in men with earlier stage disease. What kind of, should it be ancillary in the oligometastatic patients? The oligometastatic disease, where people just have a couple mets and they may or may not be hormone resistant. Studies are now clearly showing that you should have those, if you have fewer than 5 spots, in most cases, they should be zapped with SBRT. You're going to do better. Makes kind of sense. Why let cancer go when you can do a non-toxic treatment like SBRT and zap the spots, whether it be the lymph nodes or the bones where prostate cancer usually resides. Even the liver or the lungs can also be treated if there's spots there. Less common sites, but occasionally they happen. And so the studies that I think are going to be starting up at UCLA is in those patients that are going to get SBRT anyway. Would it be beneficial, since we know that most cancers respond better to treatments when there's less cancer?
Yeah.
So there's 5 spots that are seen, and we know most cases there's other smaller spots that are being missed, even by the PSMA PET scans, even by the C11 choline scans. But if you could give this injection that it goes and swims around and finds little tiny spots that can't be seen, will those patients do better? Will some of them be cured? Or a higher number be cured? Some men with oligometastatic actually do get cured. It happens. I've seen it. But the majority won't. It'll give them longer life, a better life. Maybe they'll even be able to stop their hormone therapy for a while, have a better quality of life. So that'll be the next step with this. And that's starting up already. People are excited about it. This will become a very standard mainstream treatment for people that have had some chemo in the past, like Taxotere. And it's going to be a very desirable treatment. It will be covered by Medicare almost certainly, and other insurances as well. And it's going to benefit a lot of people without a whole lot of side effects, which is maintaining quality of life.
Yeah, I'm glad you're excited about it. And, not to toot our own horn for a second, but sometimes you have to. We were talking about this at the PCRI meetings 4 and 5 years ago. There were people, remember that? There were people going over to Germany to get this and
Yep.
other places. They were getting it 3 or 4 years ago. And some people said, you guys are gaga. This is untested. And I'm going, well, I understand, but you know, it's the Vogelzang, Scholz, and the mantra, which is, if you want to keep going, we can keep going. And we should feel good about this, like the PET CTs. We were doing 3 and 4 years ago, people were going over to Germany for this, and now it's here. So I'm glad you're excited. What I was going to ask you is, you've been smiling a lot these 2 hours. What's going on here? You've been smoking the devil's lettuce or something like that. I mean, you've been smiling more than I'm used to, for especially on oncologists. Oncologists don't smile that much. They're kind of depressing. But is there anything are you sitting
remember,
on a cushion or something?
I've cherry picked all the favorable cancers by doing only prostate cancer. I really have a lot of respect for my colleagues that treat lung cancers and pancreas cancer. No, those things are, you're really on the front lines. I don't know. I might be energized, Mark. We've switched a lot to phone visits in the last, ever since the COVID and insurance companies started paying for phone visits. So I'm literally seeing probably twice as many patients in a day as I used to, but probably 60-70% of them are phone visits, 10, 15-minute conversations with people all over the country. And we're helping a lot of people. Yeah. And I'm doing more efficiently and more energetically, something I've been doing for 20, 25 years, and I enjoy my work. And so I think this, you're basically just stepping into my world for these 2 hours. This is what I do all day long. If I can't do it with a smile, I'd better quit. I'm a very busy
impressive.
guy.
We've been doing this a long time. You're always on your game, but you're really on your game today. So I do want to bring up a few more quick points before we call it a day, unless there's something else you wanted to talk about. People always are asking me, when are you going to update some of your books and other things? Believe me, I'm working on it. This full-time educational gig, I'm just trying to get my feet wet. I'm really enjoying it, and we're loving working with the doctors that I'm working with. So here's what I just wanted to bring up in terms of prediction space. And I brought this up with Brady, and we really didn't go too far, but I want you to comment on this before we end. And then I'll bring up one other thing as a good way to end if you want to, unless you have another question. So people might know my wife's a social worker, and we've talked about this, and I call it preventing compassion fatigue. I want to talk about partners for a second. I want to talk about the partners out there who are constantly, the caregivers who are constantly giving care. And this is also some of the patients out there. But what I always try to remind them is a philosophy that is very ingrained in social work, because this is what happens to social work a lot. You're giving, and suddenly you develop what's called compassion fatigue. You morally and ethically think that all you're supposed to be doing is giving. You're never supposed to provide self-care. You're never supposed to provide your own positive outlets. So part of the reason I showed that Qigong exercise at the beginning of the conference is that Qigong, Tai Chi, whatever you find, gardening, these are some of the positive outlets and self-care that they teach social workers about when they're experiencing compassion fatigue. So the idea, and I worry about you too. So I talk about you in terms of protecting your well-being. I went running this morning in the toughest route in Ann Arbor, wind blowing in my face. And I really wasn't tired because I was just so excited that we were getting to the end of the conference. We were going to educate a whole new group of people globally. And then but that's my sort of outlet. I need that therapy. If I don't go out there and run for 5 miles, you don't want to do this Zoom thing with me because I am an ogre. I'm horrible to be with. And so what I have learned through my wife and through the social workers, and I think you do a good job of it, but I worry about with you too. And I talk to the support group members. There has to be the topic in 2022 of compassion fatigue, that basically prostate cancer is a couple's disease. And if you're not looking out for each other, you're no good to each other. So just as much as the patient has to be looked out for, the person taking care of the patient in the couple, the partner, they have to take care of themselves. And so you have to be sensitive to that, both of you. So I wanted to get this in because I always try to put in a little tidbit at the end of the conference that I think we should talk about this at the September conference. Apart from Moyad doing Qigong in Florida and going running, how do you take care of yourself, whether you're a healthcare professional or you're a caregiver? And I am telling you that I have been writing about this for 30 years since studies came out at Memorial Sloan Kettering about it, that prostate cancer is a couple situation. It has to be recognized that way, and you have to both take care of yourself and figure out what that means as a couple. I promise you now, I will get off my soapbox.
That is so necessary. Now, we made two commitments. One is we're going to either ask Dr. Brady or someone else to talk to us about penile implants.
Yes.
And the other commitment is for us to follow through on that. And I think that is essential. This is a long-term struggle for many people. Thankfully, it's long-term. People live a long time, even with metastatic prostate cancer, but it is very draining.
It is.
And so thank you for sharing that. And
but I'm saying this to you as a friend too, because people ask me all the time, well, why don't you write more? Why don't you do more Instagram? Why don't you do Twitter? Well, first of all, I don't do Instagram. I don't do Twitter. I really only do some of the videos that PCRI wants me to do, because anything beyond it is I begin to feel that level of fatigue. I do. I feel overwhelmed. I feel like I'm not good to anybody anymore. I'm losing my compassion. So I need to stay a little bit introverted in order to build up that battery again. And my wife can recognize it too. And the reason why this is such an incredible theme is that what people don't realize what I do is I also do a lot of peer review for journals. So I'm asked to referee and read articles. And what I told people about last year was there was a study about exercise done in Canada in active surveillance patients and how it might provide an anti-cancer effect. And it's called the ERASE trial, ERASE. It was only a 12-week study, but the researchers were brilliant in Edmonton. They did an incredible job. And what I said was, when the article came out last year and was one of the most trending articles in oncology last year, is I said the shame of that study is they have a secondary study that's not just going to look at the physical attributes of exercise, but is going to look in the active surveillance patients, the mental health aspects of exercise. Well, that just came out in the Journal of Urology, April 2022. So it's really just out, but it's not out there. Let me just read you from that same study that everybody lost their minds about last year, about what's not receiving attention, all right? A 12-week supervised exercise program, this was their findings, may improve prostate cancer-specific anxiety, fear of cancer progression, hormone symptoms, stress, fatigue, and self-esteem in men with prostate cancer on active surveillance. Are you kidding me? That's the story. The story is, I don't know if exercise fights your cancer or not. That's not the point. The point is it keeps you in the game. Even if your PSA is going down, if mentally you're not there, you're not feeling fulfilled, it doesn't matter. Then you don't see the results. And so here you've got one of the most famous studies of last year. Then there's a follow-up that just came out. I haven't seen it in a single media outlet. And it shows you that, okay, well, maybe exercise helps your physical symptoms. And that's true, or helps your PSA, may fight your cancer. And now we're finding in these men within 12 weeks, it calms them down. It reduces their stress, their anxiety. They see life different. This is why I do what I do. And it goes back to the compassion fatigue. Let's quit looking at exercise as only a physical benefit. It's a spiritual, mental health benefit, and that's why we want you on board. In fact, I always argue that world leaders should never be allowed to meet unless they exercise right before they meet. The world would be a lot better place. We'd have a lot better leadership out there. I'm not saying United States, I'm saying we'd have a lot more peace in the world if people were forced to exercise before they went to the table to have a discussion. We'd be more compassionate. We'd be more kind. We'd be more human. And part of the problem is we're losing our exercise time. We're losing our outlets. And when you lose those outlets, you lose yourself personally, and you lose that connection to humankind. You know, people always ask me, how do you find these speakers? And you notice something about almost all of our speakers, not just you, Dr. Scholz. Look at Jeff Brady. You think I go hang out at the bar with these guys? I never do. The reality is they all have something in common. They are very committed to these self-preservations, or they take care of themselves. They all have outlets, right? Brady plays baseball. He's a runner. He's a triathlete. Cooperberg is still doing these runs. Look at you and all the tennis you play. But it's not like I'm looking out and going, oh, well, Mark Scholz plays tennis, so that's why we're going to have him on this conversation. I just find it interesting that most of the people that have come to PCRI that we look at and go, wow, they're amazing people. These are the people that have these kind of outlets, which I think makes them better doctors. It makes them better researchers. It makes them better husbands. It makes them better wives. It makes them better people. And so that is what I wanted to finish my speech on today in my soapbox, because after 12 hours, I wanted to make sure people still understand that it comes back to you. Yep. Not you, but
absolutely.
Us.
No, to the patients. And this is the one question that all my patients get asked when they come through the door. And I often can tell the answer before I ask it is, what's your exercise program look like? Especially for our patients on Lupron. If they are unwilling to exercise, we know they're going to suffer greatly. And if they're willing to devote themselves to exercise, they're going to get through it pretty nicely. It's not like it helps a little bit. It totally changes their life. And they're actually, I have patients that do so well when they're exercising on things like Lupron that have had low PSAs for a long time. And they say, I'm okay with staying on this, Dr. Scholz, my quality of life. I'm not talking about all patients, but because they've compensated for the negative aspects of the muscle loss and whatnot through their exercise programs, then they can live with it. They can live happily with it. So thank you for emphasizing that. I think that's the, I'll talk to patients about, if you're struggling, get a trainer, join a class, whatever is motivational to be able to sustain this, because our goal is to not only make you live longer, which exercise unequivocally will make you live longer, but also live better and enjoy those years as well.
Last year when I was doing stuff from up North Michigan, people kept asking me, why did you buy a lawnmower for $200? Why are you cutting your own lawn? Look, it wasn't to save the extra $20. I mean, I'm not like that. Okay, I'll spend my, I'll buy donuts too. I'll do that. I just thought I wanted to get back to a simple time where I was doing chores and my mind would stop spinning all the time. So I go out there once a week and I use this push mower and I'm completely drenched. It takes me an hour and people still around the neighborhood go, what are you doing? And I'm going, this is my drug. This is unbelievable. And I walk out of after cutting the lawn going, I'm so happy right now. Everyone's going to love being around me for the next few hours. And that's why I picked up this silly old lawnmower for $200 that was used. And I love it. So I know I'm preaching to the choir. I'm just trying to let you know what I'm seeing constantly. And this stuff is no longer whispering. It's shouting. It's shouting that you've got to be in the game. You've got to do this. And we agree. Look, I don't like tennis that much. I'm picking up pickleball lately, but it's your outlet. As long as I've known you, you just love hitting tennis balls. Good for you. I love running. People still say it's going to destroy your knees. Well, it's now 40 some years of this. I'm doing okay. And it's my outlet. My wife loves to garden. It's her outlet. Find your outlet, man. Find it. Men and women.
Well, you talk about outlets because you have a purpose, Dr. Moyad. And that I think is, of course, the first step is you're on a mission, you're going somewhere. Some people, it's trying to get the best prostate cancer care. And then once you have that mission and that purpose and that direction and that meaning, then it's possible to be consumed by it and get into it too deeply. And you're talking about being able to balance it. And balancing it with some form of exercise is brilliant. So the other reason I think I'm smiling is because I think the last time you and I had a chance to enjoy each other this way was in our last conference on video. So that's just terrible.
I know, it's terrible. I agree.
As everyone knows, you're just a fun guy to be around. Thank you for sharing of yourself throughout this very extended conference. And you were called upon to be much more involved in this conference. We're starting to make a shift away from the interminable slides and the technicalities and the graphs to try and get to the nitty gritty of what patients need. And that's, I think we're actually positioning you in your area of strength.
I agree.
And of course, by inviting such amazing speakers, it's just been fun for all of us. And honestly, even though this has probably been more demanding for you, you don't look quite like the usual limp dish rag that I see you at this time. I always get to see you on the last day. And sometimes I do feel like I'm dragging you over the finish line, but I think this has been energizing for you. You've obviously amazingly prepared to extract the value out of each of these interactions. And
I appreciate
and I think that's part of my smile, Dr. Moyad, is the just the pleasure of spending some time with you. And you know, it's really comforting, you know, if you're sharing the podium with someone. I know you've done that with a lot of people, and you're really good at making the people around you look good. But I know you can imagine from our side, we have the same issue. How's the dynamics and all this sort of thing? I don't even have to think about that when I'm talking. You know, I just know that you'll be there. And I think all of us speakers know that we have such confidence in your ability to guide us and lead us into the right direction.
No,
So since we are starting to wrap this up, just I know a lot of people feel very grateful, and I want to share that thanks on behalf of all of our watchers and listeners.
I appreciate that. And I feel blessed. And, you know, I feel blessed to be in your presence in the PCRI, and how it's really turned into a youth movement, this group running the PCRI. And they've been able to take this message to so many people. Otherwise, I made the joke the other day, otherwise we'd be in some closet in the back of the room someplace figuring out how do we get 1,001 people to our conference, right? And it was the conferences are exhausting. It really lifts your soul when we're in person, but at the same time, there's so much energy going on in that conference. And it's true. What Dr. Scholz is saying is that when the conference is over, I'm always surprised he hasn't called a stretcher. I mean, I look terrible. I feel terrible. I complain. And I realize there's just no juice left, right? There's nothing in the battery pack. But this has been great because we found our voice, and I'm really glad we got to finish the conference this way, and we doubled it. We did it, right? We got here and we actually doubled it. I can't believe it. So yeah. So what you said is true. We have to communicate more, because as you become more busy and I become more old and tired and fatigued, we have not communicated on those random days in the weekend where we're just saying hi, as opposed to just talking. You know, now we're just seeing each other like these 2 times.
It's crazy. Let's ask our PCRI organizers, have we set dates for the September conference yet? So maybe we should share those now.
Yeah.
Do we know them off the top of our head?
The first
September 10th and 11th. All right. And we're planning an in-person conference. Is it confirmed that it'll be at the Marriott? Marriott Hotel, Los Angeles Airport, Marriott Hotel, where traditionally the PCRI conferences have been held, September 10th, Saturday the 10th, and Sunday the 11th. Is that the way it works?
Yeah.
So Dr. Moyad will be moderating, and he will be no doubt scouring the country and the world for special, unusual, and brilliant people to share with us the right way to live our lives. Yeah. And just
hopefully we will be together. Hopefully we will be together. I think we will, even if there's just a limited audience. But I think it's looking good right now that we're supposed to be together on those days.
Very good. Well, thanks again, Dr. Moyad.
Thank you. Thanks to PCRI. Thanks, Dr. Scholz. I appreciate it. Happy birthday. Take some time off. Right?
All right.
Find your outlet besides tennis. I'll talk to you soon.
All right.
Thank you so much, everyone. I just want to take a moment to thank everybody who attended this conference. Thank you for joining us and showing us your support for what we do. If you like this content, please give us a thumbs up on this video and leave a comment. We love to hear your thoughts. Your words are literally what we live on. Our job is to create content for prostate cancer patients around the world, and when we hear your voice, it helps us know that we're going in the right direction. So please leave your comments, let us know what you have more questions about, and we will go ahead and get back to that. And also, I just want to take a moment to thank all of our incredible speakers, Dr. Mark Moyad, our favorite moderator who carries us through all of these conferences, Dr. Mark Scholz, who created the PCRI, and none of this would be possible without him, Dr. Cooperberg for giving us such an amazing perspective on active surveillance, Dr. Brady for taking the time to contextualize ED and incontinence and give us some answers, Dr. Kwan, who always comes with such amazing energy. He does such a great job talking about prostate cancer imaging and helping us know how to empower ourselves as patients, Dr. Kishan, Kishan, who did a great job just covering SBRT. He did such a way of simplifying things. It was great. And then Dr. Vogelzang, he's been here before. He does such an amazing job covering advanced cancer, and he definitely gave us some of the answers we needed. Thank you guys so much for presenting and giving us incredible information. I also want to thank our sponsors. Without them, it wouldn't be free. So thank you so much to Bayer, Pfizer, Astellas, Janssen, AbbVie, Advanced Accelerator Applications, Dendreon, and Tolmar. Thank you so much for making this possible. Also, as a reminder, please subscribe to our YouTube channel. We come out with new prostate cancer videos every single week. We have more events just like this. In fact, this summer, I'm so excited to announce this, we have our first Men's Health Fair. I'm so excited. It's going to be a virtual one-day Men's Health Fair. It'll have exhibit halls and all sorts of information, and Dr. Moyad will be back with us for that. Also, if you would like your questions answered, maybe there's some things in the conference that you would like, just to get some answers on, you can go ahead and call our helpline. You can visit pcri.org/helpline, and you can get all the information there. All right, thank you so much for joining us. This is Alex of the PCRI signing off. I love you guys so much. It's such an honor to serve you. This conference means the world to us because we get to hopefully help you guys. And again, we would just love to hear what you guys thought of the conference. Leave your comments below. Thanks so much. Bye. The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting, have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking, develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing, have signs of infection such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.